More like a fun.
One thing. I'm halfway there. He's like, I was in the yeah. Yeah, I wanted to do that, but I couldn't. Yeah. Okay, I'll run. I thought that's what you're doing. Wow. But it was nice. It was like a more of a hospital we can recommend. What? I was like different between. They like very great, and the person was like, oh, I'm doing it on. Oh, yeah. Yeah. But like, and also.
Yeah, there was. That's how I written the. Maybe one and one. Have like. And then they're like. And then like. They're worse than the out. They asked for it.
You're like, oh no, how. Our possession. Away, I don't know, yeah, maybe,
How much?
yeah, it should be metal, yeah. It should have like
They're plastic.
some. That will shape, but it doesn't cost.
You have to walk out the.
You see what all. First time. Feeling. Like, I think she. I had to go back. It's mine. Oh, I have to wear mine. But. I'm sitting. Injection. Yeah, and it was in like once this first time here, it was like a charge. They're basic, so they had something where it was like. The past. Its head. So it would like. And then. And. It was like a child.
Like. They, and. To the, context of the head. But then it's like. Not even explain that. No, okay, so. If you get the end, you go, there's side. That's the downside, what the upside. Told us, maybe, but I would say that you made it in.
So they need to find another report, like for.
That's the reason why they.
They're all.
Always side effect.
For side effects of being work. Right.
Side effects from the bed. Yeah. There's complicated one thing I call it, but I will do that. You get it.
Yeah, I got that in. Maybe change. One of my best friends, fiance, was love.
Oh.
Very hard.
Well, then.
Walk away. And I would use their pregnancy.
Yeah, there's like a plant, sometimes what they use to make the plant, they use the plant.
Like garden.
Because, they'll kind of, but there are cases that's like.
Oh, and then. Finish fast. Whoa.
That 1%.
Yeah. You know what?
But it's,
That's where.
No. Yeah, we're still on there now.
Okay, good, 'cause I don't remember. Just like, about to finish your- So I think we're gonna talk about this, then I'm gonna need to go. What's it on? Like 5 years.
It's extending out.
Yeah. Yeah.
Oh, yeah, some people are like, yeah. they're really good. Some people are like, they're more.
One of my good friends, you know, they have like a user. I don't know, the beach girl west. I wanted to beach for grass. Right.
That's what.
Right. Just fall that. Yeah, that I give. Oh, she's. Oh, it took a long time. Yeah, I started it at that point, but you have a passage. That's our standard to be able to, that's our standard, sorry, but and that's. You have like. A lot. Like anyone, it's a lot, they'll really have that problem, like they'll love them. Yeah, lots, on the gas. Oh my God. But I imagine. You know, one day, like, more than they have a nice thing.
What is it? Like, at least just like. I have somebody in the house where they just like have fun.
Like Twilight.
My father. You know, like this. One after another, all of them, just like, I'm getting like stressful. And for like for this to happen now, it's like, what if we translate on that?
Say, like. One.
Just like,
Yeah, the kids, like, put it that way.
yeah, exactly. At least now, like,
I don't have.
know, it's like,
There's people still get off, like, I'm crazy.
definitely.
But say stuff or like. They work hard, yeah. They have a feeling, I don't know, that's a whole lot of stuff that you never.
Yeah. I mean, same time though, it's like, what she was thinking. And she probably needs to like evaluate the priorities, which she's taking care of herself first. That's like the main priority for still, she needs to take care of that more, you know, giving all that person that I. Helping.
It's like really. Yeah. Yeah, that is like, okay, I have like, this is like, that's a little. Like, you could have like. Like, life. I've never had that in my the videos of like, the roles that probably were like, they have like a finance. And that's. Like, they're kind of like so off. They'll ask like how it is. Tired today. What's your guys?
Oh, yeah.
Yeah. Doing that, somebody like opened the door, brother, oh, it doesn't really make it better. Yeah. They got me.
Laws that are not. Laws that are not like. Effectively, they can all do that.
Yeah.
Like, that's the biggest priority. So, like,
What is that?
I have to. Sexy. I'm gonna get called here. So I mean, that's up to you. Like, help me. My eyelash and then like, no, when I actually got done. I will pull up. I have no idea why. At that point too, it's like.
Yeah.
Sympathetic, yeah. It's just like, let it keep them first. You'll be anxious because we're not. Once.
You start growing. Yeah.
I became talk about it.
Yeah, they don't wanna like increase it. Like, really not.
Is it ever gonna be, yeah.
If I don't. Keep it, then I'm like, all of the-
I've never.
All right, let's go. Let's go vascular. Go right into vascular, folks. Let me find where I left off. We had just finished the MI stuff. I think we're on physiology part. Yeah, let's see. Slide 75? Yeah, yeah, that's right, that's right. Okay, there we go. All right, folks, let's go. Progression of atherosclerosis. Remember, I had talked this out, but I just want to go over it one more time with you guys. Okay, they like asking this question. Endothelial damage is always the first thing that happens. Then lipid deposition from that fatty burger that we eat. Then macrophage and ingested lipids, and then tunnels underneath the endothelium. That's how you form an atheroma. The atheroma then causes turbulence, like I showed you. Oh, wait a minute. I need to expand this. I don't know why I'm doing it. Sorry. Yeah. All right, platelets and increased atheroma and fibroblasts will cause scarring over time. That's why now you call it atherosclerosis. And symptoms will begin, remember, when you hit 70% occlusion. All right, in the carotid, we call it amaurosis fugax. The person describes a curtain going over the visual field. In the coronaries, we call that stable angina. And that's when you see ST depression. In the GI, we call that abdominal angina. That's the SMA, that gets occluded. They get pain when they eat and they're okay between meals. Lariche syndrome is the one I told you I'd like to ask about because it causes butt claudication and impotence. And what they're gonna die from? Heart failure. No matter how bad it is out in the periphery, it's worse in the coronaries. And then the legs, popliteal claudication. Metalloproteinases try to remodel the plaque and then they eventually get ruptured. And then 90% occlusion will occur suddenly. All right, ST segment elevation, therefore, is late ischemia versus ST depression, which is early ischemia. All right, so ST segment elevation, late ischemia, total or near total occlusion, more than 90% occlusion if they want a number, unstable angina if they want clinical, transmural if they want to know what layers are involved, and then we call it a STEMI once the enzymes rise. That means an MI is in progress. ST depression, Ida. Early or late ischemia. Early, total or partial occlusion. Partial, 70% or 90%. 70%, transmural or subendocardial. Subendocardial, stable or unstable angina. Stable angina, and then only when the enzymes rise, then we say, oh, you have a non-STEMI. How do you treat a non-STEMI? Ida. Give them oxygen first, I agree. And then medication. You got a partially occluded vessel. How do you open it up? Vasodilator called nitrates. Everybody understand? This is how you talk yourself into the answers. Don't try to memorize it. Talk it out. That way the answers make sense to you. Okay? And now ST segment elevation is everything opposite. Now it's late ischemia rather than early. Now it's total occlusion rather than partial. More than 90% rather than 70, unstable rather than stable, transmural rather than subendocardial, and then STEMI once the enzymes rise. Now here's a nice drawing that shows you what ST elevation looks like. Any questions so far? All right, here's a lot of stuff that shows up on your exam, folks. Medications for acute MI. For this round, I'm going to tell you what each one does. The only way you can remember a long list like this is to know what each one does. So make sure you're listening. Oxygen, who's that benefit for? For the brain. It's not about the heart. Brain always comes first. I told you, physicians keep forgetting that. Brain comes first. Then aspirin. Why aspirin? Because I just told you, platelets are closing off the vessel right now. So you need to block the platelets so that they can't finish clumping. You block COX-1 and 2 irreversibly because we don't want to be competing. This is a serious life or death issue. Then we give them nitrates. What do nitrates do? Stimulate nitric oxide, which is made from arginine. Nitric oxide then dilates your veins and your arteries. So what you're doing is pooling blood down to their feet. So preload decreases, their heart feels better immediately because there's less to pump. Anybody understand that? Anybody not understand that? You understand that, Ryan?
Yes, sir.
All right. So that's nitrates. Morphine. Morphine decreases their perception of pain. It's an opiate. Because as long as somebody's feeling pain, they're putting out epinephrine and norepinephrine for stress, which is beating up on a heart that's already in the middle of an infarct. So if you decrease that perception of pain, less stress response. That way the heart doesn't keep racing. But morphine has never been shown to decrease mortality though. Clopidogrel or ticagrelor, take your pick, one or the other. Remember, they want 2 antiplatelet drugs now, aspirin and one of these 2 drugs, not just aspirin by itself anymore. Why does that work? Because you have a better chance of decreasing platelet activation, which is good. Remember, these 2 guys block glycoprotein 2B3A, all right, so that you cannot bring in more platelets. All right, so they found that it does decrease clotting. However, it increases bleeding complication. But when life or death is the issue, you don't worry about it. All right. Watch out the first 2 weeks of clopidogrel. Remember, TTP can occur in the first 2 weeks of use. Then we use beta blockers only when the blood pressure allows. The Timmy Tammy trials where they tested this, you got 3 months to start a beta blocker. You know, when they first come in, their blood pressure may not allow it because they're in shock. You cannot start a beta blocker when somebody's in cardiogenic shock. Okay, but beta blockers have been shown to decrease mortality. Why? Because it decreases the sympathetic tone of your heart. That means your heart can't race as fast anymore. That means less chance of an arrhythmia. It's a beta blocker. And you want a specific beta 1 beta blocker. Hannah, how do you know a specific beta 1 beta blocker? No, how do you know a specific beta 1 beta blocker when you look at it? There's something in that name I told you to look for. Yeah, the first letter, make sure you say first letter. First letter is A through M, but not L and C, then those are the ones you want to use. All right, ACE inhibitors decrease mortality. Why? I told you 17% of them go into heart failure during acute MI. All right, ACE inhibitors are treating those people that go into heart failure. Second, ACE inhibitors decrease production of aldosterone, which means the heart can't take up so much of it, which then leads to more inflammation and scarring. All right, so the books always say decrease remodeling. That's what they're talking about. All right, so ACE inhibitors do decrease mortality. So the ones that decrease mortality, I'm highlighting them for you because on the test, they're always going to ask you. All right, ACE inhibitors. High intensity statins. Why? Because they decrease inflammation. Remember I told you, it's not about cholesterol in the setting of acute MI. It's decreased inflammation. That means the heart doesn't scar quite as badly and it doesn't stop beating because it's all scarred up. All right, so rosuvastatin and let me see, Lipitor, atorvastatin are the 2 big ones. Heparin stops a clot from extending any further. It's not really a clot buster, but they put in a clot buster chapter. That's really a mistake because it doesn't break down any clots. It just stops the clot from extending any further. So it blocks clot extension. How does heparin work? It's a cofactor antithrombin 3, which means you block thrombin as well as factors 9, 10, 11, and 12. That's the whole intrinsic pathway. TPA works the same way as streptokinase, urokinase, alteplase. They all do the same thing. Convert plasminogen to plasmin. And plasmin is your #1 clot buster. That means for those who qualify for TPA, then you put them on TPA. I'm about to go through who actually qualifies. Then stop metformin right away. Why? Because we're going to cath lab for contrast. You remember our discussion on metformin? You cannot mix with contrast. You'll ruin their kidney. So you hold any more doses. If they've taken one today, hold any more doses. Give them an NS until 16 with a lot of normal saline because we're going to cath lab. If they have not taken a dose, then don't give them a dose. And let's go to cath lab. All right, and then stop calcium channel blockers. Why? We don't want to take away any contractility from this heart right now. You understand, Karis? You understand, Mitchell? All right, any questions on any of these drugs? By knowing the action of each drug, folks, that's how I can remember the list. If you just try to memorize this as a list, next day, I bet you can't give me the whole list. You won't. Each one makes sense. And that's the way I remember it. Because each one, I'm trying to accomplish something. All right? Nolan. To maintain whatever contractility the heart has. You don't want to be blocking contractility. Why wouldn't the beta blockers do the same thing? They do, but calcium channel blocker is more direct. Yeah, so that means it's more effective. So that's why we say stop that one. But the beta blockers decrease sympathetic activity, so that's why we like that one, because it still has another benefit besides blocking contractility. All right, Anam? Yeah, I mean, any of the those you would block, but verapamil, the thiazide, definitely, you got to stop right away. But even the vasoselective ones, they say stop. Yes, Mitchell.
Which one specifically decrease mortality?
Decrease mortality, aspirin, nitrates, clopidogrel and ticagrelor, one or the other, beta blockers, ACE inhibitors, and high intensity statins. The other ones have never been shown to decrease mortality. We use them because they treat symptoms. All right, 3 decisions to be made. You're the ER physician who sees this patient. You got 3 forks in a road, and you got to decide which road you're going to go down. So listen carefully, because I've seen all 3 forks in practice questions on UWorld already, folks. They expect you to be up to date on how to manage an MI, because that's the #1 concern of every doctor. You don't want to mismanage an MI. That's usually major lawsuits. All right, first one. If you're in a PCI capable hospital, proceed to PCI right away. Remember, in the clotting lecture, I said, if you get this clot moving in 90 minutes, no fiber has been laid down, so it's not anchored. It'll just scrape right out like Jello. Everybody understand? That's why the study showed if done within 90 minutes, the best prognosis. The big, huge drop in death rate and MI rate. Okay? So again, it's tied to physiology. The fibrin is laid down in 2 hours. So that's why you do it within 90 minutes. All right. Number 2, if you're close enough to PCI capable hospital and the procedure can be done before 2 hours. That means the other hospital like 20 minutes away, you can call them, say, I got a guy I'm going to transfer to you. That means they get the table already. That means as soon as he gets there, boom, on the table. Well, that's less than 2 hours. Then go transfer immediately. We'd rather them be at that high capability hospital, folks, not at some tiny hospital. Okay? All right. Any questions on that? Because again, you got to look carefully at which one they're giving you on the vignette to know which road they want to travel down. Okay? Like I said, I've seen all 3 already on practice questions. All right. 3. Oh, wait a minute. I missed. Oh, sorry. There's a 3rd one. You're too far away from a PCI capable hospital. That means they cannot get them on the table by the 2-hour mark. What do? That's the people who get the TPA now. Before, everybody got TPA. Now, no. Only a 1/3 of them will get TPA now. And that's only the ones where you cannot get them to a hospital that can get them on the table and do PCI within 2 hours. Then go ahead. Give them the TPA and then transfer the patient right away. Why? Look at this, 30% of patients will have another MI in the next 24 hours. And we'd rather they be at that capable hospital when that one happens. Any questions on how to manage acute MI? This is the current management of acute MI in America. It's all of your tests. Everybody, every test has this stuff. Okay, question, Anders. What acronym? PCI? Percutaneous coronary intervention. That means angioplasty. All right. Who gets to go to surgery? Now we're going to cath lab. Now we have to decide who gets to go to surgery. Here's the 3 main reasons. Number 1, 70% occlusion of left main. I heard they're bringing this down to 50%. So if you see 50% on your chest, pick it. Because the left main does 85% of your myocardium. So it makes sense. We got to be, what's the word? More sensitive to managing it because he supplies so much myocardium. Everybody else is 70%, but that guy is your life or death artery right there. So they're coming down to 50%. Okay? 70% occlusion of 2 or more vessels in a diabetic. Because we know they have more aggressive atherosclerosis, they're going to knock out another one. You don't wait for the 3rd one. And then 70% occlusion, 3 or more vessels in a non-diabetic. Years ago, it used to be 90% for all 3 of these. But then somebody realized, why wait till I have an event do it at 70% when symptoms begin. Made perfect sense to me. That's why I went down to 70%. Okay, we don't wait for the event to occur now. Okay, save more lives that way. Any questions so far? Anna? Right. No, PCI, if done within 90 minutes, is the best results. But if you give it to another hospital and it can be done with by 2 hours, still do that. Right, because remember, by 2 hours and from 5 minutes laid down and it anchors into endothelium. That's why if you can do it before that, then you can at least scrape most of it out. If you do it within 9 minutes, you can scrape almost all of it out. That's why that's the best result. But even in that extra half hour, you can still scrape a lot of it out. That's why they say you still got up to 2 hours before fibrin is tightly laid down. Now you can't scrape too hard because you rip the vessel. And you don't want to do that because then another clot will form. Cares? Yeah, bypass. Right. All right. So who gets to go to surgery? This is for bypass surgeon. What to do with everyone else? That means single vessel disease in anybody or double vessel disease outside of diabetes. What do we do with them? Here's what we do. PCI, that means angioplasty. Scrape out as much of the clot as you can. You understand, Michael? Because you're trying to help the person at that point in time. At least scrape out as much of the clot as you can. We know you can't scrape all of it out, but we scrape some of it out. And then you put a stent to push the plaque up against the wall. Because we know you can't scrape all of it out. Well, just push it up against the wall. That way blood freely moves through the middle. All right. And you got 2 stents that I've talked about before. So this is the second time you're hearing it. If you want to use a bare metal stent, remember aspirin and clopidogrel for 30 days and stop clopidogrel. Aspirin is always for life. But if you use a drug-eluting stent, aspirin and clopidogrel for 1 year and then stop clopidogrel, aspirin is always for life. So second time you heard about how to manage stents. Any questions on that? All right. So this way, when they take the person to cath lab, they'll tell you the results. You should already know, okay, what am I going to do with this guy? All right. When someone's in the cath lab, folks, the operating room is ready. That's why they want the person at a level 1 hospital, because a small hospital can't handle to pay all those people to be ready. And then, oh, we don't need you, but you got to pay them. You got to pay for that. And all the instruments got to be back to the processing again, which is very expensive. That's why they say send them to a level 1 hospital. Those are the only ones who can afford it. All right, what if you go to surgery? Where do we get vessels from? They'll ask you this too, folks. Internal mammary artery, there's only one, but it lasts for 10 to 12 years. Most doctors will start with that because that means I don't have to revise it for at least that long. Now that's the average, but some people have up to 20 years before I have to revise it. So if it's just 1 or 2, remember the internal mammary is not forever long. And we may get 2 or 3 pieces out of it. So you can only use it once. All right, but it lasts 10 to 12 years. Saphenous vein has a bunch of tributaries and down both legs. You got tons of veins you can harvest. But it only lasts 5 years on the average. That means you have to redo it. Okay? And don't forget to turn veins upside down because remember the valve are facing the opposite direction. Any questions so far? Management of acute MI. I told you we're going to go through the whole thing. Every fork in the road, they're going to ask. All right, Bryce, you have a question?
Yes. Is there any criteria for how to choose between a bare metal stent and a drug-eluting stent?
Good question. How to choose bare metal versus drug-eluting is up to the doctor. All right, but the bare metal stent has a high stenosis rate. I'm sorry, restenosis rate. Yeah. So as long as you don't mind dealing with restenosis, fine, use that route. Drug-eluting stent just has a longer period of time before the rebound effect is lost. So you have to use it for at least a year every time you decide to use that one. All right? Yeah. When you go either route, you're on. All right. Middle-aged male with chest pain. Remember I told you before, myocardial infarction number 1, aortic dissection number 2, angina number 3. Aortic dissection is ruled out right away with a chest x-ray that doesn't show a wide mediastinum. MI is the next thing we're going to rule out. Okay? So how do we rule out an MI? It's called a 24-hour hospitalization. Somebody did a big study back in, I think, 90s. You know, hundreds of thousands of cases. And so, well, how long do you actually have to keep them in the hospital? Because before, every doctor was keeping the hospital forever, trying to run every test possible so that they would not be sued for the acute MI, missing an acute MI. And he found that within 24 hours, something should become positive or else send him home. So 24-hour hospitalization is all we do now. That means check EKG every 6 hours. Check cardiac isoenzymes every 6 hours. Monitor for arrhythmia, so they have to be on a monitor. That way, anytime they go into arrhythmia, we shock them. Okay, that means the crash cart is nearby. Discharge after 24 hours if everything is normal. How do you know when to discharge them from the ER? If they have at least 2 to 3 troponins, that means at least 6 hours apart. So if you want to do it 2 hours, 3 hours, if you do it at 3 hours, then it's 2 of them. If you do it every 2 hours, then it's 3 of them. So the rule is troponins at least 6 hours apart are still negative, you can send them home. Considering that their chest pain is gone. Okay, this is a chest pain that came in and you're not quite sure, it doesn't look, the EKG says, no, it's not an MI. You say, okay, well, let's do some troponins. If you get them 6 hours apart and they're negative, they say send them home. It's not an MI. This way you don't start hospitalizing everybody with chest pain in the hospital. Okay, any questions on that? All right, then you reevaluate in 6 weeks. What for? For angina. That's the only one we haven't ruled out now. Rule out the dissection right away. We just rule out the MI after 24 hours. Come back in 6 weeks for angina. Any questions so far? Inflammation due to an MI. Remember this? Hopefully everybody still remembers this. I just put it in here again, just remind you. The stages of inflammation, folks, don't forget it because it covers every disease they're going to ask you about. Swelling is always the first sign. First cells that show up in neutrophils, show up at 4.5 hours, predominantly by 24, peak at day 3. You've heard it 1,000 times already. T cells and macrophages show up at day 4, peak at day 7. Fibroblasts show up at day 7, peak at 1 month, and complete scarring in 6 months. MI is no different. It's inflammation. Why do we do it in 6 weeks? Because in 6 weeks, fibrosis is more than peaked. They arbitrarily picked this. There was no science to it. It just said, fibrosis peaks at 1 month. All right, let's bring it back in 6 weeks. Makes sense to me. Why? The whole fear was, if I put you on a treadmill and you got a part of your heart that's not scarred down, it's going to blow. Because your heart may start pumping hard and then boom, the wall just blows and you'll die. That's never actually happened, but that's the fear. So anyway, what do we do? 99% of the time we do exercise stress tests. So in every question I've seen, that's the answer. That means don't worry about all the other stuff, but I put it in here just to educate you on what it actually is. Stress test, exercise them, put them on a treadmill and the ankle keeps going up higher and higher. And you just keep walking. So I get your heart rate to the desired rate. And if you still have not complained, okay, then you're fine. What's a positive stress test? Chest pain came back. Second, ST segment went up or down, or there was drop in blood pressure, meaning your heart can't keep up with you. That means he's not getting enough oxygen. Because on the test, they'll give you one of these results. You got to know that's a positive treadmill test. Straight to the cath lab. So when you're having a stress test being done, cath lab is on standby. And when you're in the cath lab, operator is on standby. All right, so that's where there's no downtime. Okay, no downtime at all. I've had 2 stress tests because of my hypertension and diabetes. And thank God both of them were just fine. But I had a buddy of mine who had one, and he's a plumber, and I hadn't seen him in weeks. I was like, man, where did he go? We used to talk all the time. Then all of a sudden he finally surfaces. He said, man, I went for my stress test and mine came out positive. And they took me straight to cath lab. He had 4 vessels that were clogged up. And they took him straight to the operating room and did surgery. That's why he's alive today. That's what a stress test does. It catches the MI way before it happens. The rule is if your stress test is positive, I mean, you got more than 10% chance of having that heart attack in the next 12 months. You guys ask you what's this interpretation. That's why we said, check your cath lab. Remember, 1 to 3% is okay, 10% is not. All right, 10% is too high. So no, bypass. Okay, anyway, that's stress test. Next one, stress thallium. This is a radioactivity test read. This is, I just inject your radioactivity and see if it goes all the way around the heart. If it does, then all the vessels are wide open. But if I see an area, which we call a cold spot, that's an area with no radiation. That means no radioactive activity rather. that means no blood flow went there. There's your ischemic area. So this is just an indirect way of finding the ischemic area, the cold spot. It's usually just an anatomy question. Say you find a cold spot in the anterior wall of the heart. And what's your interpretation? Well, it means the LAD is clogged up. And that's all they want to know is if you know how to read this. All right, next one. The obedient diaphragmal stress test is for the person who cannot get on a treadmill. Give me one instance where somebody cannot get on a treadmill, Mitchell. They don't have legs. Amputees. You can't say, well, you got them chopped off 10 years ago. All right. So my point is, I'm not going to give you a list. You can figure it out for yourself. So amputees, somebody got bad arthritis, obese, pregnant, you know, they got shot in the leg. That kind of, you can't put them on a treadmill. Anytime you cannot put them on a treadmill, sit them down. Use medication. Your butamine is pure beta 1. I'm just going to raise your heart to the desired level. That's it. Diaphragm, I'm going to vasodilate your coronary, see if blood goes everywhere. Yeah, there's several of them. What's the other one we use? The butamine, there's one other one. I don't know we use. Diaphragm, there's one more. I can't remember. Anyway, but that's what we're trying to do. Do it pharmacologically, okay? Because you can't do it in a treadmill. All right, calcium power phosphate scan is done when you think maybe somebody did have an MI 6 weeks ago. Well, let's light it up. As you remember, dying cells take up calcium. What if I put radioactivity on it? And it'll light up the dead area for you. So opposite of the stress out, which is cold spot, we see a hot spot. Say, okay, now we know which area actually infarcted 6 weeks ago. 2D echo. Evaluates anything that's anatomical. Wall motion, valvular, holes in the heart, anything that's anatomical, it can detect it. And then come into a hospital near you, 4D echo. Anybody ever seen 4D echo? And a 4D echo, folks, is a hologram. A hologram of your heart. This is neat stuff. This is like space age stuff, right? The patient just laying there. You can let him watch TV while you're doing this. That's why we like it, because there's no pain, no radiation, or nothing. Just put a little group on his chest, and then you start, all of a sudden, the heart right there in front of you. You're watching his heart beat right there in front of you. You can actually see the blood flow through the coronaries all the way around. You can see where the clot is. You can see where the calcifications are, right? It's like you can just grab his heart, but obviously there's no heart. But it's like, oh, it's in front of you. Get this. You can put your hand like this and slice that heart open. It'll open up like this for you. And you can look in there and see blood flowing in and out. You can see wall motion around it. You can see valvular problems. I mean, it's amazing. It's like, Star Trek stuff. That's what's coming down in pipeline. Ooh, there's some more. That's just the heart. Then neurosurgeons are using it. They can hologram your brain right there on the table. You see, the whole time, no radiation. I'm not using anesthesia. We're not doing surgery. Let's just hologram his brain right here. Let's say somebody got shot in the head. You say, oh man, how do I get in there and cut out some of his brain and do the least harm? Have you guys ever seen some of these medical shows? They have the person playing their favorite instrument. That's how they figure out when they screwed up. You're playing your instrument, also you can't play it, they messed up. That's why they do that. Okay, but this way, why don't we just do it the hologram? You put the hologram, the brain on here, you say, oh, there's a bullet right there. Okay, what if I make a cut like this? Then you hit the button, and the button tells you what you just took out. You did it. Oh, damn, no, I don't want that. Imagine if you had done that in reality. You just got permanent brain damage. See that? You can try every cut. Let me do a circle. Let me do a square. Just try anything you want until you look at what they did. Oh, yeah, very low damage there. Okay, let's do this route. That means now you can go do brain surgery and be out in half an hour. You just imagine how many lives we're going to save when this thing is perfected. The general surgeons are using the same thing for the bowel. Stab wound or gunshot wound to the abdomen, everybody goes straight to surgery. Just remember that whenever you see that vignette, straight to surgery. Why? You can see the bullet went in, bullet went out, but you don't know where that bullet went before it came out. A lot of people used to die because we thought, oh, you see the entry, you see the exit. Oh, yeah, it just went straight out like that. And then they'd be dead in a few minutes because nobody knew they were bleeding to death on the inside. So we take them all to surgery now. But now, look at this. I can just hologram your intestine right out here. That means before I would have to open you up, And then I have to go through your intestine inch by inch like that, looking for any holes, any tears, anything. Then I have to do the same thing with your liver, same thing with your spleen, same thing with your kidneys. That takes hours. Hours of messing with all my organs, folks. All my organs are inflamed. Everybody follow that? So after they're recovering, they get abdominal compartment syndrome. So much swelling that all of a sudden you see this stitches pop. Or the pressure is so high, it compresses the bladder, they can't even pee, and you can ruin their kidneys. So we've lost a lot of people with that procedure, but we have to do it. But now with the hologram, I can hologram one organ at a time, take my time, do whatever I gotta do, take a look at every inch. I can take all the hours I want, but you're not under anesthesia anymore. I don't have to worry about compartment syndrome. Once I figure out what's wrong, I say, okay, we need to take 2 centimeters off the liver on the medial side. Oh yeah, 1 inch off that kidney. You already know what you gotta do. No more rummaging around. As soon as you take him in there, anesthesia, do what you need, you're in and out in less than an hour. Think about how many people we're gonna save who don't come out brain dead anymore because it took 10 hours to get it done. All right, so that's what it's amazing what's coming down the pipeline for you guys. Yes. Would it be safe for what now? Oh yeah, for pregnancy, because there's no radiation, no trauma to the baby at all. Yeah, you can take a look at everything about that baby or those babies without any harm being done to them, and then decide what you need to do. Yeah. All right, the sarcomere, the physiology part. This is how we work our way into heart failure now, the last topic. Here's the sarcomere. The way you evaluate a sarcomere, Saba, is always look for the dark line. That's the Z line. From one Z line to another Z line equals one sarcomere. That's how you get yourself oriented. So you don't miss these questions. They always put a muscle picture, okay? The light areas that surround the Z line, that's where actin is. Remember, actin is a thin filament. That way now you know where actin is. The dark area in the middle is a length of myosin. That is called the A band. A band is the length of myosin. As you can see on the very edges, there's some overlap. That's why it's shaded a little bit darker. So over here on this side, there's some overlap. So A band contains mostly myosin, but some actin because of the overlap. In the middle of the A band is an area that's just myosin alone. So they call it H for heavy. So, oh, it is labeled here. H zone. See, just the myosin right here in the middle. There's no overlap. H band. And then right down the middle, there's little knobs, even though it's not in this picture. I'm going to put them in here like that. This is the M line. M line is where CPK is stored. So by getting yourself oriented, now you can answer their questions. Because the light areas that surrounds a Z line is the I band. That's just actin. The A band is myosin and actin because there's some overlap in the corners. The H band is myosin by itself. No actin at all. Anytime a muscle contracts, Sandeep, what happens to the length? Shorter or longer? Shorter. That means the amount of overlap has to increase or decrease. Increase. That means the two areas are non-overlap, they have to disappear. As I remember, H and I are the two bands that disappear with every muscle contraction. With every muscle contraction, you have to increase overlap. That means the areas are non-overlap, they have to disappear. That's how I remember which bands disappear with each contraction. The other bands stay the same. Any questions on that? So the Z lines is where actin attaches to. So actin attaches to the Z line and then sticks out. Any questions on that? All right, so that's the orientation. Now CPK, what is CPK for? Creatine phosphokinase. First of all, creatine. Creatine is an acid. It's acid, fat or water soluble. Andrus, water soluble. This is something that athletes, some of the weightlifters, they take creatine. You can buy a GNC. They take it to build muscle. Well, at least you know, no false advertising there. It does work. But you're going to put on a lot of weight. A lot of them will come in your office complaining, man, I'm gaining weight. I'm working out every day. How come I'm gaining weight? Ask them what supplements are you taking? And most of them are taking creatine, and that's just holding a whole lot of water. Okay, yes, it builds muscle, but it holds on to water because it's an acid. Water soluble. All right. Now, a certain amount of muscle is broken down every day, man. A certain amount of muscle is broken down every day just for nutritional needs and exercise. You follow me? That means every time you break down muscle, CPK has to be released. Does that make sense, everybody? So that means there's a certain amount of CPK that's released every day for everybody. That's why there's a range. Okay, that range, as long as you stay within that range, then we know there's the normal amount of muscle breakdown. We're not shocked or surprised. But if that CPK is higher than usual, we say, okay, that means you broke down a lot more muscle today than you normally do. That means then I got to figure out, well, why is that? Well, first of all, men break down more muscle than women. Why? Because men exert themselves more than women. Everybody follow? What if they gave you a woman who works in construction versus a woman who's a secretary? Well, the one who works in construction is exerting more. So her CPK is higher than the other one. Everybody follow that? So whoever exerts themselves more will always have a higher CPK. Again, that's why they have a real wide range of what normal is. All right, because it doesn't matter if you're male or female. Whoever exerts themselves more will have a higher CPK. But if you go outside of that range, we say, okay, you got muscle problem. That's called myositis or polymyositis. That should sound familiar because we already done those. So when CPK is much higher than it should be, then you got myositis, polymyositis, or dermatomyositis. Something is making your muscles break down. Now, first, let's look at creatinine. To get rid of creatinine, when muscle breaks down, get rid of creatinine because it's water soluble. Who's going to get rid of it for you, Bailey? Kidney or liver? The kidney. So that means I need a certain amount of blood flow going to the kidney in order to get rid of this creatinine. You understand that? That blood flow going to the kidney is called renal blood flow. Or that depends GFR. Or that depends insulin clearance. And that depends on creatinine clearance. So all four of those are linear. But they're inversely related to serum creatinine. Remember, we did the same thing with BUN. Okay? So your level of creatinine in your blood, inversely related to those four things. That means when one goes up, the other one goes down. That means if your creatinine doubles, what happens to your GFR? Abigail. If your creatinine doubles, what happens to your GFR? What's that? Why is it going to increase? Okay, why is it going to decrease? Either way, you got to explain something to me. Okay, let's ask Maria. If your creatinine doubles, serum creatinine. Serum creatinine double. What happened to your GFR? Decreased by a half. An inverse of a half. That's how you're sure whether you understand what that sentence means. Does everyone understand? Because you're the one ordering BUN creatinine on people. You got to know how to interpret it when it comes back. If the creatinine double, you say, oh man, GFR got that in half. All right, as creatinine triple, you say, oh, he only has a third of blood flow to his kidney. That's how we use creatinine and BUN, folks. But you want to know the four things. Same way I gave you BUN. Creatinine clearance, GFR, renal blood flow, and insulin clearance are linear, but inversely related to serum creatinine. Okay? Normal creatinine, 0.5 to 1.5. If CPK is elevated, then I say, okay, you got myositis, polymyositis, or dermatomyositis. Anytime you have an itis, inflammatory muscle disease, it attacks the proximal muscles first. Because if when inflammation leaves your heart to go to the periphery, it's going to touch the proximal ones first. And that way they'll tell you, oh, he's having trouble getting out of a chair, he's having trouble getting out of bed, trouble walking up the stairs. Then I know proximal muscles, then I know it's one of the itis. Any questions on that? All right. So myositis, polymyositis, LSCPK, most common cause, this should all sound familiar. Hypothyroidism. What's the most common cause of hypothyroidism in a newborn baby? Veronica Acuna.
Thyroid hyginesia.
Thyroid what? What did you say? Oh, let me have her speak for herself. Veronica, what'd you say?
Is it thyroid agenesia?
Yeah,
Mm.
agenesis, agenesis.
Agenesis. I'm sorry.
Agenesis or dysgenesis. All right, so hypothyroidism in American adults. Hannah, Hashimoto's, and anybody goes with Hashimoto's. Anti-TPO. Worldwide is iodine deficiency. Drugs are number 2. And the most common drugs right now, statins. For myositis caused by drugs. But otherwise, it can be any fat-soluble drug. And that's why we've been highlighting every category. I've showed you the long-acting one, so you can make these connections for yourselves. All right. JO1 is the marker for autoimmune myositis. So either they'll mention the JO1, then you got to make the diagnosis, or to make the diagnosis, ask what's the marker. JO1 is the same thing as transfer RNA synthetase. Infectious myositis, remember, 2 parasites we've already talked about. Trichinella spiralis and Taenia solium. Trichinella spiralis, Chris with a K, from eating raw what? Not pork. Yeah, not pork is having the other one, bear meat. Yeah, a lot of this in Alaska. Taenia solium is from eating raw pork. That's Florida and Louisiana. They got a lot of pig farms. All right, but know the connection, because remember, they're going to tell you where the person had been, and that's how you make the connection. Oh, okay, that's how he got it. All right, any question, myositis, polymyositis? How do you treat any inflammatory disease? Nave, how do you treat it in autoimmune disease? What drug would you use? Steroids. Pick any steroids you want. Which steroid is oral? Abigail. And Dr. Van beating up on me today. All right, Bailey. Prednisone. Yeah, so okay, just making sure you still haven't forgotten this stuff. All right, anyway, that's myositis, polymyositis. And then there's dermatomyositis. Remember derm, they have a rash. The rash is called a heliotropic rash, a red or violaceous rash on the eyelids and knuckles, also known as Gotron sign. We're going to talk about all of this. We said this is perineoplastic, would be secondary to an internal cancer, and colon is number 1 right now. So well, what I do is I need a cancer. There's only one. Okay, I click. I've seen it with ovarian, I've seen it with lung cancer. It doesn't matter which cancer they pick. All right, that's why if you just memorize colon, then you're gonna pick the wrong answer. And say, oh, breast cancer. No, I can't pick that. It's a malignancy, period. Okay. Now, if there's more than one malignancy, then you can pick colon over the other ones. But it's malignancy first. Any questions so far? All right, obviously, you need to search for this colon cancer with a colonoscopy. And Eric, you have a question?
Yeah, real quick, Dr. Francis. Does anti-JO1 apply to dermatomyositis, or is it a different antibody?
Yeah, different antibody. JO1 is only autoimmune myositis and polymyositis, not dermatomyositis.
Sweet, thank you.
No problem. All right, rhabdomyolysis is when the muscles are so inflamed, the whole thing breaks down and myoglobin now leaks out. Just a more severe form. Again, remember we've talked about this. So the elevated myoglobin is the one that gives it away. How do they hint at it? Remember, red urine, but no RBCs. Anybody remember what else presents the same way? Red urine with no RBCs besides rhabdo? Lauren? Yeah, porphyria, same look. Okay, but rhabdo, remember, you'll have muddy brown cast, which is part of acute tuberous necrosis that myoglobin does to your kidney. Okay, treatment, like we talked about before, fluids, because it's water soluble, bicarb, second. Always look for them in order. So rhabdomyolysis. Muscle differences. What are the differences in all the muscles? Here we go. Cardiac muscle. In addition to wave depolarization, calcium must flow into the T tubules during phase 2 for contraction to occur. So this is cardiac muscle. What's different? So cardiac muscle depends on extracellular calcium. The ventricle depends on extracellular calcium to trigger off its contraction. Smooth muscle has no sarcomeres. That's why it appears smooth. No lines in there. It also contains no troponin. If it contains no troponin, actin myosin are always bound. We call that latching. That's the reason why you always have bowel sounds. Bowel sounds. The medical term for vowel sounds is called borborygmi. Borborygmi. There's no Latin derivation for this. A couple of guys came up with it, sounded good, so we kept it. So you can imagine, one guy listens to it and what do you hear? Hey man, what'd you hear? I heard borborygmi. What the hell is borborygmi? I don't know, man. That's what I heard. Man, you crazy. They give me a stethoscope. Let me take a listen. He takes a listen. What do you hear? Well, dude, you're right, man. It does sound like borborygmi. They made it up, but it sounded like what you hear, so they kept it. But there's no Latin derivation for this. All right, anyway, borborygmi. Vowel sounds. I'm going to show you what happens when your vowel sounds increase or decrease. First of all, normal. That's where you always start. What is normal? If you want to listen to somebody's abdomen, you listen, you inspect, look before you touch that belly. The minute you touch the belly, vowel sounds start up. You get a false positive. So you look, and then you put the stethoscope for 20 seconds each quadrant, 4 quadrants, and then listen to it. The normal vowel sounds should just be occasional bubbling. That's normal vowel sounds. Okay? Now, what if they increase? Then I'll do what if they decrease. If vowel sounds increase, it'll sound like more like this. It's just nonstop. That's not normal. All right. When vowel sounds increase, number one, gastroenteritis. The GI is irritated. That's why it's just rumbling like crazy. Gastroenteritis, number one. In adults, adenovirus. In children, rotavirus. Unless you're fully vaccinated child, then it's norovirus. So gastroenteritis, number one. Obviously, there's a ton of other infectious causes. Increased bowel sound, that's the first thing you think of. Gastroenteritis. Number two, obstruction. Whenever you have obstruction, the bowel is trying to move this thing out of the way. So you, okay, it's an increase. But if they want obstruction to be the problem, they'll say rushing or tinkling bowel sounds. Because that's the bowel taking a running start, trying to move something out of the way. So you hear rushing bowel sound or tinkling bowel sounds. You have a physical obstruction in the way. So when it's increased, I say gastroenteritis or obstruction. Then I try to see if they mention anything about tinkling or rushing, then I know they want obstruction to be the answer. Any questions on increased bowel sounds? Yes. Number two for what? Oh, still obstruction. Yeah, just anybody. Yep. Yeah, that's decreased bowel. I'm sorry, increased bowel sounds. All right, now decreased bowel sounds. Anytime decreased bowel sounds occur, number one, you have an ileus. That means you're in a state of less likely polarized. Chris with a C. What do you think is the most common cause of a less likely polarized state? What's that? Anesthesia after surgery, it can't happen, but that's not number one. Number one is just dehydration. Whenever you're dehydrated, we're going to vascular phys next anyway. Anytime you're dehydrated, you shut blood away from the GI tract and your skin. That's why the GI just stops working. It doesn't have enough blood supply anymore. Okay, and of course it happens after surgery too. All right, but dehydration is number one cause. Number two, electrolyte problems. Chris with a C, give me an electrolyte problem that make you less likely polarized. Okay, high calcium makes you less likely polarized. I like that. Bailey? No, low sodium and high sodium make you more likely, so that can't be it. All right,
Magnesium.
what about magnesium? High or low? High. Okay, high, Bailey. High. All right, so yeah, high magnesium makes you like, remember, it gets in the way of sodium. All right, Ida, another one. Not hypocalcemia, remember hypercalcemia, hypermagnesemia, and dehydration. There's another big electrolyte issue. Amy? Hypokalemia is the number one. Yeah, so if you have to pick one on an exam, that's number one. As far as electrolyte issues, hypokalemia makes you less likely polarized because potassium rushes out of the cell. In fact, the guy put his name on Ogilvy syndrome. OGAIF. That's how common it is. Hypokalemia induced ileus. That means if you did an X-ray on him, you notice the bowel is just inflated with gas, but there's no place where it's obstructed. That's specific for colon and small bowel. All of it will be dilated. What about Ogilvy? It just starts in the colon, not that, only the colon can be dilated. Yeah, that's just where it starts, but it can be anywhere. Yeah, this is just hypokalemia induced ileus. Paul? Nope, hyponatremia causes more likely depolarize. I told you that's the favorite one to ask. The students accidentally think, oh, you don't have sodium, you can't depolarize. When we went through the physiology, you're more likely to polarize because when you have low sodium outside, sodium will leak out in exchange for calcium going in. So I said, talk it out so you don't make that mistake. Okay? All right. Yes. Well, whenever you're dehydrated, potassium does go low, but dehydration can do it even without hypokalemia. Yeah. All right. Smooth muscle contains basal bodies. That's these little circles. They look like that. And then sticking out of basal bodies, there's your actin. And then myosin is underneath that. Let me just do it in a different color. So it'll be something like this, and then it latches up there with the myosin heads. Your smooth muscle has myosin ATPase activity. In fact, what it has is a myosin light chain kinase, followed by a light chain phosphatase, and they work together. The kinase phosphorylase, the phosphatase chops it off, and then the energy is released. Edmunda, anytime you chop off a phosphate, how much energy do you get? Remember the first two phosphate bonds? Rachel? And Miguel. Yeah, remember 7,300 calories. That's what you get. Okay, and that's what you need. You need energy for releasing muscle, not for contracting. All right, any questions on smooth muscle, cardiac muscle? So in other words, cardiac muscle and smooth muscle requires calcium. Skeletal muscle does not. They love to ask that question. Or the clinical way is ask you, how come calcium channel blockers don't affect skeletal muscle? It's because they don't depend on extracellular calcium, whereas the other two do. So please don't forget that. As muscle contracts, let's go to.
Hey, excuse me, sir.
Yes, Mabel.
Please, what did you say that the cardiac muscle and the smooth muscle and the what happened about calcium? I didn't get the last sentence.
That cardiac and smooth muscle depend on extracellular calcium for their function. Skeletal muscle does not.
Okay, thank you.
All right, no problem. So Pablo.
Yes.
All right, follow me for a second. As muscle contracts, everybody else follow along now. Length will decrease. Force and tension will rise. A band stays the same, but the amount of overlap has to increase. That's why the H and I band have to shrink away. Does that make sense to you, Pablo?
Yes, it does.
All right, does that make sense to everybody else? All right. Length tension curve says as the length of the muscle increases, you have less tension. As the length of the muscle decreases, you have more tension. Does that make sense to everybody? All I do is just show the same thing in a graph rather than just saying in words. Okay? The key is there's an optimal length for everything. All right, you have Golgi tendon organs that will monitor how much tension you put on the muscle. Okay, that means when the active molecules from two Z lines, when they touch each other like this, everybody understand? You now have maximal overlap. GTOs are the ones who are monitoring that. Once you get to maximum overlap, it fires. It says you got 1 second. And the muscle will relax whether you like it or not. So GTOs stop you and me from ruining our muscle. Once you have maximum tension, you have 1 second and the GTOs will fire. Because if you push on that sarcomere any more than that, look what you're gonna do. Run it right into each other like that. You actually destroy the sarcomere. That's how you hurt yourself, lifting weights or lifting anything else. Okay? All right, 1 second, then it fires, the muscle fires, muscle relax. So good place to see this is in the Olympics. When you're lifting weights above your head, the referees on the side, they put up the white flag that says you're okay. Red flag says you're not. So anyway, so they put up the white flag. You only have to hold that weight above your head for 1 second. Notice it's written into sports. Why? Because when you hit your maximum, you can only hold it there for 1 second. If you ask me to hold it there any further, that thing's coming down on my head. It'll crush the person's skull and you got a dead athlete. Okay? Think about when they're letting go of the weight. Notice they're not required to bring it down and do this. They always push out from underneath it like that. Because what if your GTO is fired? And you want to make sure it falls down there, not on your head. Okay, 1 second, push away from it. Okay? In the weight room, you hear boom, 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 boom. That's the guy who knows what he's doing. Just drop weight. Especially when you're doing the deadlifts, okay? All right, so GTOs prevent you from ruining your sarcomeres. All right? As you increase the preload, you need longer pause to offset that preload. Let's see what that means. Let's go to the weight room and check this out, Anders. So let's say there's a guy who's going to the weight room. He says, I need to get a beach bod by June, man. So I want rippling muscles by June. So he starts working out. So today he's going to curl 10 pounds. Let's say he has 100 cross bridges. I'm just giving you some numbers, okay? 100 cross bridges. So as soon as you pick up the weight in your hand, that's called preload because you haven't moved it yet. When you're just holding a weight, that's not called work in physics terms now. All right? Because remember, physics says you got to move it over a distance. All right, so he just holds in his arm, his biceps, let's say 100 cross bridges says, ooh, I need 20 cross bridges for this. So 20 cross bridges will engage. Boom, 20 cross bridges. Now you have 80 cross bridges to do work. Follow me? So 80 cross bridges, yeah, he does 60 reps. When he gets done, yeah. Okay, fine, drop the weight. All right, next day he shows up. He said, man, I got to get into better shape. 10 pounds are for wimps. I'm doing 20 pounds. As soon as he picks up 20 pounds, biceps said, what the heck? 20 pounds? Oh man, we need 50 cross bridges for this one. Now, between yesterday and today, you needed 20 cross bridges yesterday. You need 50 cross bridges today. See that? You're gonna have to wait a little more time for those cross bridges to offset the preload. So, professional weightlifters is what you see when they're in the weight room. These are guys who read the magazines. They pick up the weight, you hear it. Oh, yeah, oh, yeah, oh, yeah, oh, yeah. They just start doing all that. The weight hasn't even moved yet. But now all that is their little routine. But that's because they've been taught to do that. The average Joe who doesn't know that, is he's just gonna pick up the weight and do this. Yeah, right, and then you rip yourself to pieces, okay? Because let's say you do that, you try to lift the weight, the cross bridges weren't made yet. You follow? You don't have no cross bridges, you try to lift it, and the muscles say, I can't do this, and they let go and like, what do you do now? The muscle is torn. Because what you're doing is doing this, you know? You're ripping your muscles apart. That's called a muscle strain. Right before the muscle edges slip apart, they do that. That's why you go into a severe spasm. That's why they got, and now he's out here for like the next 3 weeks. Okay, because you don't have to wait. So that muscle regrows in length and edges are back to normal, and then it'll release the spasm. But that's why you're out of commission for 2 to 3 weeks. Okay, that's why box stores like Walmart, they're aware of this because before they were paying a lot of workers' comp, because when you're out, they can't work you, but they got to pay you because you got hurt on the job. That's why they wear these harnesses. You have seen those harnesses, right? The harnesses teaches you to lift with your leg, not your back. Because if you start to suddenly lift a box with your back and the preload was not offset, that's how you hurt yourself. Okay. So as you increase preload, folks, you have to allow more time for the preload to be offset before you start moving it. Okay. So now let's say it comes the next day and you say, you know what? He looks over the corner, he sees a cutie over there. Ooh, I gotta get her attention. Yeah, I know how to do that. He said, 20 pounds is for wimps. I'm doing 50 pounds. 50 pounds? As soon as he picks up 50 pounds, the boss says, oh man, we need 98 cross bridges for this. How many cross bridges does he have, man? He only got 2 left. You want to follow? This is that guy. It picks up the weight and you hear this. One, and then drops weight. You did all that screaming for one rep. That's how you know he had no more cross bridges left. Because you're not gonna do 60 reps with 2 cross bridges, forget it. All right, but that's how I know he's at that point. So you can walk into a weight room, you can tell who's at what level if you understand physiology. Okay, so no problem. So let's say he comes back, Anders, and he spots that same cue again. She's over in the corner and she's got light blue sweatsuit on. And he says, I got light blue on too. She must be into me. Hey, delusions are good. It's okay. It's okay. So anyway, so he says, oh, I gotta get her attention now. So he says, I'm gonna do 70 pounds. 70 pounds. Tries to put his arm on the 70 pounds, and the bicep says, what the? We need 180 cross bridges for this. How many cross bridges does he have? Only 100. How do you know that guy? That's the guy who tries to lift the weight, and all you hear is screaming, and the weight is not moving. The weight hasn't moved yet. He's screaming, snot flying out his nose, you know, spit flying everywhere, blood vessels popping in his eye, but that weight never moved. That's because he doesn't have enough cross bridges. But you know, men, we don't know. We just try to show off to some girl in there. So the biceps start talking to each other. Right bicep starts talking to left bicep. Hey, left bicep, man, what do you think is going on here? Left bicep said, man, I'm telling you, there's a woman in here somewhere. You know, there's a woman in here. You see how fast the weights are going up? I'm telling you, there's a woman in here somewhere. Why don't you take a look around, see what you see? Dude, I'm a muscle, man. I got no eyes. Let me take a look around. I don't know if there's somebody in here. I'm telling you, though, it's got to be a woman because the weights are going up too fast. So let's help them. When the muscles are convinced all the time, they're going to try to help you out. Once you're out of cross bridges, weights will not move. That's the last guy we just did. All right. First thing the muscles will do to help you, hypertrophy. Anders, what does hypertrophy mean? Build up what? Yep, say increase in size. I got to hear the word, keyword, size. That means where once there was a room for 100 cross bridges, now there's room for 1,000 cross bridges. Everybody see that? He needed 180 to lift that 70 pounds. He has another 820 left over. That's why he's lifting weights like feathers. Now, the guy who doesn't know this admires, he's got muscle, so he says, ooh, I'm gonna lift like he does. And he lifts the weight, and you don't have to cross bridges to lift this thing, then you rip your own back muscles, okay? But he's been lifting every day, so his muscles have been helping him out. First response is hypertrophy. Now you can overcome the resistance. That's why it's also called resistance training. Everybody with me so far? Anybody got a question or anything? I'm gonna talk you through the whole thing. All right, so the first response of muscle to any stress is always hypertrophy, increase in size. So now you have room for more cross bridges, that way you can overcome that. So that's why anytime there's stress or resistance in your body, the muscles will hypertrophy to overcome it. That means it's overcomable. You can overcome it. But I'm about to show you what problem comes out of that. Karis. Yeah, if you hold the weight in your hand, that's preload because you haven't moved it yet. Move it, you got to go over a distance. Just to hold it in your hand, that's not called work in physics terms. Okay, but your biceps feel the tension on them, and that's why they immediately start engaging cross bridges to overcome that weight. That's what preload is. It's not contraction. It's just cross bridges engaging to offset that preload. In order to prepare, exactly. In order to prepare for the contraction, you got to first offset the preload. All right. Any questions on hypertrophy? All right. There's a bad side to this. Hypertrophy is increase in cell size. All right. If you increase in cell size, okay, then that means you have more room for cross bridges. So now the muscles will engage more cross bridges. Everybody follow me so far? All right. After a while, the second muscle response to stress is to anticipate the average stress. They will anticipate it. He says, hey, man, right bicep, how much weight is he putting on you? Give me a second, man. Let me calculate this. And Up, 72.4 pounds. So what about you, left bicep? How much stress he putting on you? And then he puts, I got a new calculator. Give me a second. And put down 4, cut it. No, sorry. Put down 3, cut it 4. 98.2 pounds. 98.2 on the left. Whatever I just said for the right. Okay. He's left-handed. Whichever arm is lifting the most, that's your handedness. Now I'm right-handed, so that means, and that's 90% of people. So that means if I'm gonna lift weights like this, even though you see both my hands moving, my right arm is doing most of the work. If you go to any muscle magazine, take a look at the biceps. One of the biceps is always bigger than the other one. That means I can tell what handedness a person is. You can't help it, that's just the way it is. Okay, so that's why you'll see a differential in how much each arm is lifting. Any questions on that? Now, here's the bad side of what just happened. Your muscles are anticipating how much weight you're gonna put on. They say, so the average of the two numbers, let's say is 85 pounds. It's okay, how many cross bridges do we need to engage for 85 pounds? It says 150 cross bridges. Okay, 150 cross bridges unite. 150 cross bridges. Ping! That's why you see the weightlifter starts walking like this all the time. Yeah, his arms always bent like this. Hey man, straighten out your arm. What are you talking about? You know, you see the same thing as legs. All of a sudden, he starts getting bow-legged. He wasn't bow-legged before. He's bowed because the muscles are contracting. Okay, but that's what happens. His arms are like this because they're anticipating the average weight that they have to lift every day. That's why then when he goes to the weight room, he doesn't have to wait for the cross bridges to be made yet. Right, follow that? Because they've always been made. That's why you lift the weight like it's nothing. That's because the cross bridges are made for preload. All right, that's why the more weight you can lift, the more weight you will lift. Because you keep hypertrophy, more cross bridges are made for you, and the anticipatory response will increase over time. That's why every weightlifter, their arms get bigger and bigger, the more their arms flex. And they cannot help it. Okay, they cannot help it. Here's the problem with that. If your muscles are contracted like that, Olivia Balding, that means they're also contracting around all the vessels that go through those muscles. Everybody see that? Everybody see the problem? First, the veins, then the arteries. So that means you're compressing my veins. Blood usually goes superficial veins, down to the deep veins, and then into the IVC and up to your lungs. Right with me? If you compress the deep veins, then that means superficial veins cannot go down there. But it's going to take a lot longer to get down there. That means blood will back up, and blood is now sitting on superficial veins, just waiting and waiting and waiting. What is that? That's called a DVT, waiting to happen. Except it's called superficial thermophlebitis, not deep veins. This is the superficial veins, is where the stasis is. Everybody follow me? The compression is in the deep veins. So clots is not going to form down here. The pressure backs up, and now stasis in the superficial vein. Superficial thrombophlebitis is the term that we use. Now you say, well, if clots happen all the time like that, Dr. Francis, why don't we tell weightlifters stop weightlifting? That's because superficial thrombophlebitis. For the clot to get to your lungs, they have to go through a 90-degree angle to get to the deep, another 90-degree angle to get to IVC. That means the chance it's going to get to your lungs close to none, less than 1%. That's why we don't worry about it. But there's only one vein where the superficial veins have an angle, a nice acute angle like this. There's no 90-degree angle at all. It just can slide right in to the IVC. And that's your femoral veins. So whenever you get superficial femoral thrombophlebitis, you treat it like a DVT. All the other ones do nothing. How do I know an athlete is at that point? If ever you see the muscle magazines, you see how that vein stands up on his bicep? That's how you know he's at that stage. You see the veins on his neck, sorry, in his head. You see right here in the forehead, right? All the veins popping up. Why are they standing up? He's at that stage. So you can look at the pictures and tell exactly where he's at. Yes, Solange. Would it make sense to tell him to start taking baby aspirin every day? At first thought, you say, yeah, it would help. However, if the risk of a PE from it is less than 1%, that means the aspirin worse than the thermophlebitis. But if you get superficial vein thermophlebitis, it's the same as a DVT. that person needs to be on heparin. And then you transition to what other drugs, Solange? Warfarin after a bridge of how many days? 2 days, but if you don't want a bridge, what drug should you use? Za, who's Za? Oh, so the drug is Exan, Rivaroxaban or Pixaban. All right, the only two don't need a bridge. Everybody else needs a bridge. 2 days, then you switch. And for the first clot, I know how you got it on them. How long you gonna be on warfarin? First clot, I know how you got it. You did it from weightlifting. How long you gonna be on warfarin? Now 6 months. Hannah. First clot. What are you saying, 3 months? Okay, I can tell, but it is 3 months. Your body position told me you were just guessing, but I want you to know it is 3 months, all right? First clot, and I know how you got it, I'll record 3 months. Second clot, and I know how you got it. How long? I don't know. Now 6 months. They're trying to bring it down to 6 months, but not yet. Cesar. How many months? 9 months? No. Ida. 1 year, 1 year for the second clot. Third clot. That's it. Lifelong. Or at any time when I don't know you how you got it, but this one I already know how you got it. All right? All right. Any questions? Michael?
Yes, 3 months for the first clot.
3 months for the first clot, correct? No, that was just arbitrary and it worked out. Yeah, they just tried it. You know, they tried different times and 3 months seemed to be ideal without excessive cost and everything. Yeah. Any questions on this weightlifter? All right, so that's the veins. Everybody see on veins. Now I'm going to arteries. Now the arteries are also being compressed by the muscles. If the arteries are being compressed by the muscles on them, what happens to your total peripheral resistance? Going to increase. If your total peripheral resistance increases, Akshay, who has to pump against that resistance? Right or left ventricle? Left ventricle. Well, the ventricle, folks, is another muscle. Guess what? He's going to do the same thing. Let me make sure the people online can see this. I'm going to show you guys what's about to happen. Your ventricles will have to do the exactly same thing as your other muscles. Yeah, I just want to zoom into my hands here. Yeah, there we go. All right, so here's my hand. That's your ventricle. Okay. So when the ventricle starts to hypertrophy, all right, it starts to expand outward like this. See that? So you actually have more space within the ventricle. You now have more cross bridges around it like that. That means contractility, Abigail, rise or fall. Huh? Increase. Everybody understand? If I got more volume, more contractility, what happens to my cardiac output, Maria? It increases. If your cardiac output increases, what happens to my heart rate? Decreases. If you got a lot of output, you don't need so much heart rate. So that's how you know when the person's at that stage. Remember the athletic heart? They always talk about they come in at resting heart rate is like 42, but they have no symptoms. Okay, that's how you know they're at that stage. That means this is still pulling out like this. They call it the athletic heart. The ventricle actually increases in size. That means there's more filling here. All right, now watch my hand. Over time, as you hypertrophy, the heart says, uh-oh, I'm about to hit the pericardium. The pericardium is outside like this. If he goes out and he's about to hit the pericardium, he says, I need to start doing this. You start hypertrophy going inward now. What are you doing to your ventricle? You're obliterating your own ventricle. Which means after a while, you lose filling space. And because you have less filling space, they call it a diastolic filling, a diastolic dysfunction. So whenever you hear diastolic dysfunction, that's somebody with too much hypertrophy. And when you don't have enough cardiac output to meet your body's needs, we now call it diastolic heart failure. So diastolic dysfunction, but diastolic heart failure means too much hypertrophy. Or now the new term they want us to use, heart failure with preserved ejection fraction. Why is it preserved? Because you got tons of contractility. But a high ejection fraction of very little volume says you still don't have enough coming out. That's why you're still in heart failure. You got a high ejection fraction, 60%, 70%, but it's of a very small volume, so it's not enough. So heart failure with preserved ejection fraction is too much hypertrophy. So let me go through those terms again. So you got hypertrophy occurring. First, the muscles will stretch out, stretch out, stretch out. That's the athletic heart. You got more volume in the ventricle, more space in the ventricle, with more cross bridges means more contractility, so output is real high. And that's why good athletes come in with resting heart rates in the 40s or low 50s, and they're fine. We don't do anything about it. Everybody understand? Okay, but then after a while, the hypertrophy starts coming inward, And as you come inward, you start to lose space in this ventricle. That means cardiac output starts falling. Cardiac output starts falling, Ida. What happens to your heart rate? Starting to go up. So you see, when somebody had a heart rate of 42, that's a well-trained athlete. Then all of a sudden they see me a few years later, heart rate is in the normal range. Does everybody understand? He's now going in the opposite direction. That's where you warn him right there. So I do. You might want to slow down in what you're doing because your heart rate is back to normal. That means it's going to keep going up. Because as you lose more and more space, it's going to get higher and higher. But you and I know they never stop. Still good to warn them. There's no legal obligation to warn them. We just do. Okay? Because we tell them, hey, this is what's going to happen if you keep doing it. All right? This is why a lot of athletes die younger. You ever wonder about that? Football players. Football players are groomed to be as big as possible. All that muscle they put on their body, folks. Football players, linemen, especially offensive line, defensive line, you know how long they live? 40 to 50 years of age. They drop dead. That's the average lifespan for a lineman. That's because of the way they're groomed. You know, I remember when I was in college, good Lord, never get there right after the football team came. All the food is gone. I mean, you see one guy, he's probably like 7 steaks on his plate. He's the lineman. The coach told him, you got to eat 10,000 calories today. And that's what he does. And then he goes to the weight room for the next 4 hours and turns it into muscle. But it's going to cost you a lot of years of life because your heart's going to get so thick that there's hardly any room in here. And then they die in their 40s. Yes. Is it reversible, you mean? It's partially reversible, just like muscle. If you stop doing whatever you're doing, it will atrophy to a point. Yeah. So it is partially reversible, not completely reversible. Okay. But that's why you try to catch them early and tell them stop doing what they're doing. Okay. But that's up to them. They never do. That's because the money in sports is huge. Everybody wants that big contract so they can make a lot of money. Okay. But they pay with their lives. Okay. Abdullah Khan, question.
Is this how Bruce Lee died?
Bruce Lee, I don't know. Anybody know? I thought he died with an accident, right? Yeah. Huh? I know his son died. The gun went off or something like that. Yeah, but I don't know how he died. I thought it was an accident too.
Oh, the heart attack.
Bruce Lee, the martial artist. Oh, okay. So he had multiple causes. Yeah. Okay. Yeah. Yeah. Serial edema. Okay. So that means it must have been a drug. So again, 2 responses of muscle. Remember, first hypertrophy, second anticipate by making the cross bridges for you. Okay. Just so you understand. That means muscle fibers remain permanently contracted. When muscle permanently contracted, increased systemic vascular resistance, increased venous resistance means risk of superficial thrombophlebitis. Remember, treat only the femoral superficial thrombophlebitis. You don't treat anybody else. Don't forget that. Everybody else, they'll tell you thick clot. So what? Do nothing. I mean, you can see them. I've seen people with their veins on their forehead. You can see a clot in there. You don't do anything. Weightlifters have that all the time. All right. Increased arterial resistance, left ventricle forced hypertrophy leads to diastolic dysfunction, leads to diastolic heart failure, and eventually heart failure, preserved ejection fraction. Any questions on these terms? Okay, so heart failure, preserved ejection fraction, what you need to do is decrease the heart rate, Gloria, so you have maximum filling time. Make sense? Then you need to decrease the contractility so that it's not compressing the coronary arteries so much. That's why they die of arrhythmias. Make sense? And that's why beta blockers are the only drugs that decrease mortality in hypertrophic hearts. There it is, folks. We just covered all of them. There's no exceptions. The only drug that prolongs your life when you have a hypertrophic heart due to anything is a beta blocker. I just explained the physiology. Hopefully you heard it. You got to decrease the heart rate so you have maximum filling time. Because remember, you obliterate your space here. But if you give more time, more blood will enter and stretch it out a little bit. And then you want to decrease the contractility so it's not compressed the coronary artery so much. Remember, ischemia is the most common cause of arrhythmias. So HFpEF, beta blocker, all of them. What if you try to lift the weight before preload is overcome? That's how you get muscle strain. Overstretching or tearing a muscle. When the muscle is torn, it goes to a spasm, like I demonstrated for you, to keep the fibers together for proper healing. How do you handle it? Well, Bailey, look at that. Rest it, since overexertion caused it. Apply heat. Why? Because you got a spasm in that muscle. Heat will help denature, right? Relax it. And then NSAIDs, because it's painful when it's contracted that hard, and it must relax as if necessary. But notice, every treatment follows the physiology of the disease. That's why they call it pathophysiology. Folks, always talk out the physiology of a disease. Don't just memorize how to manage things. Because after a while, you're going to forget it all over. And then you got to go read it up about it all over again. All right, so muscle strain. Joint sprain, a sprain is a tendon or ligament tear. Because the muscle is attached to a ligament. So if you really overexert yourself, the tendon or ligament would tear right next to the joint. Rest it, because overexertion caused it. Ice compression, why? To basically constrict and squeeze that inflammation away from there. Because the inflammatory fluid, when it comes, enters the joint. Now your joint space is, the joint is pushed apart like that, and now it can't move. There's no room to move. So a sprain limits your mobility. So ice will help you. And then elevate the extremity. Why? To drain, let gravity help you drain the fluid out of there. Well, we're men. And as men, we're stupid as hell. We don't just sprain ourselves, we strain ourselves. We strain and we sprain. That's right. We always want to prove we're better than women, stronger than women, but we're dumber than women. And that's why we sprain and strain, right? So that means for the strain, what do you need? How to cope. For the strain, how to cope. Hot. For the sprain, then it's opposite, cold. How you gonna do both of them? That's how Icy Hot became famous. The only chemical on the market that gives you both. That's why Icy Hot is the #1 sports cream in the world, not just in America, the world. They came up with a brilliant chemical. Remember I told you it does endothermic, exothermic, constantly reacting with air. And you got hot and cold from the same cream. Yep. Now you know, folks. Hopefully now you understand. So Frank-Starling curve, it's going to take us into heart failure. You can't learn cardiac disease without learning Frank-Starling curve. Frank and Starling came up with a curve that said, you know what? Since we're talking about length tension curve, which I showed you earlier, as length increases, tension decreases and vice versa. They say, well, the length of the ventricular muscle is based on end diastolic volume. So where you had length, they put EDV. The tension of a muscle will determine cardiac output. So they put cardiac output where tension was, and they came up with this graph. The graph says, Amy, that as volume goes up, stroke volume goes up. That means cardiac output keeps going up. You follow? As EDV goes up, cardiac output goes up. Does that make sense to you, Lillian? Make sense to you, Kathleen? The more volume you got in that ventricle, the more cardiac output you have. That means the more you pull a rubber band, the harder it contracts. Everybody understand that? But you go up to a certain point. When you get to a certain point, you lose cardiac output now. Why is that, Amy? First question they'll ask. Gustavo, what do you think is the reason? No. When you get to a certain length, all of a sudden you lose cardiac output. Why is this length? Watch my hand. Here they are. They got a certain overlap. If you stretch it, shoot, it contract harder, trying to get back to the normal. Stretch it, shoot. And then one day you stretch it, you know, so active mice are now separated. That's why you start on heart failure. They're not even together anymore. That's why heart failure becomes incurable. I cannot cure it. Because once they separate, they don't come back together anymore. But you can stop it from getting any worse. Remember, that's why we're trying to make the life better so it doesn't get any worse. But you're not going to cure it. Everybody understand that? Once active mindset, the key is to prevent it. Don't let it happen. Okay, treat it vigorously. Heart failure is not the end of your diagnosis. Heart failure due to what? Remember, always keep asking why and how. That way you get to the lowest common denominator. If you fix that, then everything will be better. They'll live longer. Okay, so if you got heart failure because of anemia, then you need to transfuse them. And therefore they'll live longer. Okay, yes, Karis. Can you think of heart failure as cardiac muscle sprain? Yes, you can, because it's stretched out of shape. Yeah, so that means they're not contracting together anymore. So Frank-Starling curve, it's just heart failure, folks. It's the #1 disease in America, in the world, really, right? Remember, that's the most common cause of death for almost everything, except neuromuscular, then it's respiratory failure first, then heart failure second. All right, look at this, congestive heart failure. Congestive means dilated. Over 50% mortality in 5 years. This is no small disease here. It's 13% in 3 months, 33% in 1 year, 50% in 5 years. I mean, half of them are dropped dead already. That's the reason why you always got to ask yourself, why? Try to figure out why they're in heart failure and stop it. You got heart failure because of alcoholism. Then, Mr. Jones, we need to talk about stop the drinking. Smoking too much cocaine. Tommy, we got to stop this cocaine you're snorting, man. It's killing you. Okay? You got to always ask yourself, why? How did it happen? Because there's still another thing you have to treat if you want to stop this from getting any worse. Because if he leaves the house and still snorting cocaine, he's just going to roll in dead one day. Doesn't matter what you do, because he's still doing what's causing the heart failure. This is the most common Medicare diagnosis, no surprise to any of you, I hope. Muscle fibers overstretched. That's what you see in 90% of heart failure patients. Okay? You have a dilated ventricle. That's what you see in 90% of heart failure patients. If you have dilated ventricle on them, your EDV and ESV is both increased. Does that make sense to you? That make sense to you, Cynthia? Make sense to you, Angie? All right. Because of that, you have decreased contractility, which means cardiac output and ejection fraction are both decreased as well. You understand that, Mabel?
Sir, please, why is systolic volume increased?
Because the heart is not pumping much blood out.
Okay, yeah.
Yeah,
Thank
so
you.
that means the amount that's left is in systolic volume. So that means that amount is now increased. And then here
Okay.
comes the next filling. The next filling equals end diastolic volume. Well, you're adding to the ESV, so that means now that's increased too. They're both rising. That's why you start climbing that mountain. And sooner or later, you're going to reach that length where there it is, like the mice will separate. The person will just die. Yes, Anna. S3 sounds because of ESV, correct. We'll get to that. Yes. Because there's heart failure after an MI. Remember these numbers I gave you? At least 40% of myocardium has been lost when you go to heart failure after an MI. And ejection fraction is less than 45%. They will ask you for those two numbers. And 90% of the time is because of left coronary infarct. They will definitely ask you that. Besides going into heart failure after an MI, give me another clue for left coronary infarct. Jolita. I gave you a total of 3 last week.
Crackles?
No, not crackles. A clue that you got a left coronary infarct was my question. You gave me the answer to know his left side of heart failure, but that's not what I asked. Gloria, a clue that you had a left coronary infarct. Besides heart failure after the MI. Sandeep. Not being stable, it can be from right side too. I want those classic one I gave you, Karis. Sudden death, 85% of your myocardium, you're gonna die suddenly. Sudden death, or if you're not dead, you're going to heart failure. That was number 2. And then there was number 3, Matt. And so you gotta answer my question first. And he's not sure. B, third clue. No, not chest pain. All right, Justin. Yeah, recurrent ventricular arrhythmias. That's a lot of myocardium. You just made it ischemic. Those are 3 signs of left coronary infarct. I told you, gotta make sure you remember it. Who remembers the only clue for right coronary infarct, Lauren? Heart block, because SA and AV know that both the first 2 arteries right off that right coronary. That's why I showed you that so you can remember it. Because remember, it lasts a lifetime. But you got to make sense of it so the brain has a way to pull it back out. All right, so heart failure after an MI, folks. That's why we also put them on ACE inhibitors during the MI. Heart failure. I'm all about organization, so here's how you organize it, folks. Left side heart failure is what we see 90% of the time. That means if they don't give me any clues, you assume it's left-sided. Everybody understand? You don't chase the 10%, which is right-sided. That's not very common. But clues for that, crackles on lung exam. Crackles means atelectasis, and number one reason is fluid. Well, this is fluid in your lungs. So pay attention to the lung exam so that you know whether right or left started it. Management is completely different. All right, the clinical clues, they have orthopnea, which means they have trouble laying flat on their back. That's because fluid covers the entire lung. They feel like they're drowning. And they wake up suddenly short of breath. That's what PND is. Paroxysmal nocturnal. Notice nocturnal, dyspnea. What the heck was that? Okay, somebody's mic is on again. All right, so orthopnea and PND, a crackles on lung, the three best clues that you got left side heart failure. Right side of heart failure is 10% of the time. There's no crackles on lung exam. So all the other stuff is still there. So JVD, fetal edema, all that stuff. Enlarged liver, folks, that's why you gotta be clear. Is it left or right? Because when it's right side of heart failure, there's only one treatment. One treatment is called fluids. You maximize Frank Starling curve. This is what I showed you earlier. But in step 2 and 3 people, maximize Frank Starling curve so you get to a capillary wedge pressure of 18. So you guys are responsible for knowing the numbers. Step 1, they never ask you the number. They'll just say maximize Frank Starling activity. That means Frank Starling says more volume, more contractility. The left side is fine, so he'll take whatever volume reaches him and bumps into the body. So right side of heart failure, fluids is the only treatment. Why not drugs? Why not drugs? Man, which ventricle is larger? The left one. What percentage of the blood flow through the corneas goes to the left side? 85. So does everybody see, if you give them drugs, 85% of drug ends up on the left side? That's why drugs have never made a difference right side of the heart failure. Just so you don't talk yourself into, well, that sounds good, this should work. No, it doesn't work. They've already tried them all. 85% of drug goes on the left side. Well, that means hardly anything of it reaches the right side, so it's not gonna work. Okay? That's why fluids is the only treatment that we give. And fluids is the only thing that makes a difference to prolong their life. No drugs have. That means left side of heart failure is the one with all the drug management. We'll do that last though. So another way to organize heart failure, dilated versus hypertrophic. Now dilated is 90%, that's volume overload. Would that be more common in Black and Hispanics or whites, Gloria says? So why whites? Okay, why Blacks and Hispanics? No, not because they don't have nitric oxide. This is volume overload. Nitric oxide is not about volume. Let's see what Adnan says. Let's see what Matt says. Because Blacks and Hispanics eat more packaged food, the salt and as the preservative. That's what's killing us. As I told you, until they did the study with diuretics, mortality never went down for Black and Hispanics. The minute that dies out, all of a sudden, mortality dropped. That's because you finally treated the problem. That's why you always got to understand what is the problem to figure out what the drug of choice should be or the management of choice. You got to figure that out. Otherwise, you're just memorizing what some author says you ought to do means nothing. Because when you get the test, that author will say something totally different, but it follows the same physiology. But you're not going to know if you didn't learn what that physiology was. Okay? All right, so dilated heart failure. 90% of the time, volume overload, loss of contractility, low energy state for all the signs and symptoms. Look how much reading I saved you from. You ain't even gotta go read about it anymore. All right? Low energy state. Systolic dysfunction, now you know what that means. Loss of contractility. S3 is the sound for all the dilated hearts. And then it only has one phase that keeps getting worse till you die. Which means once you get an S3, your heart's never gonna snap back to normal. I can improve your symptoms, but it's not gonna snap back to normal. Hypertrophic, 10% of the time. This is a pressure overload. Increased contractility, decreased filling of the ventricle eventually, which is what I showed you. All right, so you get a diastolic dysfunction, which then leads to diastolic heart failure or HFpEF, preserved ejection fraction. S4 is what we hear with hypertrophy. And it has two phases. Physiologic is the athletic heart. Remember, physiologic athletic heart has a dilated, slightly dilated ventricle, but plenty of contractility, which is why a lot of cardiac output, and therefore resting heart rate is low. That's the athletic heart. And then pathologic is if you keep pushing it. Now it's gonna have to, hypertrophy coming inward like that, obliterate your own space. Now you don't have filling space. That's why they say diastolic heart failure. All right, question, Josh. If you drink a whole lot more water than your kidney can get rid of, what about it? Can you increase your risk of dilated heart failure? Of course you do. That's what happens in renal failure patients. So we tell them exactly how much water they should drink each day. Because if they do, they're making their own disease worse. Yeah. All right, treatment for heart failure, applying the Frank-Starling curve. Look at this. The first thing you do, get my oxygen. Who's that for? I said, yeah, that's what I asked. I asked you first. What? Who's that for? What organ? Thank you very much. Notice, folks, every time we say, right, but it's for the brain. Don't forget, I don't care what disease you got. Your brain is still my number one concern. I told you when doctors forget, all of a sudden people are dying all around them, they don't see why they're dying. That's because you're focusing on some other organ. The brain is first. Make sure that brain gets oxygen. The heart is 6 hours, brain only got 20 minutes. All right? All right. So what do we do for heart failure? Watch carefully. Physio. Get the fluid out of their lungs. Remember, they came in weak and short of breath. That's because they got fluid in their lungs, they're drowning. Get the fluid out of the lungs so they can breathe. So that's why I use furosemide. But there are 4 loop diuretics. Furosemide is one, torsemide is another one, torsemide, then there's bumetanide, and then there's ethacrynic acid. So why did we choose furosemide as a drug of choice for dilated heart failure? Number one is because it's a loop diuretic, but we got 3 others. There's gotta be more to it than that. Number 2, furosemide works even when you have renal failure. Zena knows what's the first organ to fail when you have heart failure. First organ to fail is the brain. I better change that in your notes. Oh, the girl, you just bounce around all over the place now. All right, Steve, tell her what it is. It's always a kidney. Now, make sure you got it straight. Now, I've never changed the answer. It's never changed. All right. That's why, since the kidney's going to shut down, the other 3 drugs won't work once you go into renal failure. Furosemide still gets the kidney even when you're renal failure. Just so it makes sense to you. Why do we choose that one? Otherwise, if they put one of the other loop diuretics, you say, well, yeah, let's use this other one. It's not as good as furosemide. Okay. Number 3, furosemide, when you get hearing loss, is reversible. The other 3 is permanent. The other 3 are permanent. Okay. And then number 4, furosemide dilates the pulmonary lymphatic channel so that you mobilize the pulmonary edema much faster. So 4 benefits of furosemide. So it wasn't just by chance they chose furosemide to be the drug of choice. The problem is furosemide does not decrease mortality, it decreases symptoms. Yes. Excuse me? The hearing loss is because they have sulfur. It's sulfur that causes damage to the cranial nerve 8, and then they lose hearing. Yeah. All right, so furosemide is the drug of choice to take the fluid out of their lungs so they can breathe. And then it doesn't make any sense if I diurese 1 liter off of you and then let you drink 3 liters for the end of the day. Now I'm chasing my own tail. Everybody understand that? That's why they say restrict sodium, restrict your volume intake. That's what's next. You got to have a net loss by the end of the day, or else you're not treating the patient. Anna. Because of the loop diuretic. Simply because loop diuretics are potent, that's all. Yeah, just that. And then the other 3 puts it above the other three that blue diuretics. Hannah, the last reason for using furosemide is, oh, wait a minute. Let me say hearing loss. Oh, it dilates the pulmonary lymphatic channel, so you mobilize pulmonary edema quicker. So they start to breathe better real quick compared to all the other ones. Everybody understand why we're restricting sodium and fluid intake? Got to make sense for you to remember how to do all this management when I ask you next time, or when you see a question, especially remember the whole thing. All right, now, the next thing is improve the heart's contractility. Because right now it's not doing so good. You need to increase the contractility. Now, if they're in the hospital, we like dobutamine and dopamine. Dobutamine is a pure beta-1 agonist. Beta-1 is heart rate and contractility, so that makes sense. But dopamine hits D1 receptors first. D1 receptors is renal and GI. You're gonna dilate those arteries. And then a higher dose is alpha-1. No, sorry, beta-1 first, then alpha-1. So beta-1 would be after that. And then alpha-1, that's only a high dose. That's why we don't use it. So in the hospital, we use dobutamine drip or dopamine drip. And dopamine now has a brother, philodopam. Philodopam. Look at the end, dopam. That's just short for dopamine. That's another form of dopamine. So they both do the same thing. Now, how do I know which one to use? Here's a physiologic way. Dobutamine is a pure beta-1. All it can do is raise your heart rate and contractility. So who needs the beta-1 stimulation? Somebody who has a slow heart rate. So if you got a heart failure patient with a slow heart rate, dobutamine is preferred. You understand, Zena? All right. But if your heart rate is already fast, then dobutamine is not going to help you. Wait, follow? If you're already tachycardic, dobutamine is not the answer. It's dopamine. So I look at the heart rate to decide which one to prescribe. Then the second clue is with dopamine, is if they got decreased urine output, that means the kidney's already been sacrificed. D1 receptors will resume blood flow to the kidney for you. Help you bring that kidney back to life before it shuts down. So I'm on call, and the nurse calls me, hey, that lady you admitted to ICU for heart failure or cardiac output just dropped to 2.3 liters per minute. Normal is 5 liters per minute. So she's in severe heart failure. And I just asked her, she just woke me up out of REM. And I said, hey, what's her heart rate? She says 48. Zena, which drug are you using? Why? Which one? Dobutamine. Why is that? Because I need to increase the heart rate. Dopamine's not going to help you. Right? It's the dobutamine, more direct. It goes right there, beta-1, increase heart rate, and then cardiac output goes up. Yes. Well, yeah, it's going to increase blood pressure because remember, cardiac output is part of blood pressure. Yeah, it does it by that route. If you have hypertension, no, it's not going to raise your blood pressure that much. Yeah, it's only going to raise it because it's low, not because if you have high, it's not going to do very much. Yep. So dopamine is preferred when the heart rate is high or the urine output is low. Everybody clear about that? Otherwise, dobutamine is preferred when the heart rate is slow. If your heart rate is slow after heart failure, which coronary got infarcted? Armando. If your heart rate is slow and you're in heart failure after an MI, which coronary artery got infarcted? How do you know left? There's more blood flow to the left? Not quite. Anybody know the clue? Bryce?
So the question was, I'm sorry, I think I missed the question.
How are you gonna answer it then? All right, so I said, if somebody has slow heart rate after an MI, which coronary infarcted?
So I would say the right,
Okay, why are you saying the right?
because the SA node is vascularized by the right coronary.
Yeah, because remember I said heart block is the first sign, is the best sign of right coronary infarct. Because if you're in heart failure, you should be tachycardic, not bradycardic. That's a heart block. That's just a nice sneaky way of showing you the person has heart. That means it's got to be right coronary infarct. Can't be left. Any questions on that? So in the hospital, you got dobutamine or dopamine. We're going to send you home on DIG. So let's talk about DIG. Digitalis has 2 axes. Most books only mention 1. I want to tell you both. Digitalis blocks the sodium potassium ATP by competing with potassium. That's its first action. If it competes with potassium, that's how to remember why hypokalemia is the #1 cause of DIG toxicity. Not that DIG causes hypokalemia. If DIG competes with potassium and you don't have enough potassium, that means DIG is going to win every contest. That means you're going to block too many sodium potassium pumps, and that contraction will be so strong to kill the patient. Hypokalemia. Again, the first action of DIG is to block the sodium potassium pump by competing with potassium. Second action of DIG, stimulate the vagus from the medulla. That's how it works for atrial arrhythmias, which I pointed out to you guys. But it doesn't really help you when you're exercising because your vagus is not firing during exercise. So DIG cannot protect you during exercise when most people get their arrhythmias. Any questions on the hypokalemia part? Hypokalemia, #1 cause of DIG toxicity. Hypercalcemia, #2. Why hypercalcemia? Because if you have high calcium outside, it's gonna diffuse into the cell by concentration gradient alone. That means already there's too much calcium inside, and then you get the patient DIG, who traps even more calcium inside. Well, you already know that's gonna kill your patient. Which part? The whole thing. Good morning, class, I'm here. Oh, okay. Hypercalcemia. You got high calcium. Calcium will leak into the cell by concentration gradient alone. You understand that? That means there's already too much calcium inside the cell before you even give the DIG. And then when you give the DIG, you're trapping even more calcium inside. And of course, sit on lysosome, kill a cell, we're dead. Yeah. So hypercalcemia and hypokalemia, the top 2 electrolyte causes of DIG toxicity. Not that DIG causes these 2 now. Be careful. All right. Yes, sir. We give them furosemide first. Won't that cause hypokalemia? Yes, it will, sir. That's why you have to watch the electrolytes. You give them something else, but they'll die. So which one are you gonna pick? No, don't pick that one. When death is the other alternative, do you really care about electrolytes right now? Yeah, the guy's about to die. He's drowning. He's literally drowning because the fluid's in his lungs. You gotta do something. You gotta get out of there so he can breathe. Life is more important. So we'll worry about the potassium later. Remember, when death is the other alternative, don't worry about the electrolytes. We'll correct it later. Yeah. Yes. No, the DIG can cause arrhythmias with these 2 electrolyte problems. So anyway, anybody remember the diuretics that cause low potassium and high calcium together? Anna? Yeah. The thiazides. That's why they always tell you never put DIG with thiazides together. That's just death waiting to happen. Okay, but as Sandeep just noticed, well, furosemide at least causes the hypokalemia, so it can still kill you. That's why they always say, watch the electrolytes. You know, that's what we check it almost every day while they're in the ICU. If that potassium starts to fall, you better give them a potassium bolus, get it back up. Okay, before they die from it. Eric, you have a question?
Yes, sir. Quick question. The hyperkalemia caused by DIG, is that because you are uncoupling sodium potassium ATPase with the sodium calcium transporter?
Yeah, but I haven't gotten to that. That's side effects of DIG. I'll get to that in a second.
Oh, okay.
I'm just
Sweet.
things that cause DIG toxicity right now.
Gotcha.
And these are 2 main electrolytes. Anna. Wait a minute, is it an incidental finding that what now? You decrease hospital stay? Oh yeah, that's because you're increasing concentrations to help the fluid get out of their lungs. but it's never decreased mortality. That's the problem. It decreases hospital stay, but it does not decrease mortality. So how do we treat this toxicity? It's called, it's monoclonal antibodies against it. It's called Digibind and Digifab. So Digibind and Digifab. So monoclonal antibodies will bind up your dig and pull it out, or the macrophage will just eat it up. Mayor, do you have a question?
Yes, sir. Please, sir, what do you say about thiazide?
I said thiazides and digitalis should never be put together. Because
Okay.
thiazides cause low potassium and high calcium, the very two things that cause dig toxicity.
Okay.
All right. Now, who was the young man that was as well as dig and hyperkalemia? We're going to talk through the side effects now. Who was that earlier? Was that Bryce or was that Walter? Who was that? Oh, now he's hiding. Okay.
Eric.
Thank you,
Eric,
President.
all right, Eric, so you go with me,
Oh.
we're gonna talk the side effects. Now,
Sorry
I'm
about
gonna
that.
talk it out, you can write it down if you want, but I like just talking it out. All right, so Eric, dig was blocked the sodium potassium pump. If you block the sodium potassium pump, I heard only one electrolyte across the membrane, who is that?
It's potassium.
Potassium's gonna leak in or out, sir?
It's gonna leak out.
It's gonna leak out, the cell's gonna become positive or negative.
Cell is going to become more negative.
More negative means it's gonna be more or less likely to be polarized.
Going to be less likely to depolarize.
That's likely to polarized, that's why when you first infuse dig, their heart can stop. The key is, I want you to be able to see the physiology for yourself. So you don't have to memorize any of this. I just talk to the physiologist, I can see all the side effects that's gonna happen. All right, so the heart can stop right after you start dig. Now, if you block that pump, Eric, who's trapped on the inside?
Sodium's trapped on the inside.
Sodium is trapped. Who's trapped on the outside?
Calcium's trapped on the outside.
No.
No, wait.
Sodium, potassium, ATPase is who we're talking about now.
Oh, yep.
There's no calcium there.
So potassium's trapped on the outside.
Potassium's trapped on the outside. That's how you get hyperkalemia as a side effect. So asystole, hyperkalemia, and then sodium gets trapped on the inside. Is that what you said?
Yes.
Will the cells become positive or negative?
Cell becomes more positive,
More positive means more or less likely polarized.
more likely to depolarize.
More likely polarized. Every membrane in your body uses sodium to polarize except two. Who are those?
Your thalamus,
Thalamus and
is it the adrenals?
atrium.
Atrium.
Adrenal. All right, so that's why there's 1,000 side effects after that. Because every member in your body can start depolarizing. They can call it cramps, seizures, twitches, agitation, whatever you want to call it. Those are side effects. It's pages of side effects. Okay, that's because membranes are depolarizing. Everybody follow? All right, now, if you trap sodium inside, eventually you trap calcium inside. And that's what we want. That's how you get the increased conductivity, which is what we use dig for. Everybody clear about that? You understand, Jess? The trapping calcium inside the cell is the dose we give. The dose that traps calcium inside, that's what we want. The problem is, if sodium and calcium trap within the cell, that calcium will start what two membranes depolarizing, Eric?
It's going to start your thalamus and your atrium from
There
to
you go.
depolarize.
Atrial start depolarizing, that's why you get atrial arrhythmias. Look it up. Remember, we're using dig to treat atrial arrhythmias, but atrial arrhythmias is what it causes, it's a side effect. Okay, that's why I told you, you're gonna soon just take it off the list, and I don't see the benefit. It's causing the very thing I'm trying to treat, okay, if you use too much of it. All right, and thalamus, if you have a seizure coming out of the thalamus, what's that called, Eric?
We said that is absence.
It's called absence. Absence seizure is a side effect. See? And if you got calcium trapped in the cell, who uses that calcium to contract, Eric?
From outside the cell, that's going to be
No, the calcium is trapped inside the cell.
trapped inside the cell.
Who's gonna use it to start contracting?
We said smooth muscle.
Yeah, smooth muscle the most, and then ventricles after that, right? So that's why you get diarrhea, hypertension, see that, polyuria, polydipsia, because your bladder keeps contracting, uterine cramps if you're female, see that? Folks, that's what I say, know your physio. Memorize a whole bunch of facts and you don't know the physio, where they got that stuff from, after a while, you're gonna forget it. Because holding on to things is a bunch of detail, that's too many items. Whereas if you see the physio, oh, that's how we get the, oh, now you see the whole list. Okay, now you see the whole list without memorization. All right, so we got sodium trapped inside, we got calcium trapped inside, we got a lot of side effects. In the old days, folks, they used to give DIG to the person had diarrhea. That was before we started doing DIG levels. They didn't have any way to measure DIG levels, but look what they did. Because once they have diarrhea, it means calcium is now trapped inside the cells. And that's why the GI is contracted. All right, Fatima, question?
So basically, at the onset of administration of drugs, people have less depolarization.
Yeah, less depolarization, the heart can actually stop. Sodium will go right into that cell right after, within seconds. That's why, you know, it's rare that we actually see the asystole, but it is possible. That's the key. Every now and then one does happen. All right. So side effects of DIG. Now, remember when sodium is trapped inside, membranes are depolarized, and that makes up thousands of side effects for you. Now, when sodium is trapped within the cell, Jess, another electrolyte will follow her in. Chloride, when the two of them are trapped in the same place, what will go behind them? Water, swelling. That's why if you look up DIG, papilledema, cerebral edema, pulmonary edema, peripheral edema, entropic changes, lymphatic dilatation, call it whatever you want. Those are just all swollen cells. Now you see the physiology. Okay, Andrews.
Explain with the calcium. I thought the calcium was inside. You said before that cardiac and skeletal.
Yeah, cardiac and skeletal muscle use that contraction, start contracting. Yeah, so will skeletal muscle. Remember, all muscles use intracellular calcium to contract. And that's, I just did smooth muscle first. Smooth muscles will use it, and now you got diarrhea, hypertension, uterine cramps, polyuria, polydipsia, is your bladder.
So all three have calcium inside.
Yeah,
Because
because of the way the drug works. Extracellular calcium is not what it's affecting. It's affecting inside, intracellular calcium. It does not affect extracellular calcium.
Yes, but what does that statement? Extracellular calcium.
No, we said before, when we do muscle phys, I said, skeletal muscle does not depend on extracellular calcium to do his intracellular calcium release.
Oh.
The other two do. Okay? All right, question, Anna?
You just said that,
If you have digitalis toxicity, you're gonna be in low energy state? I wouldn't say it that way because all the cells are gonna become positive. That's not low energy. That's too much activity. It's gonna put you to low energy state, but that's not, I wouldn't say it that way. Yeah, because it's gonna be based on increased activity. Just like if you exercise too much, you tire out, but that's not the original problem. All right, so that's digitalis. Any
Excuse me,
questions?
sir.
Yes.
Please, I was lost from the point is, when you say that calcium, when calcium is trapped into the cell, you start mentioning about smooth muscle, diarrhea. I don't understand from that point,
Yeah,
sir.
because the muscles that use calcium to contract, right?
Yes.
You understand that line? Yeah, smooth muscle
Yes,
needs
sir.
it the most. That's how you get the diarrhea. That's GI smooth muscle. Hypertension is blood vessel smooth muscle. Polyuria, polydipsia is your bladder smooth muscle. Uterine cramps is uterus smooth muscle. All I did was just go throughout your body and make all the smooth muscles start contracting. You understand that?
Yes.
Yeah. That's where they get side effects from, folks. Side effects is a physio you're gonna get, but I don't want it. That's called a side effect. The physio that I'm gonna get that I want, that's called the effect. That's the one I want. Trapping calcium inside the cell, that's what I want. But everything that happens before that and after that, I don't want it. But they're still gonna happen. That's why they're called side effects. But that's how you get them. You learn the physio instead of, don't memorize a book listing off a whole bunch of things. The physio, the action is the shortest way to remember all the side effects. Okay? All right, finally.
Yeah, excuse sir. Excuse sir.
Yes,
So
ma'am.
does it mean that when calcium is trapped, that the smooth muscle and the ventricle contract?
Yeah, that's correct.
Okay.
Yeah, that's how you get atrial arrhythmias and increased ventricular contractions that could actually kill the patient. Jess? Seizures with hypoglycemia, okay? No, so explanation of seizures with hypoglycemia. If you have low sugar, that means the cells won't get enough sugar, right? What do the cells need with sugar? What do they do with it? Energy. That means you don't have enough ATP, correct? What that means your sodium potassium ATPase won't work. Everybody following this? There it is. Stop it. Sodium gets trapped inside. There's your seizures right there. That's why I said always connect it back to basics, folks. Saves you a ton of reading. Otherwise, you got to go read about everything they ask you. You got to go read another book about it. Okay? And it's still about something basic. You just didn't realize that's where they're getting all this stuff from. All right, increase TPR, ACE inhibitors. Let's talk about how to decrease TPR. First of all, how do you increase TPR in heart failure? Well, Nolan, if you have decreased cardiac output, that means decreased flow to your kidney, right? Decreased flow to your kidney equals renin, angiotensin, aldosterone. Everybody see the physiology of hypertension? Why do you think all these drugs we're using is to block that stuff? All the drugs. Because renin, angiotensin, aldosterone is the reason for the hypertension. Angiotensin 2 specifically, if they want to one answer. All right. So how do we do this? Well, the lead drug now is called sacubitril. You guys remember this now? Sacubitril with an ACE with an ARB combination. Sacubitril, anybody remember sacubitril, what it does? I mean, yeah, it blocks the enzyme neprilysin, which normally breaks down AMP. So AMP stays higher, and therefore it dilates the afferent renal artery, so all that extra volume goes straight to the kidney to be peed away. Understand that, Cynthia? Understand that, Rachel? That's why sacubitril was better than ACEs or ARBs. I did it by 20%. That's a large number. All right, so remember, that's now first line for dialytic heart failure. And that means ACE and ARB combination, or any one of them, is now second line. Next thing you do, spironolactone. Then he has a brother now, eplerenone. What these do, they block aldosterone receptors. Because remember, with low output to the kidney, high aldosterone. Remember, the heart takes up aldosterone because it's fat soluble, which then leads to more inflammation and scarring. So blocking that will decrease mortality. Josh. Well, ACE and ARB, not together. Yeah, together it's contraindicated. By themselves, yeah, you can still use it. But sacubitril is first line. You always start with that. All right, so spironolactone blocks aldosterone production, decrease mortality for that reason. Less for the heart to take up and scar with. Spironolactone also blocks androgen synthesis. Why? He's the lead drug for hirsutism. Blocks androgen synthesis. Lead drug for hirsutism. But that's how he causes gynecomastia. And then he also blocks P450. If I block your P450, what happens to your warfarin levels, Lawrence? Increase. Remember WEPT, I gave you that list last week. If you do anything P450, you gotta know it. It's about one of those 5 drugs. So spironolactone. Beta blockers. That means when the blood pressure allows, beta blocker. Right? And then, of course, there were 3 that I told you decrease mortality. Paul, do you remember their names? The beta blocker that decrease mortality? Metoprolol was one. Zena? Napropanolol. Steve? Hannah? And not labetalol. Carvedilol. Now be careful, only one gets a point, the other one gets nothing. It's carvedilol, bisoprolol, and metoprolol. That's the only three. With multiple articles showing decrease in mortality. All right, then there was nitrates. Nitrates in blacks, but nobody else. Why only in blacks? Same thing. They have low what? Yeah, nitric oxide level, very good. Because what's the nitrate gonna do? Raise your nitric oxide level. Yeah, look at that. So that's why it actually decreased mortality by 43%. I was shocked when I read the article. I was like, what? I had no idea it was that large. The other one's like 20s and 30s, 43%. So that means if you got a black patient heart failure, that should be one of the first drugs you gotta think about putting them on. All right, so keep your trail is still a lead drug though. Okay. And then if they're qualified, you put an ICD, implantable cardiac defibrillator. If their ejection fraction is less than 35% with symptoms, ICD. That's because their death rate from arrhythmias is so high. If the ejection fraction, if they have no symptoms, ICD anyway. Yeah? Implantable cardiac defibrillator. Yeah. That way, in case you're out at Walmart and all of a sudden VFib starts, it'll shock you for it. It'll shock the heart for you. So these are all the drugs that help out. And then there's one more that they've let on the market, but it doesn't decrease mortality. They're vasopressin receptor blockers. Tolvaptan, notice it's got VAP in the middle, and conivaptan. They block ADH receptors. Where are ADH receptors in the kidney located, Akshay? Where? Yeah, collecting duct of the kidney. That's the V2. Remember, V1 is on blood vessels. So if you block that, what happens? You pee more, pee less, Akshay. You pee more. Remember, all the electrolyte disorders that they have is dilutional. Pulmonary edema, all the extra water they're holding on to. So this is one way to decrease that water that they hold on to. But what they find in the study was a big study. Their initial aim was to decrease mortality, but they didn't. So it was a failure by that. However, they showed three huge benefits, which is why they're bringing them out for that. Number one, it normalized their symptoms. It diluted the water so fast, their symptoms went away real quickly. Number two, it means they got out of the hospital faster. Billions of dollars are spent keeping people with heart failure in the hospital. Imagine if you get them all out faster, saves the economy billions. That's why they wanted to come on out. But just so you know, it did not decrease mortality. Third reason, it normalized their electrolytes faster. Remember, all the hypo that they have, hyponatremia, hypokalemia, is dilutional. So if you diurese all that water, it goes back to normal. The three benefits, but one of them was not that you live longer. So there you have it, folks. All the drugs that decrease mortality in heart failure. So that means if you have hypertrophic heart failure, what drug would decrease your mortality, Angie? Man's Rachel. Man, Syed. Man's Mamita. How about Leslie?
Beta blockers?
Only beta blockers. Hopefully you guys got this stuff down in your notes now. I just told you 5 minutes ago and everybody forgot already. So if you got a hypertrophic heart, there's only one drug, beta blocker, that's it. If you got right-sided heart failure, only one thing prolongs your life. What is that, Anna? Fluids, that's it. Medications never made a difference. All right, but if you got left-sided heart failure, that's why you got to know the long list. It's only when it's a dilated left-sided heart failure, then you got to know the whole list. But there it is, folks. Every type of heart failure there is and how to manage each one. MI, completely updated for you, how to manage every aspect of it. No guessing, folks. You definitely got to study this lecture, I'm telling you, because this is worth a ton of points. when chest pain is one of the most common questions you're gonna be facing on the exam. And they're not gonna let up. That's the #1 disease in America. Why would they let up? All right, so all they keep doing is put more and more, and yet it's still a lower score nationally. SGLT2 decreases cardiovascular events. Hasn't shown a decreased mortality yet, but that's what they're hoping it will do. Yeah. Yeah, so cardiovascular events, I've already seen that question on UWorld, so I told you, these guys are very up to date on UWorld. Yeah, but the question was, which drug decreases the risk of cardiovascular events? And that's the exact endpoint that they had. They didn't decrease mortality. All right, Mabel, you have a question?
Yes, sir, please, when do we use ICD?
We use ICD. I said if your ejection fraction is less than 35% and you have symptoms, or if your ejection fraction is less than 30%, even if you don't have any symptoms. Because they have a high death rate from arrhythmias. So you want to protect them. Catch all that, Mabel?
Sir, yes, sir, thank you.
All right, no problem. All right, folks. Just a quick review. Take our break here. Why choose furosemide? I want to make sure you guys have not forgotten important things I went through. It's a loop diuretic. It works even in renal failure. It dilates the pulmonary lymphatics, and hearing loss is reversible. Dobutamine is a pure beta-1 agonist, increases heart rate and contractility, used in heart failure with bradycardia. That's usually right-sided MI. Dopamine phenoldiprem binds D1. So if you got decreased urine output or you got tachycardia, then use one of these two. Okay? So use for that instance. Digitalis competes with potassium, blocks the sodium potassium pump, stimulates the vagus nerve from the medulla, increases contractility, but does not protect during exercise, which is why they want to get rid of it altogether. But right now, we're still using it. Digitalis toxicity, hyperkalemia, hypercalcemia, treat with Digibond and Digifam. Side effect is Dig, I gave you a whole bunch. All right, so now to decrease TPR, these are the drugs we just finished listing. And tolvaptan, conivaptan are just new on the market because they decrease symptoms, decrease hospital days, and normalize the electrolytes faster, but they don't decrease mortality. And let's take a break. Now go through the neuromuscular diseases with you. All right, start back at 10:50. Okay. What? Who in there? Yeah, that's. Read email while I'm like. Okay.
Less than 30%, yeah, just less than 30% one standard, and then another thing is medication that you use it either. And you see less than 30%. Or. Or Okay. No, I wasn't gonna say, no, that's what I was gonna say. Did you, were you dead on Friday? No. I kind of died. Yes. Yeah. That's okay. Oh, okay. Nothing is wrong with the technical here. All right. We didn't know it. Wait, can you charge your body? Yeah, I'll. Oh, I don't. Yeah, I'm pretty sure. Right. I don't think I was online. No, I have a charger in there. You would see the charger? No. Ah, okay. That's one. Oh, yeah, not the one. Okay, yeah. Oh my God, so. Me llevo. Okay, bueno. Good. Yeah, I'll give you one link. Yeah, I'll give you one. Okay.
Well, we'll check out some comments. Right, you're kind of a block away from the ocean. No, it's not just. You know what I'm saying? No, it won't. Giant frame. You only do it during afternoon. Why is that? No.
Yeah. When I see you're now, just start laughing. We found out from here. No, he's perfectly there. Found out. Hey, you don't leave. I forgot, someone told me this story. Oh, one is suspected. Good man. I'm dying, bro. Let's go to sleep in great space. Happy, bro. I'm already betting on. Let me tell you what I'm saying. I ain't know what it is. That's why I'm sticking back. It's all about getting kids like this. Sterile continuous
A school state champ.
I bet on the Bengals, 4 state championships. I bet on the Bengals. I don't know anything about football. I bet on Bengals. Yeah. I bet on this stuff was today. The guy that owed money.
Yeah.
Hey,
Where
doing? Yeah. How you doing? I don't know.
And saw you were online earlier this morning. Want to check in my money? How you doing?
Oh, okay. Yes, you get this.
Yeah, they'll jump more done.
Yeah, but I'm not. That's all of it.
She graduated. No, no, they told me that they were. She was. years.
That's close.
Let's try to get the. Then again, she. Literally, they call it. Thank you for the acceptance. That's the thing with.
Anytime you find more.
All right, let's go. Neuromuscular diseases and their clues, folks. The most common presenting sign for neuromuscular disease, Zena, is what? The most common presenting sign for neuromuscular disease is what? Sign? Bailey, help you out with sign? This being tachypnea. Symptom. Zena. We can show the bed. Infections, Zena. Huh? Yeah, infections. All right, Bailey, reminder, infections are going to be found where? Pulmonary and UTI. What's the most common cause of pulmonary infections? Bacterial. Strep pneumonia, followed by H. influenza, followed by Escherichia catarrhalis. If they want most common overall, virus, which virus? Adenovirus sounds good. If they want UTI, most common bacterial cause UTIs? E. coli, followed by Proteus, followed by Klebsiella, postcoital. Saprophyticus, nitrite negative. Enterococcus. They want a virus. And a virus again. So folks, the profiles are exactly the same. The only difference is when they say cause of death. Remember I said respiratory failure first, heart failure second. That's the only time you gotta remember. Heart failure is not number one, it's number two though. I hear you. Is the clue. Here it comes, folks. That's all I got is clues for you. No long stories. Here we go. Inflammatory myopathies. That's what I know. How do I know they want this one? High SED rate. Give me a high white count. Myoglobinemia. Notice a bunch of muscle enzymes. I just put down a phone. AST, ALT, aldolase, CPK. They can put whatever they want on here. Because once I see any one of those, remember, all I got to do is see one. I don't need 5 of them. Just one. That's, oh, they want one of inflammatory myopathies. Then I go down the list. Myositis, one muscle hurts. Ouch. There it is. I squeeze one muscle, you say, ouch. Okay. Polymyositis, I squeeze 3 muscles, you go, ouch, ouch, ouch. Okay, sounds good. There it is. But they don't stop there. They usually ask you, what's the underlying cause of this patient's problem? What's the most common cause of myositis and polymyositis? Abigail. Oh, it's not viral. I gotta share Mountain Dew with you in the morning, man. Yeah. Okay, coming up that weekend, let's do a drag a little bit. Hey. All right, what is it? Let's go with Amy. Hypothyroidism. We just did this a little while ago. Hypothyroidism. They always ask you underlying. That means you got to figure out what it is and then know what causes it. So my hypothyroidism in a newborn, dysgenesis or agenesis. In America, Hashimoto's, TPO is the best antibody. Worldwide, iodine deficiency. If they want a parasite, read. Trichinella spiralis, if you be eating raw. Bear and Tenisola, if you be eating raw. Or there it is. If they wanted autoimmune, Maria, they'll give you what marker? JO1, transfer RNA synthetase. All right, very good. So they're always asking the underlying problem. That means you need 2 steps to get it right. Okay, it's not just so straightforward. Dermatomyositis, says derm. You got a rash that goes with it. That rash is a heliotropic rash, and some guy put his name on it. Chris with a C. Gotron sign. Heliotropic rash, red rash, violations rash, on eyelids and knuckles. And then it's associated with an internal what? Dermatomyositis is associated with internal something. Internal anguish, internal. Internal cancer, don't forget. And the most common cancer associated with this, Gloria, is what? Colon cancer, if they ask. Dermatomyositis. Fibrositis says the muscle insertion hurts. When I squeeze the muscle, no pain. When I ask you to move it, now it hurts. That's how I know it's fibrositis. Easy physical exam finding, folks. Doesn't hurt when I squeeze it, but when you start moving it, now it hurts. That's how I know it's the insertion that's hurting, not the muscle itself. Fibromyalgia says they're both hurting. They're both hurting. How do I know that? When I squeeze your muscle, you go, ouch. When I ask you to move, you go even more, ouch. That's how you know it hurts all the time. Fibromyalgia, they're in pain all the time. Fibromyalgia is a lot more common than we thought it was. I've got a family member who has it. She has bad attacks from time to time. Fibromyalgia, they have tender trigger points. That's the best clue. They can tell you, yeah, these 5 places, if you touch it, they scream like you just slapped them. Like so many physicians, we thought they were faking it. This doesn't make any sense. All I gotta do is touch your skin with my finger, and it feels like I slapped you. So one doctor did a very good study. What he did was get volunteers and inflicted pain on them, and then recorded what their brain perceived. Must be medical students who needed money. Right? He volunteered for this. So, you know, stick you with needles, stab you with a ruler, that kind of stuff. But the worst pain was hit your finger with a hammer. Okay? And then he had EEG probes on your head to see how your brain was perceiving it. After he did that, then he brought in the fibromyalgia patients. And he mapped out their tender trigger points. And then he touched one of those tender trigger points and saw what the EEG machine recorded. It was equivalent of smashing your finger with a hammer. That's what convinced me that these guys, they're not faking it. I thought they were faking it. This doesn't make any sense. Anyway, so the term they now use is called hyperesthesia. That means increased sensitivity. Hyperesthesia. Tender trigger points. So for that reason, what do they need? Physical therapy. Why? Because muscles atrophy if you just lay around and do nothing. That's what these people want to do. Sit in a lazy point and never move. The problem is they're going to die faster if they sit around and do nothing. As well as get DVTs. It's not good. So you got to really impress upon them the importance of exercising every day. But they look at you like you're loco when you say exercise every day. So anyway, the best and least traumatic exercise for you is water exercises. All the YMCAs, YWCAs have swimming pool exercises for fibromyalgia patients. I got a buddy who teaches 2 classes every week. That's how common it is. All right. So hyperesthesia, put them in water. That way they can bounce up and down and do the exercise, hardly any trauma to the body. And then the cool temperature water feels good in those areas too. Anyway, that's fibromyalgia. Polymyalgia rheumatica, notice it ends in algia. That means sore versus itis, which means inflamed. Polymyalgia rheumatica is clustered primarily in the shoulder girdle. That's the best clue. They'll be complaining about primarily your shoulder. How do I know that? Oh, when it comes time to lift their arm above their head. Oh, it hurts so bad. So reaching up in the cabinet to get something out, it hurts. Comb their hair, put on makeup for a female, it hurts. They just don't like it. To lift their arm above their shoulder, they don't like it. It's too painful. So polymyalgia rheumatica. And then women with polymyalgia rheumatica have a higher incidence of temporal arteritis. What the heck is temporal arteritis? Temporal arteritis, Cesar, is a granulomatous degeneration of your temporal artery. What cells are involved? Macrophages and T cells are eating your temporal artery. Okay. And obviously, when you have that much inflammation, the Z rate will be sky high. Sky high. Okay. Now, if I see a middle-aged female who's got temporal artery pain, she probably has polymyalgia rheumatica as well. They go hand in hand because it's rare to see temporal arteritis in a middle-aged female. All right, just so you know, they go together. Temporal arteritis has a rule of 60s. 90% of cases occur after age 60. That's why you don't see it in 30-year-old females. All right. 90% of them have Z rate higher than 60. So very pronounced. And you need at least 60 milligrams of prednisone to treat it. That's how severe it is. Doggone it, but I heard that steroids have 5 anti-inflammatory actions. I should have studied it this weekend. Somebody gotta help me out. Man, oh man. What? Subanos? Oh, that's good. Suba knows real well. That's why Karis is gonna share the list with you. Yeah, that means Suba already shared it with you. So now you get to share it with us. All right, all right. Break it down for me then. Inhibits phospholipase A. Kills T cells and eosinophils. Not macrophage.
That's why she joined.
Okay. Second I.
Inhibits mast cell.
No, I is for inhibit macrophage migration into the area. S is stabilize mast cell membranes. And the second S, stabilize endothelium, right? And then we have physiologic action, breaks down proteins, turn amino acids into sugar. All right, so temporal arteritis. The number 1 complication, blindness. If you let that granuloma enter the ophthalmic artery, the person is blind. So their presentation, the presenting symptom decides how you manage it. This way, if they present with just temporal headache, is you do a temporal artery biopsy first, then treat them with steroids. Which confirm before you treat. But if they have visual problems, you need to get steroids in there real quickly, or else they're going to be blind. That's why they say give them IV steroids right away, and then do the temporal artery biopsy next day. Melt that granuloma as quickly as you can. And what's the name of the IV steroid that I need to know, Steve? IV steroids. What name is that? And let's ask Fatima. Methylprednisolone is correct. It's Fatima. She's All right, very good. All right, any questions on these? So again, notice just 2 or 3 words that gets the point, folks. I'm telling you, don't try to become an expert at every one of these because they overlap. That's why I'm not talking about all the other stuff. Use low energy state. You can figure that out. But then how do you make the diagnosis? 1 or 2 words. That's all I need. All right, because I don't want to be lost in the vignette. And you're gonna be lost in the vignette if you try to know too much about it, any one of these. All right, next one, muscular dystrophies. That means genetically passed on. First one, Duchenne's. Duchenne's is the most common, has what they call Gower sign. Gower sign is when mom notices when this kid is sitting on the floor and you ask him to get up. Most kids would just get up like this. But Duchenne's attacks the hip girdle. So they can't just get up like this. So what do? They crawl up their own legs. So you see them crawling up their legs and their thighs and then till they stand up like that. No more child doesn't do that. But that tells you that the hip girdle is so weak, they're using their legs for support as they climb up their legs. That's Gower sign. And waddling gait is this move they do, transfer their weight onto the hip. So since they can't just walk straight and keep their torso straight, they transfer their weight onto the hip socket like this. So they stand like this. And then when you say, come over here, Johnny, you see them start waddling. See that? They just start swaying. Their bodies goes to the one socket, transfer to the next socket, and that's the only way they can walk. They can't just walk straight ahead anymore. All right, so those are 2 very classic findings in Duchenne's. Pseudohypertrophy of the calf is another one. It's just a nice way of saying you have fat calves or fat ankles. Pseudohypertrophy is really full of fat. Why? Because the muscle in your legs are atrophied, so the fat just fell straight down. That's just my way of visualizing it. Because they love to ask you, if I were to biopsy that ankle, what would you see? Just fat infiltration, that's it. That's the same thing as when you saw earlier. Miss Abigail, what disease were we talking about when that happened? I know he loves me, but he's punishing me today. Okay, I'm trying to let you recover, but okay. I was about to say, I'm gonna leave you alone for the rest of the day. I can just tell it's not your day today. All right, Maria. Gaucher's, remember Gaucher's, that early last night, same thing. Fatty infiltration of their ankles. All right, so this is leave Abigail alone day. All right, so Duchenne. Somebody say something? Oh, I thought I heard one. Okay, dystrophin is the protein. So Duchenne's, dystrophin. What disease you think of when you hear fibrilin? Mabel? And Mabel's not there. Brenda Rivera.
No, Mabel is there.
Oh, maybe you got to say something when I call your name.
I'm sorry, sir. I have a.
Fibrilin, what disease?
Is what?
Is what?
What's your question, sir?
What disease associated with fibrilin? When you hear fibrilin, what disease do you think of?
Like fibrilin, like I don't understand the English. English is the problem here.
All right, here it is. I'm going to write it for you.
Okay, sir.
All right,
Yes.
here we go. Whenever you see this, what disease do you think about?
Okay, this corrugate, this dystrophy, this Duchenne woman something.
What the hell are you
Duchenne
talking
muscle
about?
dystrophy. So it can be Marfan syndrome or Duchenne muscle dystrophy. Is it?
So which one is it? It's only one.
Okay, I'll go with Duchenne muscle dystrophy.
No, it's Marfan. Dystrophin. Dystrophin.
Okay.
is Duchenne's right here.
Okay.
Okay, fibrilin is Marfan.
Okay.
I'll give you one more chance. What about spectrin?
Spectrum.
Spectrin.
Spectrin. So no idea.
All right.
But I have an idea initially. Remember? At least I mentioned Marfan. It's not easy, man.
Okay, I have no idea what you're talking about, but do you know what disease goes with spectrin? Gloria. Not Ehlers-Danlos. Zava. Hereditary spherocytosis. All right, folks, be on your toes. We only got 2 weeks left. Now, you know I'm going to drill you as we go. You gotta show me you remember the stuff, okay? So you guys have had plenty of time to just drill it, study it. You got it, at some point in time, you gotta know it. All right, so anyway, dystrophin is a protein for Duchenne's. This one's X-linked recessive. Remember I told you, they always talk about the maternal uncle or maternal grandfather. They don't say X-linked. You just gotta know when they say maternal uncle or maternal grandfather, it's X-linked. And onset of Duchenne's is before age 5. If it's the same disease, Reed, and the onset is after age 5, then we say Becker's. Now, the question they'll ask you, Reed, is how do you explain Becker's? Would it be a missense, nonsense, or friendship mutation? How do you explain late onset diseases? So again, there's all the stuff I taught you guys. In case if it shows up, you gotta know how to explain it. Yes, that's the answer. Stop tightening up your neck like that, girl. Come on. Trust what you think. Yeah, remember, missense is a mistake. All right, so that's why the protein works for a while and then it finally fizzles out. That's why you get late onset. The early onset is always frameship and nonsense. I showed you guys that. Okay, that would be Duchenne's. I've seen that question like 3 or 4 times. Okay, but Becker's would be missense. Myotonic dystrophy. Myotonic means increased muscle tone. Increased muscle tone, Josh. How do you know you got increased muscle tone? All right, number 1, when you shake their hand, they have a hard time letting go. All of a sudden, big time spasm. And then you, they say, hold on, doc, hold on a second. Then you got with the spasm break, and then they let your hand slide out. So you can make the diagnosis with a handshake, folks. You don't need to run any tests on them. Myotonic dystrophy. Second clue, trinucleotide repeats. Remember this one of 5 with trinucleotide repeats. Third clue, attacks facial muscles primarily. So the person's face will be just worn thin. And the nose will seem like it's standing out. That's because all these muscles are atrophic. So prominent nose, they'll say bird's beak appearance. And that's what that means. Myotonic dystrophy. Okay. Item. The handshake, when you shake, they'll talk about when you shake their hand, they have a hard time letting go of you. Or when you tap their reflexes, that thing goes in spasm and then just pauses up there. Trinucleotide repeats, and the third one was facial muscles get worn out first, and the bird's beak appearance reflects that. You understand, Abdullah?
Yes, sir.
All right, Sheena Kapoor, you understand that?
Yes.
All right, good. Elizabeth, Shalakis, you understand that?
Yes.
All right, very good. All right, so that's these 3. Other neuropathies, Guillain-Barré syndrome. In Guillain-Barré, it is autoimmune. Autoimmune attack against peripheral nerves only. Autoimmune attack against peripheral nerves only. Second clue, 2 weeks after a URI, usually gastroenteritis. 2 weeks after gastroenteritis. If they want a bug associated with it, Jess, what bug you picking? Campylobacter is the most common bug associated with GBS now. Yes, sir.
I don't understand why, because that's like a GI bug, isn't it? So why upper respiratory?
No, URI, it starts out with up here and then crawls into the GI tract. So-
Campylobacter does?
No, any URI. You can start out with a URI, then you go in the GI tract. Just like adenovirus starts up here and then ends up in the GI tract causing gastroenteritis too. Yeah, so it's just a Guillain-Barré is more associated with Campylobacter. That's just the latest connection. Before that, it was a flu. It was all URI. There was no gastroenteritis associated with it. It's just a Guillain-Barré. All of a sudden, a bunch of Campy infections popped up. That's when it took over. All right, anyway, so Guillain-Barré. 2 weeks after a URI or gastroenteritis, Campylobacter is the bug. If they want a bug, you get ascending paralysis. So it starts with the legs and works its way up. Ascending paralysis starts at the legs and works its way up. Next, it is symmetrical. So it never jumps around. It's symmetrical on both sides too, just going up the dermatome, straight up. And if you got something crawling up your dermatomes, what do you think is the most common cause of death for that person? Justin. Cesar. All neuromuscular diseases, Justin. Still respiratory failure first, heart failure second. But see, if I can catch you, I can put a detail in your head, and that's what you heard me say. instead of the profile you just heard me say for all of them. Just want to make sure you guys are not forgetting these things. Otherwise, the questions start looking hard again. All right. All right. So anyway, you got Guillain-Barré. Guillain-Barré is the only autoimmune disease that does not respond to steroids. Just get you prepared. Now, later on, I'll talk about managing for all of these, but this one does not respond to steroids. That means you go to the second step when I get to it. Next one, diabetes. Glove and stocking distribution. You've heard that before. Glove and stocking distribution, diabetes. And what's the chemical that causes all the neuropathies of diabetes? Nate? Let's ask Anna Suji.
Is it sorbitol?
It is sorbitol, created by what enzyme, Ann?
Aldolase reductase.
Aldose. Now, there's an
Aldose.
aldolase, that's a different enzyme. Aldose
Okay.
reductase, very good. All right, so diabetes, sorbitol, for galactose was galactitol, but it's still the same aldose reductase. All right, so neuropathy, diabetes. All right, syphilis. First of all, occurs only in tertiary syphilis, not in primary or secondary. Attacking one nerve at a time, you get shooting, stabbing, lacerating neuropathy, for which the drug of choice, Nicholas Prussian, is what?
Syphilis. Oh, I'm blanking.
All right, Rashad.
Carbamazepine.
Carbamazepine, that's how carbamazepine made his name, was in syphilis. Shooting, stabbing, lacerating neuropathy. Only drug that treats it very well. All right, and then in the brain, you get Argyle-Robertson pupil in the eyes. They call it syphilitic eye, remember, prostitute's eye? She accommodates, but is slow to react. You can actually diagnose it in your office. All right, the way you do it is this. Let me give you normal first. If you shine a light in my right eye, both pupils will constrict immediately. Let me make sure they can see me online. Right? I always gotta remember that. Hang on. Oh, there we go. All right. So if you got normal pupils, every time you shine a light, both pupils will constrict like that. All right. Shine a light to the other eye, just swing the pen light over, and they both will be going in, just immediate. No lag whatsoever. That's what happens in a normal person. If you got Argyle-Robertson pupil, I shine a light in both pupils, they both constrict like that. Then you quickly swing it to the other eye, you'll see the eye is still dilated from the last response, and then it goes down. See that? That's a lagging response. That's never normal. There's no lag in a normal response, okay, in a normal person. So syphilis, you can diagnose Argyle-Robertson people right there in the office. All right, then myasthenia gravis versus Eaton-Lambert syndrome. First of all, myasthenia gravis, middle-aged female who gets weaker as the day goes by. That's the key. She's fine in the morning, but by evening, she's complaining about weakness. I had one young lady, 30-something. She said, I wake up in the morning, I feel just fine, doc. By evening, I'm slobbering out of the corner of my mouth. That's because the muscles getting weak. That's what you expect. It's always at the end of the day that they feel the most symptoms. Myasthenia gravis is autoimmune. Autoimmune. Okay, but it's autoimmune attack against acetylcholine receptors. So postsynaptic acetylcholine nicotinic receptors. If they want a tumor associated with it, and they usually do, thymoma is a tumor that's associated with almost every autoimmune disease except Graves. Thymoma is a tumor they want if they ask for a tumor associated with it. Myasthenia gravis. Compare contrast, Eaton-Lambert. Remember, they're using Eaton-Lambert now most of the time. Why? Because myasthenic syndrome usually gets students confused with myasthenia gravis. The only thing that they had in common was the word was similar. That's it, nothing else. Eden-Lambert syndrome, remember, small cell carcinoma of the lung, malignant versus benign. With small cell carcinoma of the lung, you got less than 6 months to live. Thymoma, you got the rest of your life to live. If you got less than 6 months to live, what should I offer you? Rashad?
Hospice.
Yeah, hospice. Remember, we discussed the criteria for hospice care. Muhammad Khan, you had a question.
Yes, sir. I had an unrelated question. Sir, in Guillain-Barré, you described there's ascending paralysis.
Yeah.
I think we went through another disease that had descending paralysis. Can you remind me what that was?
We're coming to it soon. It's coming up.
Oh, okay.
Don't worry. Yeah, no
Oh,
problem.
Thank
All
you.
right, so Eden-Lambert, small cell carcinoma of the lung, something the cancer produces. If you remember, poisons the sarcoplasmic reticulum, making it slow to sequester calcium. And therefore, calcium builds up in the cytoplasm, so contractions get stronger, 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 stronger. So they actually get crampier as the day goes by. Notice the opposite myasthenia gravis. That's when they realize it's just that students getting the two words mixed up because they got nothing in common. They get crampier as the day goes by versus weaker as the day goes by. And then remember, then they found a subset where the toxin poisons the presynaptic calcium channels. They're the ones who look like myasthenia gravis because they get weak all day long, not just at the end of the day. So, for myasthenia gravis, what do you have to do? First, you gotta have to diagnose it. Well, there's a cheap way to do it besides using these drugs. The cheapest way to do it now is called the ice pack test. We just take a glove, put a bunch of ice in there, and then you put it on the arm, like on the forearm, wait about 3 to 5 minutes, and then all of a sudden it starts moving. You give them a 1 pound barbell, and they're surprised. Oh my God, it's moving real. How'd you do that, doc? Well, all you did was vasoconstrict. That means fewer antibodies came in here to attack the receptors. That's why it works. So ice pack test is cheap, doesn't cost anything, okay? That's what we're now doing. But if they ask you for a drug, there it is, right at the top of the list, edrophonium. Short-acting acetylcholinesterase inhibitor. See that? Will make more acetylcholine available and therefore stimulate your muscles. That's why you feel better for about 10 minutes, then it wears off. Zena. No, so she's asking about how would they present Eden-Lambert? They present it exactly as you just said. They get crampier as the day goes by. Yeah. Or they'll say they get cramped at the end of the day. Yeah, and that's myasthenia gravis never says I'm cramped. They're just weak. They're sitting like this, they're slouching. All right, so anyway, that's edrophonium. That's to diagnose it, and then you use neostigmine first line to treat it. And then you give them steroids because it's still autoimmune. So neostigmine with steroids, first line treatment for myasthenia gravis. Why does myasthenia gravis get worse when you're hospitalized for another illness, Gloria? Like pneumonia, UTIs, whatever. They always get worse when they're in the hospital. So why is it when the immune system is fighting something else, they get worse though? Because what now? You're on the right track. Just got to refine the words. It's because in trying to fight the pneumonia or UTI, whatever it is, they also make more antibodies against the acetylcholine receptor. So it's normal for myasthenia to get worse with any infection. Just so you know, they like to toss that in there, make it sound like it's some new disease. No, they always get worse after an infection. You may have to raise their dose for a few days. That's it. All right, anyway, that's, again, edrophonium to diagnose it, neostigmine to treat it, along with steroids. Predostigmine is second line. Plasmostigmine has too many CNS side effects. Ida, it makes it too fat or water soluble. Too fat soluble, that's why we don't use it. An old one they brought back, which I already introduced you to, ribostigmine, can also be used. So plasmostigmine is the only one that they say don't use because it makes them groggy all day. So much of it goes up to your brain. Any questions on acetylcholinesterase inhibitors? Then I gave you the irreversible ones. If they're irreversible, are they competitive or non-competitive? Acuna mezu.
Non-competitive.
Non-competitive. What happens to my KM?
The KM is going to decrease. Sorry, the KM is going to stay the same. Stay the
Yeah,
same.
KM says you're not fighting for the active site, so you can't change KM.
Correct.
The max decreases because you're turning off the enzyme. You understand?
Yes.
All right, you understand, Elishiba? Elishiba, do you understand? All right, Shri, you understand?
Yes, sir.
All right. So the other non-competitive acetylcholinesterase inhibitors, remember, are organophosphates, the NF8 or thion. And if you see a farmer come into the emergency room with suspected organophosphate poisoning, what was the clue I gave you to look for? Lillian. Just sweating? What? No, not just not making sense of sweating. It was a pattern I gave you. What? It's on the clothes, but what? I'm talking about symptoms. How do I know he has it? Kathleen will help you out. Nolan, help him out. Besides sweating like crazy, what else? So how do I know any parasympathetic? He gave you guys a mnemonic to use. Dumbbells or sludge. That's what I mean. Don't just memorize sweating. That's only one letter. What about all the other stuff? All right, so anyway, like I told you, we got like 2 cases every year right here in town when they start planting. All right, when Farmer Bob shows up, what do? Cut the clothes off of him. It's on his clothes, he doesn't know it. And it can be absorbed right through the skin. Then we give him what drug, Lillian? She forgot. I knew she. Oh, I think I mispronounced it. Wait a minute. Oshni, yeah, I flipped a few letters in there. My bad, girl. I told you I should have drank Mountain Dew this morning. So anyway, Oshni, do you remember? Give him atropine to reverse cholinergic. And then you give him palidoxy, remember 2-PAM to reverse the drug. Okay, otherwise, if you don't do it quickly, remember he's on the ventilator. Now you got to wait for the drug to wear off, 2-3 days. Okay, so you got to do it as soon as they come through that door. All right, if they come back complaining about more weakness, this is somebody you already gave them neostigmine and steroids and sent them home. They come back and say, hey, doc, I'm getting more weak. What's going on? Either the disease is getting worse, which is understandable, or you're in the middle of a cholinergic crisis. It means they have too much acetylcholine in their system now. Because if you have too much of any neurotransmitter, it binds the receptor, and then it doesn't have time to reset because it never comes off. That receptor will desensitize. That's what you're seeing. Cholinergic crisis, too much acetylcholine desensitizes its own receptors. So what do? Repeat that euphonium test. Just like in the beginning, if they get better, then it's a disease. Then that means you need to increase the dose of neostigmine. Just that easy. Because on the test, they usually give you all the results, and you got to figure out what to do next. If the patient gets worse, then what you've done is add to his cholinergic crisis. He was already in the middle of a cholinergic crisis. And that means hold neostigmine for 1 or 2 doses, give them atropine to reverse things for now, and then decrease their neostigmine dose going forward. Any questions on that issue? Which part? You repeated the test because when they come in more weak, you don't know if it's the disease or a cholinergic crisis. They're both weaker. This after you've been treating, yeah. No, this is after you treat mycelium gravis and send them home. Not the farmer, that's organophosphate poison, that's totally different. This is somebody with mycelium gravis, you put them on medication, and they come back a few months later and say, hey, doc, I'm getting more weaker. I thought the drug was supposed to help me. Well, that means either the disease is getting worse, or they have so much acetylcholine that it's desensitizing the receptors. And both of them will make them weak. That's why you got to test it again to see which one it is. Okay? So euphonium test. Any questions on that? All right. Anticholinergic drugs. some of which these you already heard before. Remember anticholinergic, how do you know it, Josh? Sympathetic, the side effects are sympathetic, because you said anticholinergic. Except for you cannot sweat. So hot, dry skin, hyperthermia, then I know for sure you're taking an anticholinergic drug. So there's some drugs where classic loop should get you a diagnosis. This is one of them. Hot, dry skin, hyperthermia, automatically anticholinergic. Now, there's a lot of drugs that anticholinergic, but at least it tells you. Atropines, first line drug for cholinergic crisis. First line drug for heart block. Listen, which heart block does not respond to atropine? Which one? All right, Ashton. Yeah, third degree. Remember, AV node is gone, so it cannot communicate with the ventricle. All right, so atropine. Atropine is also used to dry out pulmonary secretions before surgery to prevent atelectasis after surgery. Remember, if the patient's laying on their back for hours, all that mucus is sitting there, clogging up the airway. So if you decrease how much mucus they can produce, that helps out. You understand, Paul? All right. You understand, Andy, DeVilma?
Yes, sir.
All right, good. Are you sure you understand?
Yes.
All right. Devika, you understand so far?
Yes.
All right, very good. All right, so that's atropine. Glycopyrrolate is also used to dry out pulmonary secretions before surgery. Benztropine is used to treat Parkinson's and was used in the past to treat dystonia. Jess, what's the definition of dystonia? All right, you're almost there. Somebody know this? You thought what? It is contraction, but you gotta say a little more than just contraction. Now, it's sustained contraction, that's the key word you want, by a group of muscles. So sustain and group are the two key words you gotta look for in your answer. Because a tick is instantaneous contraction of one muscle. That's why they're gonna have that on that list too, but that's not what you're looking for. Okay, now the best treatment for dystonia, remember this with the antipsychotic drugs. Sandra, do you remember how to treat dystonia? First line drug we're using these days? No, Hannah. Yeah, Benadryl is cheaper. It's the cheapest anticholinergic drug on the market. So benztropine. So hexafenadol is used by ophthalmologists to dilate the eyes of a diabetic for annual visit. Get a good look back there. And Ipra and tiotropium are the only anticholinergic drugs allowed to be used in asthma or obstructive lung disease. Remember, other anticholinergics dry out the secretions. You don't want that. And it causes a higher death rate. But these two can be used because they don't touch the muscarinic receptor at all. Any questions on these drugs? You can have a pattern. Anticholinergic, sympathetic, but hot, dry, and hyperthermia. That way it's easy to come up with 1,000 side effects if they want to hear. Neoplastic association with thymoma with myasthenia gravis. If you remember thymoma, you learned can be associated with any autoimmune disease except Graves. So if they ever ask for a tumor that goes with any autoimmune disease, this is your answer. And then small cell goes with Eaton-Lambert syndrome. MS versus metachromatic leukodystrophy. MS is a middle-aged female with visual disturbance, any visual disturbance. Remember, myasthenia gravis has ptosis, has droopy eyelids, but her vision is fine. But MS, she has blurry vision, double vision, whatever they want to say. If they have a visual problem, I'm picking MS every time because that's always been the answer. Next, middle-aged female with scattered neuropathies that don't make any sense. Or MS can jump around any pathway it wants. So scattered neuropathies, where you cannot explain with any one pathway, always think MS. Okay, and then I'll do what they have in common in a minute. Metachromatic leukodystrophy is different. This one is the MS equivalent, but in a 5 to 10-year-old child. So the age As I told you before, it's the biggest distinguishing feature. You're not gonna see 5 to 10-year-old with MS. Call it metachromatic leukodystrophy. Excuse me? It presents the same way as MS, but the age tells me it's not MS. It can progress, but it's not MS, so it doesn't have the same prognosis as MS. So metachromatic leukodystrophy. Was the enzyme that's deficient in this patient, Nolan? Aerosulfatase, the one that breaks down SRSA, missing. So now you get severe vasoconstriction throughout your brain, and that's how you get demyelination from ischemia. That's why it looks like MS, but it's not MS. Metachromatic leukodystrophy. Now, what do they have in common? What they have in common is that they both can cause optic neuritis. Inflame your optic nerve. How do I know your optic nerve is inflamed? So let's say I want to take a look at Maria. If my optic nerve is inflamed, if I look at Maria, I can't see her. So what I do? I look away so I can see her with the periphery of my retina. I start looking at Abigail. I say, hey, how you doing, Maria? You doing okay? And that's because I can see her now. But it looks like I'm looking right at Abigail. All right, so it's kind of strange when they walk in your office. They're always looking like they're looking at something else, but they're actually talking to you. They can only see with the sides of their retina, not head on. I can't see you head on. That's called halo vision. I can see around your face, but I cannot see your face. Okay, halo vision. Or another term for that, centroscotoma. That means I can't see anything in the center of my vision. Optic neuritis, that's how you know. And then the second one, internuclear ophthalmoplegia. This is when the medial, longitudinal fasciculus is involved. MLF connects cranium 3 to cranium 6 for what we call reactive or lateral vision. So let's say I hear a sudden sound over here on my left. I don't think I see. If I hear a sudden sound over here on my left side, my left eye must pull to the left. So ipsilateral eye pulls laterally, but the contralateral eye must pull medially. See that? And that way both eyes now look left. If I hear a sound over here on my right eye, so ipsilateral eye pulls lateral, the left eye will then pull medially. That's 3 and 6. 3 is the medial, 6 is the lateral. That's how they talk to each other. Let's say you got an MLF problem. All right. So if I make a sound over here on the right, your right eye will pull immediately. The left eye won't come past that midline, which means he never got the message. So how do you know cranium 3 is just not working? Because after that, we do what we call convergence. Bring your eye down, the finger down the middle, and both eyes cross, which means both medial and recti work just fine. But they're not getting the message to pull. Okay, that's MLF problems. Adam. Yeah, it corrects. They don't have an automatic strabismus, what he's asking. Their eyes will look like it's still looking centrally. It's only when you ask them to look to the side, then you'll see diplopia. Yeah, because one will be right here, the opposite eye will be in the midline, seeing the visual field that way, but the ipsilateral eye will pull laterally, which means you have another visual field over here. That's why they see double vision. As soon as you say go to the side, they have double vision. Yep. All right. Another classic problem they have is trigeminal neuralgia. Shooting, stabbing pain on your face and jaw, for which the treatment is what, Gloria? Carbamazepine again. People who have trigeminal neuralgia. I remember Montel Williams, the former talk show host, he has this, MS. And he talked about when he had this pain shooting down the side of his face, the man was about to commit suicide because the pain was just too great. It is very painful. I read another article that says a lot of them would rather put their hand on a hot stove because that felt better than this. You believe that? I mean, just think about it. I obviously use gay theory, but if burning your hand feels better than what this is, it just gives you an idea how severe it is. So carbamazepine came along to make it manageable. I mean, they were committing suicide because it was just so severe they couldn't live with it. All right, so carbamazepine made its name in treating this. All right, anyway, trigeminal neuralgia. How do you diagnose this? They expect you to know. MRI is the only thing that can diagnose. Only an MRI can see demyelinated plaques off of a nerve. The CT scan, no other test can see it. So they expect you to pick MRI first, lumbar puncture second. The plaques in the CSF are called myelin basic proteins, or like the second one, metachromasia is the way they'll describe it. Yes. Question on internuclear ophthalmoplegia is?
In the naming, the right side, is it the one that can't abduct?
Yeah, if the one is the one that cannot abduct, that tells you that's the side that has a problem.
That would be like, say that right, right?
Right into nuclear ophthalmoplegia, correct. Right. If the left is the one that can't adduct, probably you say left into nuclear ophthalmoplegia.
The plaques themselves, they have like a specific, I know it's randomized, it's jumped around.
Uh-huh.
But is there like specific locations? I heard one time was Caribbean treated her.
You mean the plaques?
Plaques themselves.
No, the plaques can be anywhere. Yeah, it can be anywhere. Yeah. I wouldn't place it in one spot. Adam? MRI is done first because it can see the demyelinated area. If you don't see it, then you do the lumbar puncture. No, it's not really more. They both have the same pretty much. It's just a more a supportive test. That's it. Because if the person actually has demyelination, and this is from demyelination, because you have other diseases that look like MS, but it's not. That's why you do lumbar puncture, and then you see, yeah, there's myelin plaques. That's what the myelin basic proteins is. That's how you know. Right, because it could be some other disease doing that, you know. PML in AIDS patient has the same look when you do the MRI. You can see demyelination there too. All right, anyway, that's neuropathies. And then we got treatment for autoimmune neuromuscular diseases. I saved it for now. Is how you treat them all. Steroids is first, except the Guillain-Barré. That's why I had to tell you that. But any of the other ones, steroids is always given first. But then you gotta know which one's oral, prednisone, versus IV, methylprednisolone. Okay. IV gamma globulins is next. How do I know when to use that? When they have trouble getting out of a chair or getting out of bed. So the history will tell you when it's time for IV gamma globulins. Plasmapheresis last. How do I know that? When they have trouble breathing, because that means they're about to go on a ventilator. And when they go on a ventilator, they usually aren't coming on. Think about it. If you're struggling to breathe every day of your life, and then somebody puts you on a machine that breathes for you, after a while, like, oh, thank you. You're just gonna let go. Let the machine do all the work. But then you stay there and die from staph aureus. That's a problem. Okay, because they don't want to come off the ventilator. They rather let the machine do all the work. All right, lower motor neuron disease. There's 3 of them. ALS. This is your descending paralysis. Somebody was asking earlier. All right, so descending paralysis. This is your disease. Middle-aged male with descending paralysis. Second include what's involved: corticospinal tract and anterior horn. All motor fibers are gone. Corticospinal tract is upper motor neuron, anterior horn is lower motor neuron. And so for that reason, you see what we call fasciculations. Fasciculations can only be a lower motor neuron disease. That's why they like using this word. Because I figure if you don't know what that word is, then there's no way you're gonna get it right. So 3 good clues. And the last one is no sensory involvement whatsoever. ALS does not involve sensory nerves. Fasciculation means real fine twitches of the muscle. That's little vesicles of acetylcholine still falling on them. That's why they twitch all day long. And then what was the drug we talked about that can treat ALS? Help them feel better, Melissa? You remember? No? All right. Nate? No, all right, Elisheba? She's not there, all right, Hannah?
Question, what is it?
Yeah, Riluzole is the drug that I gave you guys. Okay, what's your question?
Is atrophy of the hands specific for ALS?
No, but you do get atrophy of the hands because it starts up here at the top and it goes down. So they get atrophy before they get the other stuff. Yeah. But it's not unique. Victoria, you have a question?
Yeah, I kind of have two questions. Is ALS caused by any viral infection like GBS is or no?
What disease?
Can ALS be caused by like gastroenteritis? or
Oh,
something
by
like
an
GBS?
infection? No, ALS is not caused by an infection.
Okay, and I thought ALS also had upper motor neuron symptoms.
It does. That's what I said. Corticospinal tract and ventral horn.
Oh, okay. Okay.
Yeah, corticospinal tract is upper motor neuron. Upper motor neuron. All right, next one, Werning-Hoffman disease. Newborn baby with fasciculations. That alone gives me most of my points. Newborn baby with fasciculations. Next clue, third in line for floppy baby. Hypothyroidism is number 1 overall. Botulism is number 2 if they've been eating honey, and then Werning-Hoffman. Yes, sir. No, botulinum toxin stops the release of neurotransmitters, so you can't get fasciculation. You got to release some neurotransmitters to get fasciculations. All right, let's see. We got some hands up here. And Mabel, did you have another question?
Yes, sir. Please, what's the question you asked when you're giving us all those answers? You asked the question right now.
I've been asking questions all day. Which one are you talking about?
No, this last thing you said, you were giving us clues. I didn't even know what you said, but you said something, you were giving examples.
I don't know. Which one?
Okay,
Floppy baby?
okay. The cause of floppy baby syndrome.
Baby. Yeah, I said
Yes.
hypothyroidism number 1, botulism, they've eaten honey, number 2, and then Werning-Hoffman. 3 floppy babies. Polio?
Thank you, sir.
No problem. Polio is right after gastritis. Don't forget, polio is an enterovirus. You get the diarrhea before you get the paralysis. So it's diarrheal illness followed by paralysis. And the second best clue, paralysis is always asymmetrical. It can pop up anywhere. Paralysis is asymmetrical. And the third clue, it hides in the dorsal ganglion. You love to ask where this thing is hiding. All right. And then it comes out. And all of a sudden now you're paralyzed in someplace. Rachel, if it hides in the dorsal ganglion and it comes out, what is it using to come out? Kinesin or dynein? If it's if it's hiding in the dorsal ganglion and then comes out to infect you every now and then, what is it using to come out? Is it kinesin or dynein? All right, Ashni? Which one? How do you know it's kinesin? Yeah, because it's moving forward. Remember, from the back to the front, it's anterograde. So kinesin moves you forward. All right, very good. And I think 1 more, no, 2 more. Cerebellar disease in 5 to 10-year-old children. First one, ataxia telangiectasia. You've heard of it 3 times already. I told you this thing is like 6 different chapters. First one, dermatology. They have telangiectasias, which are spider veins all over their body. That's the best clue, because 95% of them have it. Number 2, they have IgA deficiency, so it ends up in immunodeficiency chapter. Number 3, they have a problem with DNA breakage repair by free radicals. So it ended up in the DNA RNA molecular biology lecture. Number 4, they have malabsorption. Malabsorption of fats is the reason why you get the ataxia, because it demyelinates your brain. So that's why it ends up in neuro as well. So this disease is in a lot of chapters. All right, that's ataxia telangiectasia. Next one, Friedreich's ataxia. Trinucleotide repeats, 1 of 5 with trinucleotide repeats. And then it's associated with scoliosis. Hokum, ISS of hokum, and then retinitis pigmentosa. ISS of hokum, so they always tell you his brother died at age 20 or 25 or something while playing basketball. I know it's freaks. All right, adrenoleukodystrophy, first clue. CAT1, carnitine acetyltransferase. Is that on the cytoplasmic or the mitochondrial side? Melissa? It's not getting so easy. You say, I don't know if I'm ready to finish the question. All right, okay. All right, Ashley, you know? All right, Jess? CAT1 is on the cytoplasmic, CAT2 is on the mitochondrial side. All right, so this is CAT1 is missing. Number 2, X-linked recessive. Remember, one of only 10. Adrenoleukodystrophy. Third clue, long chain fatty acids trapped in the cytoplasm because you can't make it to mitochondria. And then they'll put in another clue, low ketones. Remember, you need to break down long chain fatty acids, make ketones. So they like to throw that in there in the lab. Okay. Adrenoleukodystrophy. You understand, Justin? You sure you understand, Jim? Hey, Justin, this is only one of 10 enzymes with that are X-linked receptor, right? Look at my man sweating already. Because you know you're supposed to give it the other 9 now. All right, just give me 3. 3. You remember them? Remember that list? Justin, do you remember the list? No? All right, Cesar, give me 3. G6PD. Oh, now you're reading the list. Don't read the list to me. I want to see how much you remember before you read it. It's in the notes, folks. I just want to see if you guys remember, but don't read the stuff to me. Remember, I'm trying to help you. So if you can remember something like that, forces your brain to work. All right, so anyway, it's on your list. Remember, a golf cart. Remember that student gave you, what was it? Oh, golf patch? Oh, okay, there you go. I'd have been on the wrong cart then. Okay, yes. In the cytoplasm side. They never made it to mitochondria. And finally, cerebral palsy. The definition of cerebral palsy, Bailey, is any permanent neurological damage suffered prior to age 21. That means you can get into a car accident in your teenage years and get damage. That's called cerebral palsy as well. They expanded the definition back in the late 80s, just so we can study teenagers and all these car accidents that they have. Any questions on definition? All right, the first one, Sandy, it's called spastic diplegia. When you hear the term spastic, what pathway is involved, Sandy? Corticospinal tract. That means the cortex. Corticospinal tract starts right here in the frontal lobe. That means you're telling me the problem started in the cortex, and diplegia means the legs are worse than the arms. Where are the leg fibers found, Sandy? Medial or lateral in the brain? Medial, remember the homunculus. Legs are always medial, arms are always lateral. So when you put it together, again, the term tells me all I need to know, folks. I don't have to look it up. Spastic, cortex, diplegia, legs. That means the fibers right here along the midline. That means you got a midline cortical problem. Then they can make it anything they want after that. That's what I'm saying. It could be a bunch of diseases. But their favorite one, right along midline, CMV. Remember, calcification, right along the midline, CMV. So if they want an infection, big CMV. What's the most common overall? Hydrocephalus, because the 2 lateral ventricles compress the midline. Melissa, you ever seen spastic diplegia before? No? Josh, have you ever seen it before? Not sure. Nate, have you ever seen it before? Jess, have you ever seen it before? Spastic diplegia before. Have you ever seen it before? Some of you ever seen it before? You guys, all of you have seen spastic diplegia. You just didn't know that's what it was. You ever watch a marathon, all the wheelchair racers? What do you think they got? How come they can't run? Their legs are no good, but their arms, everything else works just fine. That's spastic diplegia. And NCAA, because it's the most common cerebral palsy, NCAA was told you need to have sports for these people. I saw them playing tennis. I didn't know they were playing tennis. I knew they could play, you know, they play all kind of water polo. I see them playing in the pool all the time. But tennis, I didn't know they could do, but they do. So anyway, that's because all the colleges were told you gotta make sports because they can use everything else except their legs. Okay, and you don't want them to sit around doing nothing. All right, so it is spastic diplegia. Spastic hemiplegia. What does spastic mean to you, Steve? Upper motor neuron, so cortex involved. Hemiplegia means half your body is affected. So the right half of my body is affected. We say right spastic hemiplegia. Where's the problem in the brain? On the left side, it's the opposite side of the brain. Then it could be a million things after that. All right, but their favorite ones, herpes likes to attack one temporal lobe at a time. So if you want infections, they love herpes. Toxoplasmosis likes to attack one parietal lobe at a time. So those are top 2 infections. Then after that, I've seen so many things. All right, seizures, strokes, cancers, all kinds of stuff. All right, then it's basket. Any questions on that? Third
Yes,
one,
sir.
Coriander. Yes, Mabel.
Please, it said there are 2 examples, herpes and which other one?
Herpes and toxoplasmosis.
Thank you,
Herpes
sir.
is temporal lobe, toxo is parietal lobe. All right, choreathetosis. Chorea means dance-like movements, or like choreograph. Athetosis means quivering muscles. The number 1 disease that attacks basal ganglia, because anytime you have movement disorder, basal ganglia is involved. The number 1 disease that attacks basal ganglia is kernicterus, bilirubin, high bilirubin. Remember, since it's your brain, it's got to be fat soluble bilirubin. Understand, Montessori? Fat soluble, is it direct or indirect, Montessori? Which one is fat soluble, direct or indirect bilirubin? Fat soluble. Just ask me how. No, direct means conjugated already, so indirect. So high indirect. All right. So the rule is, it's a newborn, bilirubin. All right. If it's preterm baby, bilirubin goes above 15, phototherapy. Term baby goes above 20, phototherapy. If anybody's bilirubin goes above 25, exchange transfusion right away, because that's 98% of choreathotic CP, bilirubin was above 25. The 25 is a cutoff. Once you're 25, boom, we exchange all your blood. That's the only way to bring it down within minutes. Are we afraid of B12 deficiency after what? After, no, not for the therapy. There's another vitamin deficiency for the therapy. Which one was that? Gloria wants to help you. She forgot. Anders. B2, remember, riboflavin, it's the one that gets burnt up with sunlight. Yeah, so you got to watch out. If you're going to do prolonged phototherapy, you got to get B2 deficient, sorry, B2 supplement. So choreathosis, the newborn, kernicterus, and now you have the parameters. And then in the children, rheumatic fever. And then Wilson's disease, a distant third. So a very short list. And then finally, atonic cerebral palsy. Atonic cerebral palsy, the word atonic means without tone, without any muscle tone. Your muscle tone, Hannah, is set by your corticospinal tract, which goes right across your frontal lobe. So if you got atonic cerebral palsy, there's a frontal cortex problem. After that, it could be a seizure, tumor, stroke. I don't know what it's going to be, but your answer better have frontal cortex. Yes, sir.
Does low motor give you?
Lower motor neuron give you what? It's not going to be atonic. Lower motor neuron, well, no, that's not true. If you get lower motor neuron, they will use the word flaccidity. Yeah, flaccidity, not atonic. In atonic cerebral palsy, they drop to the ground like a wet noodle with no tone in their body whatsoever. And then you got to pick them up off the ground. You can have atonic cerebral palsy and atonic seizures. I've seen atonic seizures too. Yeah, they just drop to the ground and they start wiggling around like they got no bones. And then all of a sudden they start coming out of it. It's a real weird seizure. I've never seen one.
So like cataplexy for the narcolepsy?
No, cataplexy for narcolepsy, they hit the ground, they go straight into the ground. They don't writhe around. They don't wiggle around on the ground. They just fall to the ground and go straight to sleep in the ring. That's different. All right, so atonic cerebral palsy, folks, no tone. And they're wiggling around. So the mom brings them in and says, Doc, what we're gonna do about this head wiggling all day long? What we're gonna do? Clamp? We put clamps right by the head, right there. Say, okay, think we got him, think we got him. Just when you think you got the head to stabilize, oh, the shoulder starts moving. The shoulders start going. You say, okay, clamp, clamp. Okay, we got it. Just when you think you got it, oh, then the belly starts wiggling. Ooh, wiggle, wiggle, wiggle. Anyway, everything's wiggling in these kids. You gotta clamp them down and just get them to sit in a chair. They're in a wheelchair with clamps all over just so they can stay there. So a lot of them fall out of the chair, slip, fall, something to worry about. But Timmy, what do you think is the most common cause of death for that child? The atonic cerebral palsy? It has to be respiratory failure. Why is that? Because it's still a neuromuscular disease. Yeah, sounds good. All right, very good. All right, folks, there you have it. You've been empowered again. That's neuromuscular complete. Vascular starts right after lunch. We'll start at 1:25. Yes, sir. Talk fast. I got a little meeting. Go ahead. Where do you say taxia? I don't think it's X-linked dominant. I don't know. Is that X-linked dominant? Oh, I didn't know that. Was that? Eight taxes, nine you take. What about it? Not that I know of. There's genetics involved, but I haven't seen any integral pattern for it. Let's see, muscular, vascular. All right, so you guys have to.
One more, don't be.
It's pretty retrograde, Dude, I
Yeah, but yes, they are not supposed to be excessive. Yeah, yeah, those are what those around a lot to me. That happens. I mean. Then all that when you like this guy, I'm down the stairs. Why do I have to keep holding? That you. You're fucking Sasquatch down the stairs. Last night. Yeah, it's deep. Yeah, I know it is. What, yeah, we're gonna put down the stairs. Okay, well, that's. That's what happens. Watching on you, the kitchen's above. It's a hard one. It's a damn water here. It's so loud. Like you're really training him like it rattles the vents. Yeah, that's like that, really on. But you don't. It's like. You don't have it, that's why. I do, I a while ago. Go on here, go on here. What I do. You know, you swipe. What the fuck is this? My niece used to do that in magazine. Oh my God.
All right, on to the next topic, vascular fizz. What are we gonna get out of here? Number one, hemorrhages. Different causes of bleeds in your body. And then in the middle, we'll talk about hypertension. Complete update on hypertension and how to manage it. All right, and then at the end, we'll go through vasculitides. All the diseases that cause vasculitis, that's a big category that they love to test because it comes under all the cardiovascular diseases. So that means we got to review all of those. All right, so here we go. All right, got to have some flow. It's all about smooth muscle, in other words. Smooth muscle. So since we've spent a lot of time talking about cardiac and skeletal muscle, now we got to give smooth muscle a little time for him. Smooth muscle, the thickest layer of smooth muscle is found in the aorta. Since you only have one aorta, last I checked, so when they say thickest layer, then my answer is aorta. But if they say most smooth muscle by surface area, see, that's a whole different question. When they say by surface area, that means when you add them all up. Well, you can't add up only one vessel, okay? So when you add them all up, it's the arterioles. Because you got one aorta, but hundreds of arterioles, okay? And the least smooth muscle is found in the veins and venules. One more time, thickest, most, and least. Any questions on the difference? All right, because a lot of students get the three mixed up, totally different. All right, the arterioles are considered the stopcocks of your vascular tree. What does that mean? Their job is to protect the most frail vessels in your vascular tree, which is the capillaries. The capillaries are the most fragile, frail. Why? Because they're made up of one layer of cells only. That means if the pressure is too high, boom, they blow. Okay. All right, so the arterioles, their job is to protect them then. Their job is to keep the amount of blood flow. Now, notice the word I just used, flow. So you get flow and pressure mixed up a lot. They're not the same thing. They're not the same thing. They're inversely related. Make sure you keep it straight. So the arterioles, because they have the most smooth muscle, they do the most to get your blood pressure go up or down. But what they control the most is flow. Okay? They maintain auto regulation. That means if you want flow to increase, you got to dilate them. If you want flow to decrease, you got to constrict them. Now, why is this so important? Because in the books, they talk about arteries doing the most vasoconstriction. And they do, but they're not the ones who do the most regulate your blood pressure. So students think what the book said is the answer to the question on the exam, but it's not. Who does the most regulate your blood pressure? It's always the arterioles. Who vasoconstricts more than anybody else? The arterioles. Who vasodilates more than anybody else? The arterioles. Why? Because there are more arterioles than there are arteries. So even though the books go on and on about arteries, that's still not the best answer when you get to the exam. Okay, so be careful. Autoregulation, what the heck does that mean? Let's go, Miss Angie. Autoregulation, what does that mean? Let's talk about it. You want to talk about it? Okay, here you go. So between 60, so as long as you keep your blood pressure between 60 and 160 systolic, blood flow to the three most important organs stays the same. Angie, what are the three most important organs in order? Brain, heart, and kidney. So that means as long as your blood pressure stays between 60 and 160 systolic, Halima, blood flow to the brain, heart, kidney stays exactly the same. You understand that? You understand that, Josh? All right. You understand that, Karina? You understand that, Miguel? You understand, Maria? You understand that, Sabu? Okay. You guys say you understand it now. Who knows whether you'll understand in a few more minutes when I ask you the same question a different way. All right, anyway. All right, so anyway, as long as your blood pressure stays between 60 and 160 systolic, blood flow to the three most essential organs must stay exactly the same. Why? Because your blood pressure changes with your body position. That means you would lose your brain, heart, and kidney every time you change body position then, right? When you lay down, your blood pressure goes down. When you stand up, your blood pressure initially goes down and then goes back up. But that means anytime you stood up, guess what? You'd have a stroke. But you don't have a stroke. Why? Because as long as you stay between 60 and 160, nothing happens. So how do we know to call it ischemic infarct? It means your blood pressure went below 60. Anytime you're sick, your blood pressure goes below 60 systolic, that means blood flow to the three most essential organs drops down. Who are the three most essential organs in order? Zena. Brain, then the heart, then the kidney. Nurses are trained to know about 60. Now, if you watch some of the medical shows, you hear the nurse yelling at the doctor when that systolic hits 60. Doctor, blood pressure systolic overpower, what should I do? See that? Because the nurse is told, you better scream at the doctor. I don't care what he's doing, you better get his attention right away. Because if you don't do something about it, guess what? You're about to lose 3 organs, which means you're about to lose your patient. Everybody understand why 60 bothers any doctor, and it's also bother you. If I see 60 systolic on anybody in a vignette, you already know you better do something fast. Even if I see 60 diastolic, I'm worried because still there's a problem, okay? So let's say your blood pressure goes from 60 to 159 systolic. What happens to your renal blood flow, Zena? Go up or go down? It should go up, a little or a lot? A lot. And Ms. Mitchell, if your blood pressure goes from 62 systolic to 152 systolic, what happens to GFR? Stay the same. Does it go up or go down? Stay the same. Does it go down a little bit or up a little bit? Stay the same. You understand, Zena? All right, don't ever fall for that anymore. All right, remember I told you, that's what it's called suggestive selling. If I suggest to you that there's an answer, you fall for it. It means you don't understand because you talk yourself into it too fast. All right? As long as I'm quoting you numbers between 60 and 160, the answer is nothing happens. But notice what I did was change the words. The blood flow becomes GFR, becomes granite clearance, becomes, I could use any one of those terms. It's still the same thing, which means nothing will happen. See, but they got you thinking, well, could we go up a little? Will it go up a lot? The answer still will not change at all. It's on that list. Okay? They're trying to suggest the wrong answer to you. All right, so ischemic infarct. So what do you think happened? What do you think they saw, Chris, with a C, when they got those 5 men who dropped dead 2 weeks into taking their first Viagra? Mixed Viagra with nitrates. This is exactly what they saw. That's how they know hypotension killed them, not that Viagra kills them. Right, follow? That's why Viagra was allowed to stay on the market. And then they warn you, don't use Viagra and nitrates together. How far apart should you separate them, Jess? 24 hours is the optimal number. Separate Viagra and nitrates. And then remember all the other vasodilators by 6 hours. And if you're a pilot, wait at least 6 hours, or hopefully in a day you're not even flying. So ischemic infarct. Any questions on ischemic infarct? Another name for this, pale infarcts, which means the blood flow went away. Any questions on ischemic infarcts? Lauren. No, yeah, infarct can occur in all 3 organs. It can occur in any organ. It's just where's it going to occur first? You know, remember, you go from the bottom up whenever you're sacrificing. You understand? What about the other side, hemorrhagic infarct? Well, Karen's hemorrhagic infarct says your blood pressure went above 160 systolic. So let's talk this out, Garrett. If your blood pressure goes above 160 systolic, which vessels will do the most to try to get it back down to normal? Is the arterials. That's their job. So let's pretend you got 2 tables right here, okay? So people online, you're gonna have to imagine. All right, so we have 2 tables in front of me. One table is the arterioles, and they feed this table the capillaries. Do we follow? So the arterioles protect the capillaries because they're one after the other. Do we follow? Is at the capillary level, you try to keep flow the same, and therefore keep the pressure the same. Why? Because they're the ones who feed your tissues. Tissues have a certain nutritional need. That means as long as the flow stays the same amount, they get all the nutrition they need. And that's why you're alive and well. Everybody follow? All right, now we're gonna jack it up to 160. Who's gonna do the most to try to bring it back down? The arterial. Now, if they bring it back down, no problem. We're right back to the beginning. What if they don't bring it back down? If the arterials don't get the pressure down fast enough, then the capillaries will take over control. Folks, you never want the capillaries to take over control, because if the capillaries take over control, it gets worse real fast. You want the arterioles to maintain control. Everybody follow me again. If the arterioles do not get control in a certain amount of time, the capillaries will take over. Then it gets worse. This is why we try to catch hypertension as early as possible. Help the arterioles get it back down. If you don't, capillaries are going to take over. When they take over, they speak a different language. Their language is flow. The arterioles' language is pressure. Everybody see? That's in opposite directions. Flow. So let's say the capillaries start talking. And so now when I say when they haven't done enough time, I'm not about 1 week, 2 weeks, 2 months, 3 months. It's years down the line. And the pressure is still up. Capillaries are going to eventually take over. And then they're going to take the arterial, tell the arterioles, hey, arterioles, do your job, man. Bring the flow down. Garrison, if you want to bring the flow down, do you want to constrict or dilate? Flow is amount. So that means if you want to decrease the flow, you need to constrict. Everybody else understand that? Be careful. Flow and pressure are not the same, folks. They're going opposite directions. A lot of students get the two mixed up. So capillary starts saying decrease the flow. The arterial said, no problem, we can decrease the flow. Basically constrict. Carries. You basically constrict, what happens to pressure? Increase. Resistance. Increase. Does everybody see we're traveling in the wrong direction already? If you let the capillaries take over, they start speaking one language. These guys understand a whole different language. They're talking flow, this guy's talking pressure. So when you decrease flow, you constrict, but that increases pressure and resistance. So after a while, what happens to velocity, Karen, if you constrict them? I don't know, you're asking me or you're answering my question? This is tricky for you. What do you think happens when you constrict? What happens to velocity? I don't know. I'm asking you first. You're asking me the same question. Oh, Lord. Cena, help this young lady out. When you constrict, velocity, it increases. Don't be asking the same question I just asked you. Okay, so it increases. That means blood is now flying through these capillaries. Zena, if blood is flying past you, let's say you're the cell, and I send food your way, and it passes you at 200 miles an hour. Can you get the food to eat? Chances are you won't get any food to eat. You know what I'm saying? So let's say you got a little capillary, little baby capillary. He said, Mommy, I want some French fries. I want some Burger King. I want some McDonald's. Okay, son, don't even worry about it. Here comes some French fries. Oh, man. Because the French fries flew by at 200 miles an hour. You're not going to be able to eat that thing. All right? This is why they call hypertension the silent killer. Their tissues are slowly dying. You don't even know it. Food is flying past them so fast, they cannot feed themselves. They cannot gain oxygen. They cannot get glucose. They cannot get whatever the heck they need. They cannot get it. Everybody understand it? Folks, that's why we screen people for hypertension at picnics in the park, at the mall, at churches, because a lot of people walk around with hypertension and don't even know they have it until something really bad happens. That's why you try to catch it before that happens. Everybody understand? Okay, so the capillaries start saying, hey, blood is flying by here too fast. Slap, slap, slap. Man, what the hell? Slow it down. And so the arterial said, okay, we'll slow it down. We'll slow it down says you got to constrict to slow down the flow. Remember? These guys talk flow. These guys talk resistance. So when you say decrease the flow, they constrict some more. What happens to flow when you do that, Bailey? Does it increase or decrease when you phase constrict? Flow, decrease. What happens to velocity? Increase. We're still moving in the wrong direction. And that's why it's going to keep going up and up and up till something bad happens. Well, the arterials say, okay, now we gotta do something about this. These capillaries are just too demanding. Way too demanding. So what are they gonna do? What's the first response of muscle to increase resistance? Hypertension is resistance. Karina, what you learned today?
What can you do?
What is the first response of muscle to resistance? Let's see.
Oh. Maybe cross purpose.
What was it called? No, preload is the tension before you've even moved it. Let me ask Chris. But what's the term we use for that?
Yeah, it starts with a P, right?
That's with a P. So what do you think? It's called hypertrophy. The first response of muscle to resistance, because hypertension is resistance, is hypertrophy. So now the smooth muscle within the arterial starts hypertrophy. What does that mean? It means you can clamp down even harder. Does everybody see we're still moving backwards? Hypertension is still getting worse. It's not getting any better. It's not getting any better. So now blood is moving 300, 400 miles an hour. Abrasion, zoom, 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 zoom. What do you do with all that zoom, zoom, zoom? You Hylanize. You Hylanize. That means you become a tissue that can handle a lot of abrasion. That's called hyaline. So now you see hyalinization. Okay? Everybody understand? I'm going to talk you through it again. This is why the nurse yells at the doctor when the systolic pressure reaches 60, because hypotension is about to kill your patient. Doctor, you better tell me to do something. This is the reason why we say, okay, put 2 large bore IV needles in somebody after trauma. Because you want blood coming up from the legs, blood coming down from the upper body. One of those is going to reach the heart. All right, because you don't know if the IVC is torn. That means the one from the leg can't get there, but the one from the arm can. That's why they say 2 large bore IV needles in every trauma patient. We understand it. It's not just, oh, the author said to do that. It was a reason why they said to do that. Okay? 2 large bore needles must be given. Must be started, really. All right? 1 above and 1 below the diaphragm. That's where we like to put it. 1 in the leg, 1 in the arm. If blood pressure goes under 60, you'll lose all 3 important organs, and that would be a bad day. Okay? So keep it between 60 and 160 systolic. Now, for the hemorrhagic infarct, arterioles cannot control blood pressure after a certain amount of time, usually years. The capillaries get involved. But when they get involved, things get worse. All right, now we're at this point, hyalinization. This is where the arterioles decide to hyalinize so they can handle all this abrasion, blood flying through here 300-400 miles an hour. Any questions on that? That's why anytime you see hyaline arteriola, notice arterioles, arteriolosclerosis, it means the person has chronic hypertension. Amy, where are you going to see hyalinization first? What organ? In the kidney, who's after that? In the heart, who's last? The brain. And if your blood pressure keeps going up, let's say you got a plaque in your coronaries. Remember I showed you? The high velocity can rip and crack one of those plaques. You just had a heart attack. Here's why hypertension is the #1 cause of renal failure, heart attacks, and strokes. Look at that. One process. Because one process does all 3 things. Okay, so chronic hypertension, hyalinization. What if the arterioles can now get the blood pressure down? Then they'll go back to being normal. But then the blood pressure goes back up, Karen. Then you hyalinize again. Then you get the blood pressure down, go back to normal. So now you see normal, hyaline, normal, hyaline, normal, hyaline. You know what we call that? Onion skinning. Now you know what it is. Onion skinning means you got hypertension that doesn't always stay up. Sometimes it actually normalizes for a while, and then it goes back up again. The best example of this is scleroderma. Scleroderma, that's its normal epidemiology. 3 or 4 years of bad hypertension, 3 or 4 years of normal blood pressure again. 3 or 4 years of bad hypertension, 3 or 4 years of normal again. The most onion skin is seen in scleroderma for that reason. But I want you to understand the physiology of onion skinning. That way, when they say the vignette, you don't just kind of read past it and that's it. They're telling you it's blood pressure that goes up and down. It doesn't stay high all the time, doesn't stay normal all the time either. Any questions so far? Kara, sorry. No, when capillaries take over control, they want control of flow. But arterial, excuse me, but arterioles speak the language of resistance or pressure. The problem is that travels in the opposite direction. Because the decrease in flow, you have to face a constraint, but you're increasing pressure. And here we're trying to get the blood pressure down. So that's why when the capillaries take over, that's it. Bad things are going to start happening eventually. And we're just talking it through. You go from hyalinization first to underskinning second. And then if the blood pressure still doesn't come down, Bailey, your arterioles say we got to do something we never thought we'd have to do. Maria, they do something you never expected. They start replicating. Smooth muscle is not supposed to replicate. Smooth muscle is not one of the rapidly dividing cells in your body. It is when you got hypertension. Right? So when you start replicating cells and increase cell number, what's the term for that, Bailey? Not metaplasia. That's to change one adult cell type to another. Dysplasia means you've just turned over to cancer. I'm still waiting for you to start replicating. Fatima, I'll help you on this one. So what happens when you start replicating cells? There's a term for that. No, not just mitosis. There's a name for it. When you start replicating in response to resistance. All right, so on. It's called hyperplasia. And look at that. That's why you get hyperplastic. Notice hyperplasia. Hyperplastic arteriosclerosis, which says you got malignant hypertension. You understand, Halima? You got malignant hypertension because your body says this blood pressure has now come down. Arterioles do you jump? And arterioles start replicating. Smooth muscles start replicating. It's not supposed to do that. That means you got malignant hypertension. Which means you might want to do something real soon, get this under control, or else organs are going to get sacrificed. All right, Halima, you have a question? This is the phases of hypertension. Yeah. Yeah. Yeah, it goes in that order. Hypertrophy first, hyalinization, then onion skinning, and then hyperplastic changes. Yeah. So that's why understanding the terms. Yes, sir.
So the suffix sclerosis got put in when you went through the hypertrophy, because that made it initially.
No,
target?
scarring. Sclerosis is scarring. So when you start to hyalinize, that's a scar tissue. Yeah, not when you have hypertrophy. All right, so malignant hypertension. Now let's look at the other terms after that. A hypertensive crisis, folks. Hypertensive crisis says your blood pressure went up in a real short period of time. When anything happens in a short period of time, remember that can be quite devastating. Like when you throw an embolus to your brain, how come it's a massive stroke? Your brain wasn't ready. When you throw a clot to your leg, devastating. Why? Because your leg wasn't ready. Same thing here. And blood pressure goes up real fast. For whatever reason, we call that a hypertensive crisis. Okay? A hypertensive emergency or urgency says your most important organ is now in trouble. What's the most important organ in your body? Halima. The brain. That's why the person comes with a headache, double vision, blurry vision. All right, feeling that throbbing going on. That means you better do something within the hour, or else you're about to lose your patient. That's the rule. In hypertensive urgency emergency, the brain is in trouble. You have to do something within the hour to get this blood pressure down, or else we're about to lose the patient. And what's the best drug for hypertensive crises that you've learned, Justin? Who? Sodium nitroprusside is the answer. How do nitrates work, Justin? Talk me through this venodilation stuff. Remember, direct action stimulates nitric oxide, which activates guanylate cyclase, which activates cyclic GMP. Yeah, they don't always just jump straight to that's 4 steps down the line. So I don't want you to miss the question. All right, so nitrates, nitric oxide, activates guanylate cyclase, which activates cyclic GMP, and that way you dilate your veins, then your arteries, your blood pressure is going to come down no matter who you are. And that's why that is the best drug for hypertension crisis. What if you don't want to use a nitrate? What beta blockers can I use instead? Olivia Spalding.
Carvedilol, metoprolol, and there's a B one.
No. You give me the list of beta blockers with decreased mortality after MI or heart failure. There's another list I'm looking for. What beta blockers can be used for hypertensive crisis? All right, Anna. So it's labetalol and carvedilol, those two, just those two. Which one? Nebivolol is not as effective. I mean, it's supposed to vasodilate, but it's not as effective as the first two. The first two, labetalol and carvedilol, are the best choices in real world and on test questions. I've never seen labetalol get a point. All right, why? Because it blocks beta 1, beta 2, and alpha 1. Your blood pressure is going to come down if I block 3 receptors. Everybody follow? Nebivolol is just a smooth nose relaxant. Yeah, it dilates a little bit, but nowhere as much as the other two. So on the test, don't pick nebivolol. Okay? Hypertensive urgency emergency. I need something that can bring the blood pressure now. Yes, sir. Treatment of choice for hypertensive urgency or emergency in a pregnant woman, labetalol is preferred. Why? Because sodium nitric peroxide causes cyanide poison. That's the last thing you want in a pregnant woman. Yeah, they like it for chronic hypertension. Remember, PIH, which is pregnancy-induced hypertension, methodopa is better because it doesn't cross the placenta, no harm posed to the baby. Huh? No, that's for treatment. In a crisis, labetalol is preferred drug. Second is hydrolysate. Yeah, in that order. Any questions on hypertensive crises? Again, sodium nitric peroxide is the best drug of choice. You always look for that first. They want a beta blocker, labetalol and carvedilol. If it's a pregnant woman, then you don't use sodium nitric peroxide, we go straight to labetalol. Okay, but that's different than treatment of pregnancy-induced hypertension, methodopa, or treatment of preeclampsia, which is magnesium sulfate. But you understand, we're treating hypertensive crises, what I'm talking about here. All right, so that's hypertensive emergency and urgency.
Thank you, sir.
Yes, who's speaking?
Mohammed.
Hi, Mohammed, go ahead.
Sir, I wanted to ask, what value do you see malignant hypertension at?
What do you see? What values? For malignant hypertension, it's usually, I think, over 180 over 110. If you get above that, right, those are the scary numbers. Yep.
Thank you.
Good question. All right, quick review again. Remember I said we're going to be saying things twice. So the nitric peroxide, drug of choice for any hypertensive crisis except in pregnancy or aortic dissection. And for both of those, we like labetalol. It causes cyanide poisoning if used for too long. Remember I said most people use it for like 3 or 4 hours and then come in with something else. So anytime I've seen a vignette where somebody was on sodium nitric peroxide for like 10, 18, 24 hours, I already know they want cyanide poisoning. I click, I don't even read the rest of it. Because you're not supposed to be on it that long. And so you got to know what normal is. I told you that way I've known slaps you in the face. Twice I've seen that. Oh, I've done it for 24 hours. Click, next question. Next one, oh, he was up for 36 hours. Click, next question. And both times, it's still the same cyanide poisoning. That's what I'm saying, folks. Once you recognize your clues, trust yourself. Pick the same answer again. You'd be surprised it's still the same answer. It didn't change. All they do is give you a new story. Yes. Oh, yeah. Yeah, you don't even wait 24 hours. Like I said, 4 hours, maybe 6 hours maximum. No, switch to something else. Yeah. That means we usually switch to labetalol, carvedilol, switch to something else, but don't keep sodium nitric peroxide going on forever because you're going to cause cyanide poisoning eventually. Yep. And it's giving us a continuous IV infusion. Does that make it fatter? What a soluble, Solange? What a soluble? Is an answer to base. Answer. Charge or uncharged? Charge. Oh my God. Large or small? Hard, easy time across the membranes. Hard, volume distribution, high or low. Low, CNS toxicity risk, high or low. Low, who's going to metabolize liver, kidney? Kidney, hepatonephrotoxic toxic. Never depend on GFR P450. GF, what's the most important thing you can do? Get rid of this drug out of your system. Give him fluids. That's not on the list. What am I picking now? Oh, she was rolling, man. Come on, babe. Last question, you had it. What's after that? Fatima helper. Bicarb, oh, you were rolling all the way through, man. And so we give it 99%. Only was the last one. Good job, good job. That's why I say, be on your toes, folks. 'Cause remember, we rehearsed these things so many times. It should not be a surprise when I ask you to tell me the answers. You've been hearing other people say it. It's time you got to say it too. All right, anyway, that's Southern Night Depressed side. What I mean, it saves you a lot of reading. But if you don't hear it and what I say, now you want me to go start talking about it. I'm not going to waste time talking about that. That's something you already know. Okay. All right, cyanide poisoning. Again, a quick review. You heard it biochemistry. Causes a conformational change in hemoglobin, making it unable to bind oxygen. So what happened? Oxygen saturation low, PO2 normal. Who else has that profile? Saturation low, PO2 normal, Gloria. Where they can't pick up oxygen. Carbon dioxide binds the iron, so saturation is normal, PO2 is low. It's the opposite profile. I need somebody else who has that same profile. Hendrik.
Lead poisoning?
Not lead poison. Let me ask Eric.
Is that methylglobinemia?
Yeah, methemoglobinemia. Remember, if the iron is 3+, it can't pick up oxygen. She gets the exact same profile. Saturation low, but the PO2 is still in the blood. You just can't pick it up. All right, very good, very good. Treatment, remember 4 things to do for cyanide poisoning. Ammonitrite, what's that gonna do? Oxidize the iron at 3+. When you oxidize something, Cynthia, did you give it electrons or snatch its electrons? Okay, wait, if I oxidize you, did I give you electrons or snatch your electrons? Right. Okay, you answered for the wrong profile when I asked that question the way the first. It all depends on how they ask it. You gotta, what angle do you take? All right, so yeah, I've snatched your electron. So ammonitrite, oxidize the iron to 3+, and 3+ has a higher affinity for cyanide. That's what you want. You want the hemoglobin to bind to cyanide so it can't get into the cells. Remember, it can destroy electron transfer, which is even more harmful. You got to keep that cyanide from going into the cells. Let it bind to hemoglobin. We'd always replace him. Then we give him B12. Remember cyanocobalamin. B12 has a strong affinity for cyanide. Now you can snatch it from hemoglobin and then pee it all out. And then methylene blue will turn the iron back to 2+, and then transfuse to make up for whatever hemoglobin did get destroyed. You understand that, Halima? You understand that, Melissa? All right, you understand that, Ashley? All right, cool. So sign that point. Yes, I know. Oh, okay. Yeah, that's a good question. Yeah, that can be on step 1. How much should you bring somebody's blood pressure down acutely in a hypertensive emergency? They always say bring it down at least 10 to 15%. That means right away, and then let the rest just drift down slowly. Because that 10 to 15% takes the pressure off your brain. At least that headache goes down. Intracranial pressure goes down. That's what you want. And then let the rest come down slowly. Okay, so cyanide poisoning. Veins and venules now. Veins and venules, Ida, have the most capacitance. Capacitance means to hold on to. You understand? That means your veins and your venules hold on to most of your blood at any one time. All right. So the person is dehydrated. Which vessels are holding on to most blood now, Ida? Still the veins and venules. Does everybody understand? I don't care what wild story they got on your exam. The veins and venules hold more blood than anybody else, no matter what's going on. All they do is make up a whole new story and hope that you're going to talk yourself into, no, well, it got to be the other vessels now. No, veins and venules hold 60% of your blood volume at any one time, no matter what the situation. You understand, Miguel? All right, you understand, Rachel? All right. So therefore, Rachel, your veins and venules depend on what we call skeletal muscle contractions to squeeze the blood upward. So you got all this blood draining down towards your feet because of gravity. As you walk around, folks, the muscles in your legs squeeze that blood back up to your heart. What if you don't walk around and that blood is just pooling in your legs? Everybody understand that? And that's why the #1 cause of venous clot formation is what, Chris? What's that called? No. The #1 cause of venous thrombosis is what? Yeah, it's called stasis when you're not walking around. But that's the word you got to use, is stasis. That's why stasis is still the #1 cause of venous clot formation. What's the most common cause of genetic venous clot formation? Miguel. Now protein C division, close door, Michael. Factor V Leiden is #1 when they say genetic. All right, but you can see why a person's got to stay mobile. So that blood keeps squeezing back up to circulation. You understand, Summer? That means if I just sit here all day, like a bus driver, like a 16-hour flight from India, that means your blood stays down your legs the whole time. It's only a matter of time before a clot forms. So your veins have one-way valves which move blood from superficial to deep veins, which I showed you before. Superficial down to deep is like 290-degree angles, and then into the IVC. For a DVT to cause swelling, for years we thought, first of all, if you come in with one leg swollen, the answer was DVT or through otherwise. Everybody understand that? Steve, what if you got 2 feet swollen?
Why would you have bilateral?
I don't know. I didn't say you have bilateral DVT. You got to tell me why. You asked me why do you have a bilateral. I didn't tell you the person has a bilateral DVT. And let's ask Solange. She's rolling today. Right side of her face. That's my point, man. It's not a DVT. So anyway, I'm just reminding you. One leg swollen, DVT or through otherwise. Both feet swollen, you got right side of heart failure. And the most common cause of right side of heart failure today, cares. Today, but not yesterday or tomorrow. Most common cause of right side of heart failure. Too much fluid, it's not going to be the answer. Let's see what Halima says. Right side of heart failure, #1 cause, right side of heart failure. Let's see what Jess says. No, Jess has it now. Left side of heart failure is #1. I told you, pay attention to the lung exam when somebody comes in with heart failure, because that's the only way you're going to really be sure whether it's right or left. Okay, because when it starts with left, that's a whole different scenario than if it started with right. Management is completely different. Right, fluids only. Left, never fluids. That's why you got to be clear on which one are you treating. That means if you don't verify it, it's so easy to give away that point, folks. So easy, because everything else is the same. They overlap. All right, so somebody did a study years ago to find out that whenever someone comes with a swollen leg, the clot didn't happen that day. We thought the DVT happened today, now you got a swollen ankle. No, happened several days ago. But here's all the things that have to happen before you see a swollen ankle. #1, DVT occurs. Then you have increased hydrostatic pressure. That means blood is backing up. That means the one-way valves will get stripped. One-way valves allow blood to go this way, but if the pressure starts building up, see that pressure rips it backwards like that. Now you have insufficient valves. Blood flows now from deep to superficial. You see that blood is moving backwards now. So it's supposed to go only from superficial to deep. Now it's going from deep to superficial. Now you have increased hydrostatic pressure in the superficial veins. You understand that, Josh? You understand that, Halima? Blood is backed up to superficial. Blood then oozes out of the superficial vein. Then lymphatic vessels outside of the veins will pick it up. That means you have a safety mechanism when blood oozes out of veins. Your lymphatics will pick up proteins and fluid that leaks out. Any questions so far? All right, lymphatic channels then get overwhelmed and full of stuff, and then fluid leaks out of lymphatics, and now you got swollen extremity. Remember, we saw one question. I don't know if you guys remember, there was one lady who had pictures of all those varicose veins, and they said, which one of the following was true? And the answer was stripped veins. This is what they're talking about. That one study proved that when you see him, it didn't just start that day. This person's had a clot in there for quite some time. Okay? Yes, sir.
Doesn't it also present with increased temperature?
What has increased temperature?
DVT?
DVT doesn't have to have increased temperature.
Trying to figure out why it would have.
I mean, you can, because warm blood is sitting there. That's the only reason why it gets warm, but warm by itself, you start thinking about cellulitis. Yeah, DVT doesn't have to be warm at all. All right, any questions on DVT? If you got DVT, the first medication I should start you on, Olivia Spalding. All right, Leslie Gonzalez.
Heparin?
Heparin, how does heparin work?
What you said again, doctor?
How does heparin work?
It's works like activation of antithrombin 3.
Right, there's a cofactor for antithrombin 3 to activate it. That means you block thrombin as well as factors 9, 10, 11, and 12. How long does heparin have to overlap with other anticoagulants? Leslie?
2 days bridge.
Yeah, 48 hours. But what if you don't want to do a 2-day bridge? What drugs should you start instead?
Apixaban or rivaroxaban.
All right, so apixaban, rivaroxaban. Ready to follow? Okay, but if you're gonna start warfarin, how long do they have to stay on it for the first clot? And you know how they got it?
3 months.
3 months, second clot, and you know how they got it?
1 year
Yeah, 1 year, third clot, and you know how they got it?
for life.
For life, or at any time you don't know how they got it, they're on it for life. All right, so don't forget, that's just like the third, fourth, I don't know, 17th time that we're going through that. So that means next time I drill somebody else, nobody's looking at me all strange. That means you gotta know that profile. All right, workup for DVT. If you think there's a low probability, what would that be? An athlete. If you're an athlete who exercise every day, 3-4 hours, practice for your sport, there's no way you should have a DVT. So if you come in with one swollen ankle, say, man, this is low probability. This guy who runs basketball every day for 4 hours. Okay, that's when you do D-dimers. D-dimers, name, represent pieces of a clot that's chopped up somewhere in your body. You understand me? You understand, Josh? So if the D-dimers is positive, and the number for the step 2 and 3 is above 500. Anytime it's above 500, that's positive. You have to work them out. So that means there's clots being busted up somewhere, and so it could be the DVT, you don't know. But if D-dimers is negative, I know for sure that swollen ankle is not a clot. So it has like a 99% negative predictive value, but not positive predictive value. That's what it's good for. But low probability. If I want to be 99% sure you don't have a clot, do a D-dimer. If it's negative, you ain't got a clot. But if it's positive, you can have a clot somewhere in your body, not necessarily the one that's in your ankle. I don't know. That's why I got to work you up now. Any questions on that? Just so you know when D-dimers are indicated for workup, low probability. All right, if you got moderate or high probability, that's somebody who lays around, no, I'm going to work you up. That's Doppler ultrasound is what it's called. Do an ultrasound and you'll see blood looks black. When you do an ultrasound, blood is black, black, black. Also you see white. A little chunk of white. That's the clot. And that's the way they'll describe it to you. You'll see a short segment of white appearance. That's a clot. Now you have to put them on heparin and so forth. Yes.
Is that the test when like red goes away or?
No, red goes away, blue goes towards, that's on echocardiogram.
Oh.
Yeah. So Doppler ultrasound is the quick and easy, because ultrasound, no radiation, no trauma, no nothing. Just put a little bit of gel on their ankle and then start doing the ultrasound. All right, further control of blood vessels. Your veins. Let's go to Sandra, you're following me now. Your veins, Sandra, are under parasympathetic control. If they're under parasympathetic control, are they usually dilated or constricted? Dilated, because parasympathetics dilate. If you dilate a vessel, Sandra, what happens to flow? Increase or decrease? Huh? Point up or down, so I can't tell what you're saying. Point up or down. Increase. When you dilate, flow increases. What happens to velocity? Velocity decrease. Everybody understand that? So that's why when you stab a vein, like when you want to start a venous catheter, when you stab a vein, notice only one drop of blood oozes out. That's it. That's because you have lots of flow, but such low velocity. Hardly any blood is lost when you stab a vein. Stab an artery, what happened? It's going to sprain across the room. That's because the arteries are under constriction. We'll get to that in a second. So veins under parasympathetic control, that's why they're usually dilated. Blood flow rate is quite slow. Okay, example, subdural hematomas. Subdural hematoma, most common cause is trauma. Little old men and women get this all the time. They bump their head on something, They don't think anything about it. 3 or 4 weeks later, now they're about ready to die. You gotta take the surgery real quickly. But they'll ask you, how come it took 3 or 4 weeks for it to present? This velocity is so slow. You can't collect fast. You only collect slowly. Subdural hematoma. Usually involve bridging veins. If they want to make an anatomy question. Bridging veins. Trauma is the most common cause. Little old men and women get it all the time. When you do a CT scan, what do you see? A one-sided crescent, because it pushes the brain down like that. So you see a one-sided crescent on CT scan. Then you go straight to surgeon, evacuate it before they die from it. But they love to ask, why did it take so long to finally present? That's because veins cannot collect blood real fast. Any questions on that? What if hypovolemia develops Elishiva? Elishiva.
Yes.
All right, you follow me for a minute. You ready? Say yeah.
Yeah.
Okay. I love that enthusiasm, girl. So I gotta send you some Mountain Dew, man. All right, so if hypovolemia develops, Elishiva, the first thing your body does is venoconstrict. Now notice all your books say vasoconstriction, but they didn't tell you the veins constrict first. That's what I mean, how books can be misleading. Not that they mean to, but the author just says in a way that is very misleading for test questions. They figure you were supposed to know the physiology. Veins always constrict before arteries, but the books don't mention that. Why do you want to venoconstrict first before vasoconstrict Elishiva? Because your veins have most of your blood in them. You understand? It's got to make sense for you to remember it. The veins have 60% of your blood. Your body says, let me squeeze some of that blood into circulation. I need that right now. And that's what it does. Squeeze it. And then the volume gets back into circulation. Okay? Venoconstriction is always first before vasoconstriction. You understand that, Elishiva?
Yes.
All right. Who controls all of this? It's your autonomic nervous system. Elishiva, what neurotransmitter controls autonomics? Hey, Elishiva, this is where you're supposed to say something.
Acetylcholine.
No, not acetylcholine. Who controls your autonomic nervous system, Michael? Norepinephrine is not a neurotransmitter. Let's see what Maria says. Then say norepinephrine. Then it's norepinephrine. Thank you very much. It's norepinephrine. Controls all your autonomics. And norepinephrine, Maria, has a higher affinity for alpha or beta receptors. Alpha. So it turns out, folks, that there are actually more alpha receptors on your veins than your arteries. How come the books go on and on about alpha receptors and arteries like they have most of them? That's not true. Never has been true. Your veins have more alpha ones on it. That's what ensures that you will always venoconstrict before you vasoconstrict, folks. But the books just kind of leave a lot of stuff out. Okay? Venoconstriction must always occur first. And if venoconstriction happens, Elishiva, is in your skin and GI. That means there's even more alpha receptors in the skin and the GI than any place else. That means anytime you're hypovolemic, Elishiva, what two organs will lose their blood flow first?
The skin and GI.
Skin and GI. Everybody clear about that? Skin and GI. That means if you're dehydrated for a long time, what organs lost their blood flow first? Elishiva.
Skin and GI.
Skin and GI. Does everybody understand? Anytime you lose volume, skin and GI are going to lose their blood flow first. Everybody understand that? Anybody not understand it? Speak now. Okay, we'll see shortly. Anna, at your level, when somebody goes to surgery and you cut them up, don't they lose blood? Don't they lose volume? Yes. So if they lose volume, are you going to veno or vasoconstrict first? Venoconstrict first. And what two tissues lose their blood flow first? What? Did I hear something about liver? I wouldn't say that on the test. Nolan, remind him. Thank you very much. Skin and GI will lose the blood flow first. Everybody understand that? Everybody understand that? Everybody understand that? You really understand it? How about if I explain to you why people are always so cold right after surgery? How come you have the nurses in the recovery room giving them 2 and 3 blankets? That's because their skin lost blood flow a long time ago. And how come your skin peels off after surgery? I wonder why. Huh? How come you have an ileus after every surgery? I wonder why. It's how they drill you guys. But see, did you ever understand it? Or are you gonna say, oh my God, they put surgery questions on step 1? That's how they know you don't understand what's going on. It's still the same physio. Surgery, you lose blood. That's volume. You lost volume, there it is. Same response all the time. Same response all the time. Basic physiology all the time is what I keep saying. But most physicians always swear something different. I say, okay, you pick your answer. But you don't realize you're picking the wrong answer. Because it's the same response all the time. Okay? I remember years ago when I had surgery, and I remember when I was recovering, and when I was in my room, I'm sitting down in a chair. When I got up, I saw a layer of cells on that chair. You know, you're always wearing the gowns with your butt hanging out. So you see the imprint in my skin, just a layer of skin just peeled right off. That's what you expect, folks. That's what normal is. Okay? You know, because when the incision is still fresh, you can't take a shower, can't take a bath. So I can't do anything about it. But every time I sat down, layer of skin came off again. There it is right there. Okay? And I can't eat until the surgeon says what? Till you got bowel sounds. See? Gotta wait till bowel sounds return. But then they'll ask you, how come the bowel sounds went away? All of a sudden the residents don't know. It's still basic physiology. But they swear some surgical literature you need to figure this out. I said, no, go back to physio. You can figure it out from there. Okay, much easier. So anytime you're hypovolemic, skin and GI, that's why you have foreskin turgor as the first sign of hypovolemia in anyone. That's why, like in pediatrics, what do? We feel their hands, we feel their feet all the time. Because the baby can't speak to you, but physio can speak to me. If I feel those hands and feet and they're cool, this baby's in shock already. Because he's responding to hypovolemia, whether you knew it or not, baby's in shock. Years ago, they did a survey of pediatricians. They said, what is the definition of shock? But your pediatrician says when the blood pressure drops, which means most pediatricians don't even know what shock is. And a person who's in shock, the cool extremities says when you're in shock. You know what the definition of shock is? Insufficient blood flow to feed the rest of your body. I mean, to feed all of your body. So if you got cold hands or cold feet, that means you don't have enough blood flow to feed your entire body. So you start shunting. The minute you start shunting, you're already in shock. That's called compensated shock. But most pediatricians didn't know that. If you gotta wait till the blood pressure to fall to call it shock, you're way, way behind. Because that means all the compensatory mechanism slipped right by. You didn't see any of that. You waited till the blood pressure fell. That's when compensation has fallen apart. That's very late in the game. Here it is. Foreskin turgor. Loss of bowel sounds and ileus. Look at what we measure as physicians. Cool extremities. That's what we do in peds. You on the vignette, they say decreased capillary refill. Now you know why they're telling you that. Normal capillary refill should be less than 2 seconds. It should be instantaneous. But once you hit 2 seconds or more, that's delayed. You're hypovolemic. Mottled skin is another way to describe it, or the medical term livedo reticularis. All that means your skin does not have enough perfusion to it. That means you are hypovolemic, whether you knew it or not. Or call it compensated shock. A way to help you get back on track, Ida, is to call them AV anastomoses, arteriovenous anastomoses. These are connections between arteries and veins that allows blood flow to shunt real quick. So, Ida, here's your capillaries on one side like that, coming around to the other side. The other side is your veins and venules. So I'm going to make them blue and return it back down like that. AV anastomoses are these arrows. Look at that. See that? They can take blood that was on the capillary side, shunt it very quickly to the venous side, so that way you can return it back to circulation to protect your core. Your core is your brain, your heart, and your kidney. AV anastomoses allow you to shunt blood from capillaries to veins so that you protect the 3 most important organs, brain, heart, kidney, all the time. You understand that, Zena? She understands. You understand that, Meha? course you understand it, man. Tough little woman, man. She got this. All right, check it out. You follow me now for a few seconds. So avian anastomosis allow you to shunt blood away from non-essential organs. These avian anastomoses are concentrated in your fingertips, your tip of your toes, tip of your nose, lips, and earlobes. Meha, can you explain any disease for me based on what you just learned? Just one connection. Let me slide over here. Anam, give me one connection. Ileus. So how does that, look at this stuff right here. Just this stuff here. Your fingertips, tip of your toes, your nose, lips, and earlobes. What? Raynaud's phenomenon. How come all this stuff shunts? Spontaneous business pattern. That's what Raynaud's is. Spontaneous business pattern. Why do you think you lose all these areas right here? Anybody else got one for me? Cares? Sickle cell. How come these are the most vulnerable areas? Now you know. Chris? Frostbite. Frostbite. What do you think about the areas we gotta amputate? How come the tip of your nose is freezing when it's cold outside? Just like when you go outside right now, it's cold as it is, almost below zero. Your lips are suddenly chapped. What do you think I got my chapped lip? Today I gotta use it like crazy. Why? Because it's cold outside. Okay, so that means blood is shutting away from your skin. Okay, that means if I don't, and then I can't speak, because now my lips are sticking together. Okay, so you gotta do something. All right, you don't think about it, but that's what is going on. It's cold outside, all of a sudden, the tip of your nose, your ears are burning. Where do you think? Look at the pen right here. It's right in front of you. Right in front of you. How about a septic person? I mean, I walk in the ICU room of one of my septic patients, you see the tip of the nose about to necrose off. And one day I finally understood why. Their fingertips and toes start turning black. All of a sudden, one day I understood why. Whereas before, I didn't know why those particular places. It just happens. That's what you're going to be told. Oh, we always see that up here. No, there's a reason. There's a very good reason. Okay, now you understand it. All right, Jess, what's your question first? Do I worry about GI necrosis and someone with a hypertensive crisis? Of course I do. Because the GI is going to lose his blood flow pretty early. Yeah. And people have sepsis, you can see ischemic valve. Think about babies with necrotizing enterocolitis. How come they get ischemic valve? Same thing. Anything that makes you hypovolemic, you start shunting, you run a chance that you can necrose your bowel. During surgery, when you're losing blood throughout the surgery, why do you think the surgeon's running normal saline the whole time? To make sure your blood pressure does not fall. Because if it falls, that bowel can necrose. See? But instead, it's just written down as a protocol. Everything's protocol. And so physicians just think, oh, well, I don't need to know that because I can just read it off the wall. And that's why we fall further and further behind with understanding. Because everybody just says, oh, that's the protocol. That's not the answer. Well, who wrote the protocol? Ask him that. Because he wrote it down based on physiology and everybody just reading lines now. Okay? Disregarding the physiology that brought that protocol together. Yes, Chris. Hypertension can lead to ischemic valve, yeah, and any one of these, yeah. All right, so fingertips, tip of your toes, tip of the nose. Now, here's incredible phenomenon in surgery. I remember I used to see this, and then one day I understood it. When you start surgery, the surgeon takes a scalpel, cuts the patient's skin, let's say the belly, cuts open, belly opens up, you see blood pour out. Ready, follow? If you keep an eye on that wound, within a few seconds, shoot, the blood disappears like that. Shunting just started. How come they don't bleed anymore throughout the whole surgery? Eh? Ever wonder? You don't have to wonder anymore. In case the surgeon ever asks you and you're in a surgery rotation. Look at that, you can explain it easily. Because shunting is just clicked in. That's the avian anastomosis. Shunt away from the skin. Okay? That's automatic. Now, over to let's see. Yeah, somebody had picked on. Oh, Paul, my man. Yeah, in the front row, I haven't picked on you all day. All right, Paul, here we go. Let's say this is your GI tract. We know we're gonna show from the GI tract, right? Skin and GI first. Watch carefully. Blood normally goes up like this, from the submucosa to the mucosa and then back down. Follow? All right. Where do you find digestive enzymes in the GI tract, sir? Which layer are they found in? Now, if you're eating food, I thought the food touches the mucosa. How's it gonna touch the stomach? That means you have to get ulcers all the way throughout your GI tract. Yeah, everybody understand your digestive enzymes and mucosa? That's the only one that touches the food. Everybody understand that? Now, Paul, if you start shunting for any reason, who's gonna lose his blood flow first? The submucosa or the mucosa? Does everybody see the mucosa is gonna lose the blood flow first? Does everybody understand why therefore after every surgery, you lose your entire mucosa? Why do you think we cannot feed a person right after surgery? See, again, another protocol. They tell you, oh, protocol, yeah, NPO. That's why we got an NPO before surgery, folks. You ain't got no enzymes after that surgery. You cannot digest the food, even if you wanted to give it to them, you can't digest it. Takes about 48 hours to get all your digestive enzymes back. The whole protocol for refeeding a person is based on 48 hours. Gee, but most residents have no clue. Why is it 48 hours long? They forgot. It's just a protocol. It's just written that way. All right, what you do is start with clear liquids. You want the liquid to flow over the mucosa. That reminds the mucosa, hey, there's something coming. And the mucosa all of a sudden starts regrowing and the enzymes start coming back. If they can handle the clear liquids, you say, okay, full liquids. That's like soup. And now it's got a little protein, a little taste to it. And then the mucosa gets, oh, there's some protein in it. Oh, let's get some more enzymes up here. See that? And then after that, the next day you say, okay, clear, full liquids, soft diet. Soft diet is like mashed potatoes, applesauce, that kind of stuff. You say, okay, no problem. You can handle that, regular diet, get out of here. You discharge it. 48 hours, you're feeding, kick you right out. All right, that's why they used to make hospital food so bad, because they want you to get out. Nobody wants to stay there and eat hospital food. Josh.
So you lose that mucosa.
When you lose that mucosa, how did that relate to post-opioid constipation? No, it's not about that at all. Post-opioid constipation is when you're using opiate, heroin, for so long, or morphine for so long, that the gut won't move anymore.
Yeah, but if you have that dying tissue.
But you don't have dying tissue in opioids, though. Because remember, they're relaxing, so they're gonna vasodilate. You still have tissue there. Yeah, it's just not moving, okay? There's nobody as obsessed with passing gas as much as a surgeon. If you're on surgery rotation, every morning, what's the first thing you ask you? 301 pass gas yet? Hey, lady in 402, did she pass gas yet? He got to go down the whole list and see who the hell is pass gas today. Because if they pass gas, what's that mean? The gut is waking up. All right, let's start feeding him so I can get her out of here. His liability stops once that person is feeding and they get out. He knows he's in the clear. Until that person is feeding, he still has liability because it was his surgery that caused the illness. Everybody follow me? That's why they're so obsessed with that. Okay, but again, they don't explain it very well to the residents. Residents just know you got to wait till somebody pass gas and then you can start clear liquids. Okay? No, it's physiology. Okay, once that gut starts, okay, let's go. Let's get this person out of here. Okay. All right, any questions on avian anastomosis? All right, cool. Another one. Cosmetic surgeons. Guess which areas they're told do not use any extra epinephrine. You want to see that? If you use epinephrine in these areas and constrict too much, there will necrose. This is cosmetic surgeons. If you're in the ER, same thing. If you're going to do a digital block on fingers and toes, see that? They tell you do not use, don't add any epinephrine to that because you don't want that finger or toe to necrose because they're heavily full of these avian anastomosis. You shut all the blood supply away, it'll necrose.
Isn't it like lidocaine with epinephrine?
Lidocaine already comes with a little bit of epinephrine in it. That's why I say don't add any more epinephrine. Yeah. Because you may, if you give too much epinephrine, you constrict it. AV anastomosis will open up.
But they added because they do want the basic.
Yeah, the epinephrine is added because you do want vasoconstriction because you want lidocaine to stick around a lot longer. That's what epinephrine is for. But in these areas, I tell you, don't add any more epinephrine in there. Because if you vasoconstrict too much, the AV anastomosis will open up that whole area of the necrose. All right, any questions on that? Moving on. Examples of AV anastomosis at work, remember frostbite, somebody mentioned? Sepsis, I gave you in the ICU. Do not use extra epinephrine in these areas. Raynaud's phenomena, all that is related to AV anastomosis. What about the arteries? How do we control those? Let's go to somebody, Brenda Rivera. You with me?
Yes.
All right, Brenda, you roll with me for a minute here. So your arteries are under sympathetic control. Brenda, if you're under sympathetic control, are you gonna be constricted or dilated?
Constricted.
Constricted. This is why arteries are always constricted. If you constrict, what happens with flow? Increase or decrease?
Increase. Oh, decrease. I'm sorry.
Yeah, decrease. What happens with velocity?
Decrease.
No. Flow decreases. Velocity increases.
It's true. Sorry.
You understand? This is why
Yes.
when you, put a needle in an artery for like an arterial line, remember I said blood shoots across the room to the other wall. Look at that, because it was constricted, that means high velocity. That's why it shoots out like that. Well, a good example, two good examples. Reactive hyperemia. Anytime you cut an artery, you also cut the sympathetic nerve that was attached to it. That's why blood pours out like you wouldn't believe. Because when you cut that nerve, vasodilate, a whole lot of blood comes out. That's why arterial bleeding is much more deadly than venous bleeding. See? So reactive hyperemia just says you get this reactive vasodilation of an artery if you cut it from any direction. A good example, epidural hematoma. An epidural hematoma, most common cause, trauma again. How'd you get it? Trauma to the temple. Anybody know what sport has the most trauma to the temple? Raise your hand if you think you know. Oxane, baseball, number one. I mean, the first time I saw that question, Oxane, I picked, I picked football. I was thinking about the head-to-head collisions that happen all the time, but they're wearing helmets. Baseball was not. So the ball's coming at you when you're standing there at the bat, the ball's coming at your temple the whole time. Bing! That's it. The most epidurals have been recorded in baseball, and of course they died 2 hours later. That was before concussion protocols. We didn't even know what the hell a concussion was. So the guy was, remember, they got a little foggy. Hey, I'm all right, coach. I'm all right, coach. Back in the game, back in the outfield. 2 hours later, the guy would just drop right there in the outfield and be dead. That's it. Because you waited too long. Where's the 2 hours coming from? Anybody remember where the 2 hours come from? Melissa? Where's 2 hours come from? That's right, girl. I know your name now. I'm gonna call your name all day long. All right, Josh. Serotonin, thromboxane, we're off. That's all. Why don't you just tell me that? All right. So remember, you got a reason now to explain things, folks. But you got to know how to explain them. I told you there's so many questions when they ask you to explain things. All right. So if I don't make you think about it now, you're gonna be facing on the exam and be drawing blanks because you've never been challenged. Okay, there's too many questions with explain this, explain that. Well, the 2 hour lucid period, I explained that to you when we did clotting. It's thromboxane and serotonin wearing off at 2 hours. And then all of a sudden, blood vessels open back up, whoosh, whoosh, they die. So with epidural, you got to catch it before it happens. So what do? CT scan. What are you going to see? This epidural, you see outline of your scalp, outline of the blood impression. So that's why they call it lens shape, like your eye, your lens. It's lens shape. Remember, subdural was just one-sided concave or crescent shape. This one will be lens shaped, both sides. And then you got to take the surgery right away. You want to save their life. Any questions on subdurals, epidurals, arteriovenous bleeds? All right, now let's talk about receptors that make everything happen. Any receptor is going to start in the veins. All right, alpha-1. Since you wanted smooth muscle contraction, remember, IV3-DAG, second messenger. Because you want to venoconstrict first. You venoconstrict, so boom. What happens to flow? Flow goes down. That's how you slow down the bleeding. What happens to velocity? goes up, so you can squeeze the blood back in circulation as quickly as possible. See, it makes sense, and that's how I remember it. All right, then when it gets to the veins, so the veins, it goes to the heart, and the heart pumps into the arteries. And you want the arteries to get the blood quickly back to the tissues, alpha-1 receptors. Look at that, IP3 DAC again. Because you want the same physiology that she just told me. I want that blood to quickly get back to the tissue that's losing blood. You understand, Halima? Okay? But then if you vasoconstrict, Halima, what happens to flow? Goes down, and that's what you want, slow down the bleed. What happens to velocity? Goes up, because you want blood to quickly get back to that tissue. You understand me? But when it's flowing that fast, 200, 300 miles an hour, can the tissues feed off of that? Everybody see the problem? That's why when you get to the tissues, the capillaries, who feeds the capillaries? The arterioles. Look at the arterioles. Vasodilation. Because when you get to the capillaries, you want to increase flow. That way the tissues can eat. And decrease velocity so it doesn't move by too fast. That's how you got to remember what arterioles do. They're going to dilate when the other two are vasoconstricting. Okay, because their job is to feed the capillaries. Okay, so beta 2, psychic AMP. So when you stimulate beta 2, you actually inhibit psychic AMP. Because remember, sympathetic usually constricts. So you got to inhibit sympathetics and then you get the vasodilation. You understand? Make sense? Yeah, because you want to constrict, and then dilate, right? When you get to the tissue. Any questions about all of that? You understand that, Divya?
Yes, sir.
All right. Adonis, you understand that?
Yes, doctor.
All right. Mohammed, you have a question?
Yes, sir. So is this in just this instance, or is it always that the arterioles always vasodilate or vasoconstrict opposite to the arteriole and vein?
Right. They always go opposite. Correct. But their
Okay.
job is to take care of the capillaries, which are the most fragile vessels. That's why they always go in opposite direction.
To feed the tissue. Okay, makes sense.
Feed the
Thank you.
tissue. That's correct. Question, Chris? Yeah, decrease flow through that one vessel. That's why you constrict. You decrease flow, but you increase pressure. Yeah, but you're regulating how much flow goes through the capillary because they're so fragile. All right, so that's the receptors. Any questions? Yeah, sorry, Paul? Yeah, arterioles, beta 2, sympathetic. So that's why you got block psychic AMP. So when you stimulate, when you stimulate the beta 2, they actually block psychic AMP. That's why you vasodilate rather than vasoconstrict. Yep. Moving on. Capillaries now, the end of the road for the arteries. Capillaries are the vessels that feed the tissues. The capillaries have the thinnest membrane. Why? Because they're made for diffusion. If they're made for diffusion, Justin, that means they follow Fick's equation. So besides having the thinnest membrane, tell me something that you want to exist according to Fick's equation, Justin. What? What hydrostatic pressure? I don't want you just reading that stuff. That's not what I'm asking you about. I said for diffusion of oxygen, diffusion of food, diffusion of glucose, diffusion of anything. What are the things that favor diffusion? One, I told you right there, thinnest membrane. If you have a thin membrane, you go across it real easily. Give me something else. What? Greater surface area. As I remember, capillaries have higher surface area than any other vessel in the body. All right, Steve, give me something.
Concentration gradient?
Yeah, I want the highest concentration of anything to exist at the capillary level. That way it diffuses into tissues right away. Ida. Slow velocity. Look at that. A lot of vasodilation, so there's almost zero velocity on it. That way it moves through real slowly so that those tissues can then feed themselves. See? Again, just reminding you about Fick's equation, folks. Remember, I never wrote that equation down, but I showed you how to derive it for yourself anytime you want. All right, because if you memorize it, you're not gonna remember it. Okay, but if you know how that equation was put together, you'll remember it. And here's another place they'll ask you to apply it. Because if you're talking about diffusion, the physiology of diffusion stays the same, it doesn't change. Okay, all right, so this is an addition to Fick's equation. This is diffusion at the capillary level. Filtration force, FF, equals 2 forces 4. So that really should be a plus. I guess I didn't print out. So hydrostatic pressure in a vessel plus oncotic pressure outside the vessel, that's interstitium, minus hydrostatic pressure in the interstitium, plus oncotic pressure in the vessel. So what you got are 2 forces for filtration, 2 forces against filtration. Here's how to visualize it. I'm inside the vessel right now, right here at the podium, okay? So the amount of water in this vessel is called hydrostatic pressure in the vessel, HV. Everybody follow? If it's high, fluid will leak out immediately. Everybody understand? That's just concentration gradient. You already learned. That's the first principle of all movement. Doesn't matter if you never read it before, you already know it. So whether the book says or not, that's exactly what it's going to do. Any questions on that? Or if you have high protein outside the vessel, to pull that water out. Pull it out. That's what the first parenthesis is. Hydrostatic pressure in the vessel or oncotic pressure outside the vessel will pull water out of this vessel. And then the opposite will keep it in here. So if I got a lot of oncotic pressure here or not enough hydrostatic here, then water will move in. You understand, Melissa? You understand, Halima? All right. So Melissa, if you understand, go ahead. You got to answer a question for me. That means, what would happen to diffusion if I increase the hydrostatic pressure in the vessel? What's that? Increase. What would happen to hydrostatic, diffusion if I increase oncotic pressure in the vessel? You would decrease. Everybody understand? I got to know which side of the equation it's on. All right, very good. That's what I'm saying, because that's the way they're going to test you. And they don't want you just copying the equation. It doesn't mean anything. The question is, do you understand what it means? So they'll give you questions where they'll manipulate one of these factors, or they'll give you a disease that manipulates one of the factors and actually explain something. So, but let's say you got, because there's a heart failure. Explain why you have subdural effusions. Yeah, if you got heart failure, why do you have subdural effusions? Because you have too much water in the vessel, it's just oozing out. But that explains subdural effusion when it's happening up here in your skull, fluid effusion when it's happening in your chest, ascites when it's happening in your abdomen. See that? But they'll just pick a spot and ask you, can you explain this? Why is this happening? See, now it's simple. Anders, explain subdural effusion in somebody with cirrhosis. So low oncotic pressure, that's the word you want to use. Low oncotic pressure, everybody understand that? Because you can't make albumin anymore. And that's your number 1 oncotic substance. So 2 forces for minus 2 forces against. You understand that, Nolan? You understand that, Lillian? All right. That means if the number comes out positive, Lillian, you're going to get more or less diffusion. We're going to have more diffusion. Is water going to move in or out of the vessel? Out of the vessel. If you have a negative number, when you add these up, is water going to move in or out of the vessel? Into the vessel. Everybody understand? Because I've seen questions where they actually interpret the number. It comes out 8. Who cares? As long as it's positive, water will move out. Comes out -2. As long as it's negative, water will move in. That's it. That's the kind of questions they'll ask you. All right. But this way, you know, or they'll take it even further and say, explain why we get mannitol. What's mannitol? An osmotic agent. Therefore, the osmolarity in the plasma is now higher. It's going to pull water in. So it pulls the water out of your brain cells when you got cerebral edema. Okay. Question? Who in there had it? Oh, Fatima. Yes, it's the water that moves. Yeah. So we're always talking about from that frame of reference, water moving. Any questions on that? Yes, sir. This is about how much fluid is leaving the vessel. But if it was negative, that means the fluid is coming into the vessel. Yeah. All right, Michael. Okay, clarification on the terms.
Low hydrostatic pressure, you have water moving in or out.
If you have low hydrostatic pressure, is water going to move in and out of that vessel, Chris? What do you say? Low hydrostatic pressure in the vessel, is that what you said?
Yes.
Okay, which is water going to move? So it's going to move into the vessel. That's what he said. I believe him. I know he's starting to look a little more confident these days, man. I'm telling you, I can tell when a student's starting to see things, man. You know, remember, what's that movie? I see dead people. Here's champagne. I see Vizio. You see Vizio. Okay. All right, any questions on this equation? All right. As blood flows through the capillaries. I remember going through the tissues, they're feeding the tissues. What about after that? Okay. As blood flows through the capillaries, Karina, you with me on this one? Fluid diffuses out, but large proteins like albumin stay in. If the albumin stays in the vessel, what's happening to osmotic pressure as we go? It's rising. Everybody see how it's rising? Because the proteins can't leak out. They're staying within the vessel, but water is moving out. It means osmolarity is rising. So osmotic pressure rises in the capillaries, concentration rate pushes particles out of the capillaries. But why do proteins not freely leak out of vessels? You have two big barriers. Why do proteins, Karina, you still with me? Why do they not just freely leak out of vessels? Number one, barrier, base membrane is negatively charged, just like the proteins. Remember, proteins have sulfates and phosphates on them. Well, so does your base membrane, heparan sulfate. They repel each other. That means if this is your base membrane, Karina, and you got a protein right up here trying to go by, and decides, okay, I'm gonna go near that membrane. That membrane repelling right back up here. And it goes, keep saying that straight ahead. Make sense to you, Kathleen? All right, so Karina, that's your number one barrier. Number two barrier, fenestrations are too small. That means the holes in those vessels are too tiny. Proteins can't fit through them most of the time anyway. You understand, Karina? All right, folks, everybody listen up on this. I'm gonna show you a good transition. What if I saw a little bit of protein leaking out of a vessel, Karina? Is it the first or second barrier that's been sacrificed? If I see only a little bit of protein leaking out. If it's only a little bit of protein, that means it's still under control. That's why you picked the second barrier. Yeah, the smaller barrier. That means somehow your fenestrations have enlarged. First of all, does everybody understand the first hand? If I see only a little bit of protein leaking out of a vessel, that means your second barrier has been sacrificed. Fenestrations are bigger than usual. You understand? Yeah, as long as base membrane is there, that's why it's not just freely leaking out.
For the membranes. Disrupted.
Not yet. They will, and eventually. Yeah, so she's saying if the penetration got bigger, does that mean the base membrane got disrupted? Not yet. But at least you're seeing the transition from one disease to the next, because they will eventually. All right, but first phase, the barrier, the fenestrations that were small have gotten larger, and that's why only a little bit of protein will leak out. You with me? All right, so if the fenestrations are bigger, then that means something is making these cells swell, and so they're separating from each other like that. That means there's inflammation going on. Because swelling is the first sign of inflammation. What do you call it when blood vessels are inflamed? Vasculitis. What funny looking red cells and platelets you're going to see in the peripheral smear? What funny looking red cells and platelets do you see in the peripheral smear? No. Armando, what do you think? Italian vasculitis. What funny looking red cells and platelets do you see in the peripheral smear? They're called schistocytes, torn red cells and platelets. Where are you gonna start bleeding from, Karina? Skin and mucosa or into cavities? Skin and mucosa, what's gonna be elevated? PT, PTT, or bleeding time? Bleeding time. Everybody understand so far? And if you have a vasculitis, that means your risk of bleeding goes up or down. Up. Your risk of clotting goes up or down. Up. Everybody understand it? Now, if your basal membrane negative charge is gone, does everyone understand protein can just leak out whatever the heck it feels like? Now, that's how I know when protein is just leaking out like crazy, your basal membrane has been sacrificed. You understand, Karina? All right. You understand, Barry? You understand, Amy? You understand, Ida? Back to Karina. All right, cool. Well, one day, Karina, one day, it occurred to me that your glomerulus is made up of blood vessels. Thank you very much. That your glomerulus is nothing but a bunch of blood vessels wrapped around each other, which means they got to follow the same physiology as blood vessels. That's, oh my God. I just defined every nephritic and nephrotic syndrome for you. Look it up, see if I missed one. Every nephritic syndrome is a vasculitis. I didn't know that before. One day I figured it out, checked it all out. I said, oh, big damn, you have been memorizing this? But nothing. They're all vasculitides. And then if you don't treat it, what's gonna happen? They start depositing something in the basement membrane. That's why they call it membranous. The books make it sound like membranous is one disease. That's never one disease, that's every disease. When you start messing with the basement membrane, the basement membrane starts getting messed up. They say membranous. That's why they used to say membranous nephropathy, number one cause of nephrotic syndrome. That's because it really encompasses a million diseases, but they never define that in the book. That means the author didn't even know the difference. Okay? Now you know now more. So that means for every nephritic syndrome, it's a vasculitis. If you don't treat it, it progresses to nephrotic syndrome. Something messed up the basement membrane. Didn't have to look it up anymore, folks. Yeah. That means at the end, all I'm gonna do is to give you the clues. The rest of it you can figure out for yourself. Because you're gonna learn everything, what every vasculitis is. And now you don't have to look it up anymore. Okay, because all of them have that in common, is my point. So you don't have to look at that stuff in that long vignette. You can look at the long vignettes. But I don't look most of the stuff. I just look for keywords. Oh, that's outboard. Oh, that's HSP. That's it. In and out vignettes real fast. Okay? But that, my understanding came from here. One day I finally understood what a nephritic and nephrotic syndrome was. Now this one, I first showed this to a nephrologist in Toledo. He was the dean of the medical school. And so the previous dean before him had started sending her students down here, and every one of them was passing, just left and right. Everybody was passing. So when this guy took over, he invited me down there and he said, man, what do you do with these? How come they score so high? I said, well, I teach them patterns. And so he was like, well, what the heck are patterns? I said, well, let me show you one. I said, what field are you in? He said, nephrology. I said, all right, let me get you one right now. This is what I showed him. This is over breakfast. I mean, when I got done with him, I said, there it is. Every nephritic and nephrotic syndrome just got defined for you. I said, did you notice every nephritic and nephrotic is exactly the same? He didn't know. See what happens? Everybody's reading articles and memorizing articles. They still don't see the pattern yet. Every nephritic is the same. Every nephrotic is the same. They don't see it. I said, now go back and look at it. Based on what I just told you, see if there's a difference. You can't see the difference. They've always been the same. No, it's just doctors don't see it because you cannot see what you cannot perceive. If Dr. Shah never put patterns in my head, I would have seen it either. Because I never knew what a pattern was until I met this man. That's why I give him all the credit in the world. Because I didn't even understand what he was doing to me. All I know is one day all of a sudden I'm starting to see patterns. Whereas before I never saw anything. You know, I was just trying to see my way out of the damn exam. That's all I remember. You know, but he started putting patterns in my head, and all of a sudden I'm seeing everywhere I go. And I said, oh my God, I don't have to look this stuff up anymore. I actually can see what it really is now. Instead of just memorizing the book said nephritic syndrome. Yeah, but what the heck is nephritic syndrome? I don't know, that's what the book said. See, that's what I'm saying. That's what students are forced to do. That's what residents do. They just read a line. And it's weird because you read a line, that means you understand it. No.
Basically, any nephritic syndrome is gonna eventually turn into nephrotic.
Every nephritic syndrome will eventually turn into nephrotic if you don't treat it. My man, look it up, see if I made a mistake. It'll blow you away, folks. It's always been there. But the books didn't know it, the authors never knew it, so they never wrote that. So we as students, when we read the book, and doctors when they read it, they swear it's a new disease. I said, no, it isn't. It's a continuation of this over here. And they never knew. Oh my God. Okay? Hypertension, you call over here. Over here, you call it focus on mental nephritis. Look it up. What's the most common cause of FSGN? Oh yeah, hypertension. I thought you all they do is change the names. So everybody swears it's a new disease. I said, no, it is not. It's the same disease. It has a new name. Because one is under nephritic, the other one is put on nephrotic. That's it. That's why they give it a new name. They never knew it's the same disease. Now you know it's the same disease. Now you know it starts out nephritic and becomes nephrotic one day. That's the only difference. The key is if you know what a nephritic syndrome, now you know about all of them. You know what a nephrotic syndrome, you know about all. Now you're gonna hear about renal tomorrow anyway. Dr. Chalk will be talking about renal. And then one day I'll just kind of go through nephritic and nephrotic syndromes with you. All right, so in fact, let's just do it now. I forgot, I put it in here. I used to put it somewhere else. I think I remember now I moved it here for you. All right, since it's relevant here, let's talk about it right here. Proteinuria, because urea means the urine. So 1 + 2 + nephritic, 3 + 4 + nephrotic. So they just want to hint at it with numbers. That's the way they'll do it. That means when they say 1 + 2 +, don't call it nephrotic syndrome. Nephrotic does not do 1 + 2 +. That means significant proteinuria to call it nephrotic. So nephritic syndrome, fenestrations have enlarged. Why is that? You have a vasculitis. What are you gonna see? Schistocytes. That means fluid will start leaking through those cracks now. If you lose enough fluid, guess what? White cells and blood cells will leak through those same holes. That's why you got polyuria and white cell CAS, hematuria and RBC CAS. See that? Whole profile unfolding right here before your eyes. And then you get the hematuria RBC CAS because you lost volume, hypertension because you're going to set up the renin angiotensin aldosterone system. Ooh. Ooh, yeah. Every nephritic done. Every nephritic. You can try hard to find one on where I'm wrong. I'll shake your hand when you find it. I'm telling you, same for every one of them. Doesn't matter which one you look up. Okay, that's nephritic. Pattern C with nephritic syndrome. Okay, you're more likely to bleed, no problem. Call it hematuria if you like. But you have more likely to clot. Okay, remember this before? If I have a partial clot, renal stenosis. A full clot, renal failure. If the clot goes to glomerulus, glomerulonephritis. See that? If it goes to the interstitium, interstitial nephritis. And if it goes to papilla, papillary necrosis. And if it goes through the nephron, focal segmental glomerulonephritis. If it goes through all of them turn into crescents, rapid aggressive glomerulonephritis. Again, the book made it look like all 7 of these are 7 different diseases. I said, no, it isn't. It's the same disease making its way through your kidney. They caught these people at different times in their lifetime. And each author thought it was a new disease, and it was not. It was the same disease. Anna. When a drug is causing an acute interstitial nephritis, right, that's under nephritic. When that same drug gets metabolized and little pieces of it deposit in the base membrane, now we call it nephrotic. That's why every drug can cause membranous. Anything can block it up, exactly. Yeah. Now the question on them, check this out. How do I know which one they want? How do I know which one they want? Listen carefully, watch my arrow. Here we go. Do you want renal stenosis? We'll talk about hearing bruise in the abdomen, in the left or right of the midline. Oh, now I know they want renal stenosis. If they want renal failure, high BU and high creatinine. Glomerulonephritis, blood in the urine. Interstitial nephritis, eosinophils in the urine, or eosinophilia in the blood. Papillary necrosis, a chunk of tissue fell into the nephron. Focal segmental, they talk about scar in different areas of the nephron. Rapidly progressive, you got crescents. The test writer will tell me exactly which one he wants. Don't worry, we always do it several times. If they want renal stenosis, they'll talk about bruise in the flanks, on the sides, just the right and left of the midline. That's renal stenosis. Brewing. Remember, you need 7% stenosis, so you hear brewing, turbulence. They want renal failure, high BU and high creatinine. There it is. I know it. That's what they want. If they got blood in urine, then that's glomerulonephritis. If they got eosinophils in urine or eosinophilia in the blood, you want interstitial nephritis. If they tell you a piece of tissue plugged up the glomerulus, the nephron, that's papillary necrosis. Because when papilla sloughs off, it falls right into the nephron and clogs it up. And then focal segmental, you see scar tissue at different points in the nephron. And then rapidly progressive, you see crescents. That means when their whole glomerulus is scarred up, they look like a crescent. The test writer will tell you exactly which one he wants. And that's the thing I found when I went back and looked at these crescents. I said, my God, the test writer told me what he wanted all the time. I never knew it. That's because I'm busy trying to remember what that first day say about lupus again. See, when we think with details, we don't see the clues that the test writer was giving you. All right, I remember with lupus, if you look at first day right now, it says lupus gives you membranous glomerulonephritis. That's just the most common pattern. I remember when I'm on my boards, they give me lupus as an interstitial nephritis. Eosinophils, I didn't see it. I just put whatever the book told me you see. First day does not tell you, well, this is only the most common, but you can see any of the patterns. That's why I said be careful about memorizing books, folks. You swear you're ready, but you're not ready. Because if all you know is what the book says, you don't realize there's a lot you're missing. The test writer knows how to say it so many different ways until you demonstrate it, you actually understand the whole thing. Solange.
What's the connection between eosinophils
Interstitial nephritis and eosinophils is her question. Eosinophils means you have an allergic reaction. This is a drug causing an allergic reaction in the interstitium. That's why they call it interstitial nephritis or vasculitis. Collagen vascular disease do the same thing, set off allergies. So the test writer will tell you which one he wants. What about nephrotic syndrome? Nephrotic syndrome, Lillian, base membrane has the negative charge is gone. Why is it gone? You've deposited some of that base membrane that covered it up. If you look up every nephrotic syndrome, it has something that gets deposited in the base membrane or something that causes scarring of the base membrane so that you can't see what's down here anymore. And that's why proteins leak out freely. That means all proteins are low. You understand? Good evening. So if you got nephrotic syndrome, what happens to your albumin levels? Down, transferrin, down ferritin, down ceruloplasmin, down gamma globulins, down IgG, down IgA, down IgM, down. And I think you're right. Look how easy it is now. See that? You don't have to stop and think, what did I read in that book? It's a protein in there. Just who cares what protein they pick? Free proteins leaking out. Okay? Just say low and you get a point. Okay? Question? Run what back? I said, when you lose the base membrane negative charge, any protein can leak out anytime you want. All I do is just run through a whole list of proteins. All you gotta do is just say decrease, 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 decrease. Right? What about antithrombin 3 levels, Melissa? Which one? Decrease. Why is it decreased? Because it's a protein. So if you decrease my antithrombin 3 levels, what happens to my ability to thrombose, to form a clot? Decrease. I thought antithrombin 3 is a thrombolytic agent. So it actually more coagulable. Understand? So what's the most common cause of death in nephrotic syndrome? Melissa? Huh? What's the most common cause of death? Melissa? It's heart failure. Stand your ground, girl. Stand your ground. We're trying to change something. All right? It's still the same heart failure, but it's because the antithrombin 3 is missing. Yeah, you form a clot. You die of an MI. But notice, you don't have to think about it for 10 minutes to figure it out. All you gotta do is understand the trend. Every protein is being lost. That means anything I can blame on a protein, I already know what's gonna happen to it. I don't have to look it up. I know.
Is there any reason why the 3 is good leaking out?
Because it's a tiny protein. Why is antithrombin 3 leaking out? It's a tiny protein. All the tiny proteins are leaking out. Yeah. So clotting factors are leaking out, so they get some bleeding. They do that. But antithrombin 3 is leaking out, now you get some clotting. That's why you can get both, a little bit both. But obviously the clots are what's going to kill you. Yeah. All right, now proteins are low. Look at this. Liver will try to compensate, Amy, and say, you know, I'm going to help you. I'm going to give you some albumin in a couple of months. The body says, hey, I can't wait a couple of months. Liver says, well, let me just send you all the low proteins that I can. All of a sudden, the liver sends you all the lipoproteins and all the clotting factors. So all these clotting factors are now clogging up your vessels. That's why they become real hypercoagulable. What about lipoproteins? That's why they get hypertriglyceridemia, hypercholesterolemia, fatty liver, accelerated atherosclerosis. Fatty liver leads to gallstones. See that? I can go on and on. All I gotta do is understand the 2 processes, because it comes down to 2 processes rather than I gotta memorize everything about outports, everything about lupus, everything. No, the process is the same. Either you're at the nephritic level or you're at the nephrotic level. Okay? All right. So all of these fat casts, that's why you see fat casts in the urine. All right, coronary tendinopathies. Remember, like you get De Quervain veins in the thumb, you get carpal tunnel here. All right, man, all these things tied to fats. Hypercoagulability because you lost your antithrombin 3. And most common cause of death for every nephrotic syndrome is exactly the same. Heart failure.
So,
Chris?
so waxy like fatty casts are like a really like a key finding for like really bad.
Yeah, fat cast, so you got nephrotic syndrome. A waxy cast, so you have renal failure. Because that means it took a waxy shine. That means it's been there for a while. Yeah, so. See, I saw somebody's hand up. Up, took it down. All right, folks. Again, you hear all this again in renal. All right, so nephrotic syndrome. I always like to give you the most common, just so you know which one to think. Most common nephritic syndrome in children, it used to be Berger's, remember, update now is HSP. Right, so I gotta update this slide. HSP is the most common nephritic, followed by post-FGN. Most common cause in adults, hypertension, followed by diabetes. That one has never changed. Eric, you have a question?
I think you just answered it, Dr. Francis. I was
Okay.
asking about, I was gonna ask about diabetes
Yeah.
in terms of
diabetes is
proteinuria,
number-
because
Yeah. Go
so
ahead.
we look at microalbuminemia, that would be like our sign that our fenestrations are increasing in size, and
That's
then
correct.
once you
That's
start,
correct.
okay, cool.
Yeah, that's how it transitions. Starts out nephritic and then gets to nephrotic if you don't get it under control. Yeah. Nephrotic syndrome, most common in children, minimal change disease. Most common in adults, focus segmental, followed by membranous. Any questions? Again, you gotta drill it to remember, folks. Don't just look at it once and that's it. Drill, 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 every day drill. All right, moving on. In the veins and venules, osmotic pressure is now high enough. Remember, you're going from the capillaries to the veins and venules. When the time you get there, let's go to Rachel. By the time you get there, you've lost fluid, but proteins stay inside, right? So cardiac pressure is rising. So now osmotic pressure is high enough to pull the waste products into the vessels. And then blood pulls waste products back into circulation. Look how neat that is, folks. That means when you were going through the artery side, things are trying to move out of the vessel, trying to get to the tissues. When you get to the venous side, now things are moving in this way. That's how you pick up garbage and send it back to the kidney and liver to take care of. You understand, Rachel? Was that your hand, Abigail? Somebody, oh, Steve.
This is not in the context of.
All right, what's your question?
This.
What about it? No, we're done with the freaking front. I'm making the veins, you know. I just applied that for you by the capillary level. Now we're in the veins and venules. All right, so this is veins and venules, pulling everything back. Total pressure in a vessel. Total pressure in a vessel. Ashley, your turn. Equals, look at that, linear pressure plus transmural pressure. You understand? Some guys like math, I like physics and biochem. So, what was he doing here? He said total pressure in the vessel. Total pressure in the vessel says either you're going straight ahead or you're touching the sides. There's nowhere else to go. They just wrote a math equation for it. You understand? Okay. Look at linear pressure. Linear pressure equals 1/2 PV squared. P is density, V is velocity. Velocity in the arteries is highest when you come out of the left ventricle. Pump. The left ventricle, when he pumps, blood comes out of there at the equivalent of 150 to 200 miles an hour. And then you got to go around the arch of the aorta. That means somebody says, make a sudden right-hand turn when you're doing 200 miles an hour straight ahead. What's the chance, if there's a wall right ahead of you, that you're going to make a right-hand turn without hitting that wall? Slim to none, right? But your body does it every day. Blood comes out at 200 miles an hour. You see, this is allergies. That's why I got to always get my shots. Blood comes out at 200 miles an hour, and then it's going to make a sudden right-hand turn. The way to do that is got to come out fast enough that when it goes around there, it doesn't touch the sides at all. Otherwise, when it touches the sides, it's going to crush it. So let's say you got 100 layers. That's why your aorta, remember your aorta, you got a thick layer of smooth muscle, right? So let's just write down all the protection. Make it red here. So you got thick layer of smooth muscle. So thickest smooth muscle. To further protect it, you also have the thickest layer of stratified squamous epithelium here. Oops. So stratified squamous epithelium. That way you got many layers before you even get back to a smooth muscle. Then you need a strong basement membrane. And to make sure these cells stay here where I need them, Yeah, they got their own blood supply, vasovasorum. So let's look at this. Let's see, I need somebody new. Elizabeth Chalakis, you there?
Yes, sir.
All right, good. You flow with me for a second. So blood comes out at 200 miles an hour. Let's say you got 100 layers. That means it come out, hit the wall, scrape off one layer. That's why vasovasorum will replace it for you. Come out, scrape out another one, vasovasorum will replace it for you. You understand so far, Elizabeth?
Yes.
The problem is one day you'll be stricken with what we call atherosclerosis, which will attack smallest vessels first. That's vasovasorum. And all of a sudden you can't replace those layer cells anymore. That means, Elizabeth, you start losing your layers. 90, 80, 70, 60, 40, 30, 20, now you're down to 10. Now it's 9, 8, 7, 6, 5, 4, 3, 2, 1. And then here comes the next blood pumping. Boom! Blood hits the wall. Now it's all smooth muscle. And the air goes like, oh, thank you, man. I thought I was supposed to get my shot today and tomorrow. The allergies acting up. Excuse me. Thank you. Phew, thank you. Got the scratchy throat. All right, so blood comes out and suddenly hits the wall of your aorta, and now it's not a smooth muscle because all the cells are gone. And that's why you do that. That's how you get an aneurysm. That's how to remember why they'll say atherosclerosis is the #1 cause of aneurysm. #1. So for the aorta to last that long, folks, 60 years or longer, all right, notice we don't see aortic aneurysms until after age 60. That's because all this protection is there. What if something goes wrong? Look at that. What about collagen diseases? All of a sudden you get aneurysm earlier in life. Syphilis is eating at your aorta, aneurysm early in life. Takayasu is eating at your aortic arch, aneurysms early in life. AJ, because the heart can't pump at 200 miles an hour anymore. Aneurysms. Now you know how it happens. That all 4 protective mechanisms must be present at all times. Otherwise, your aorta won't last 60 years. Any questions at all? So #1, atherosclerosis is the #1 cause of aneurysms. Aneurysm, Helena, just mean ballooning out. That's dilation of a vessel. When you dilate like that, the walls become thinner and stretched out and therefore easy to break. Any questions on that? #1 cause of aneurysm, atherosclerosis. #1 cause of dissection is hypertension. Because what if that blood is pumping that day at high, high velocity? Gonna hit the side, pop. There it is. Now you dissect. So I'm going to take you through the 2 aneurysms, thoracic followed by abdominal aortic. Any questions first of all? Now let me just draw it. Boy, sinuses are draining like crazy today. All right, thoracic aneurysm. Most common cause, notice, still atherosclerosis, but I gave you the rest of it. Deceleration injury, car accidents. Let's say your car is going 60 miles an hour and you hit something head on. Well, you go towards the steering wheel at 60 miles an hour, hit the steering wheel, and then come back. As you're coming back, your aorta is still going forward at 60 miles an hour. That's why it just rips. That's why they tell you, anybody who has chest trauma in a car accident, they always say you got to do an X-ray and an EKG. You got to rule out dissection because that'll kill them the quickest, and rule out arrhythmias. Because if I hit your heart hard enough, you'll start a bunch of arrhythmias. This is how to manage trauma. Any chest trauma, you got to do an X-ray and an EKG automatic. So atherosclerosis #1, deceleration is #2, collagen disease #3. Now, if we draw the aortic arch, so I'm going to draw it like that. Oh, here we go. Like this. Your aortic arch goes around like that. The ascending aorta comes from the third Brinker arch. The turn comes from the fourth Brinker arch. The descending comes from the sixth Brinker arch. This is in case if they were making an embryo question. 3, 4, and 6 make up the aortic arch. The weakest layer or the weakest location in the aorta is where 4 meets 6. This is called an isthmus. That's where most tears occur. Most dissections occur at the weakest area. If you got collagen disease, most aneurysms start here at the bottom, at the beginning. That's called type A aneurysms. Descending aorta, type B aneurysms. So collagen disease causes mostly type A, and they tend to dissect backwards. That means downward. That's why they rip that aorta. The aortic valve, that's why they get aortic regurg and end up dying from dilated heart. See? Whereas atherosclerosis and deceleration tends to rip the isthmus. Any questions on that so far? Yes. Yeah. So why does chest trauma cause arrhythmias? Well, when you hit the chest, the heart hard enough, okay? Like you said, you smash a bunch of cells. Potassium is going to leak out. Hyperkalemia alone will cause arrhythmias. You can do it that way. Or blood vessels going to spasm when you hit it hard. And there's ischemia. Yeah. Either way, that's screening.
It's such a high velocity, you know what I mean? So like.
Is there a benefit to having high velocity in here, you mean?
No, high velocity, yes, but the fact that it's an arch, like the vessel.
Yeah, that to have the arch is a semicircle. A ball moves around a circle much faster. Let me give you for instance. Now, when you were a young girl, did mama ever get you a hula hoop? Every mama gets a hula hoop for the little girls. Why does mommy always get a hula hoop for a little girl? Because she wants you to get a little swing in those heads. Okay, she doesn't want to tell you that's what she's doing. So Karina says, Mommy, I don't want to do no hula hoop. Come on, Karina, try it. Okay. So she goes, winds up. Remember in a hula hoop, there's one marble. So you start and you hear, Mommy, I don't want no hula hoop. Come on, Karina, just try one more time. Okay. So then she gets a real good grip this time. How come this noise disappeared? Remember, it started out with the marble swinging around, and now it's moving so fast, it doesn't even touch the sides, you can't hear a thing. Folks, that's why your aortic arch is a semicircle, because that way it moves so fast, 200 miles an hour, it doesn't touch the sides at all. You believe it? That's why your aortic arch, you can last for 60 years. If it actually smacked aside, whatever, you would never last 60 years. It won't. Go around real fast. All right, so then when, you know, she's swinging around and there's mom is right behind, oh, Karina, oh, Karina, oh, Karina. Okay. Mommy, I'm tired. Okay. And since she stops, you hear, and Mama was in there the whole time. You just can't hear it. Okay. If the blood goes around here, remember RBCs are almost the shape of a marble. To go around so fast, that's going to create a suction in this aortic arch. That's the other benefit of the semicircle. If you have suction, what's it going to do? Suck things off that wall. Create a vacuum, right? When you go fast enough, you create a vacuum. Like when a car goes fast enough, piece of papers go flying. That's because it has a vacuum around it. Okay? So the key is to go around there fast enough so that you suction things off of there. What are you trying to suck off of there? When you eat a big old fat burger, pieces of cholesterol go flat right there on the wall. The RBC peel it right back off for you. That's called a Bernoulli effect. This is way back in physics. Anybody hate physics like I did? Man, physics back in college, you know how I think every medical student asks the question, oh, we gotta learn physics if we want to go to medical. Physics, man, but my hand. Yeah, I never understood it. It was the only class I ever flunked. All of college, one class I flunked, that was physics. I never could understand it. It was just so abstract, I could not understand it. There were so many fields, E fields, I fields, D fields. I didn't know if we were playing baseball because we're always going out to another field. Every chapter, here comes another field. I'm like, good Lord, what is this all about? You know, so I remember I studied real hard for my final, right? Final grade. And I get there, I studied all night, barely slept, showed up for the final exam, and she passed out the final exam. It was 2 questions, 2 hours. If you know about physics, you got to derive a whole lot of things and derive equations, calculate, then derive another one, calculate. 2 hours, 1 hour for each question. So I looked at the questions and I said, oh my God, it's the same 2 questions I did last night. Yeah. I started getting so excited. And then, you know, so I started hyperventilating. I think I'm gonna get out of here. Out of physics. I'm about to get out of physics. And then all that hyperventilation, yeah, curtain came up. Because I got so nervous. I couldn't remember a damn thing I did last night. And that was only a few hours ago because I didn't sleep. I did not remember anything I did last night. And I said, what am I gonna do now? And I said, okay, well, let me just try. So I did the first one. I said, okay, assume this, calculate this. I said, that's pretty good. Yeah, that looks familiar. And I said, okay, assume this one, calculate another one. I said, hey. And then I get to the third one, didn't figure out what to assume, what to calculate. I've only been in the test for 5 minutes. I got another hour, 55 minutes. That means I think I've forgotten a lot of things I gotta do. So I have no idea what I'm supposed to do next. And then after a while, I started crying. I said, well, I can't just sit here, cry all morning about this. So you know what I did? I said, I wrote a little letter on there and it said, since we're assuming so many things, just assume my answer is right. So I just wrote a letter on there and gave it to her. She said, hang on just a second. She wrote something on there and gave it back. You know what it said? Assume you'll be back here next semester. Yeah, that professor wanted that argument real quick. Oh man, I'll get you back next time. I've never been so happy to see a letter C on my report card. Hallelujah! I ain't gotta see this class ever again. Well, back then I didn't understand a lick of physics. I understand more physics now than I've ever understood. Why? Because I understand physiology first. Physics fits right into physiology, okay? So if anything moves fast enough, folks, it creates a vacuum around it. You know that? That was Bernoulli's effect, Bernoulli's law. Or you would call it. He was an Italian physicist. He says, if anything moves fast enough, it'll create a vacuum around it. That means anything close to that vacuum will be sucked into the vacuum. Well, Hoover read that and decided to make use of it. The Hoover vacuum cleaner was one of the first vacuum cleaners ever made. All they did was tie rubber bands to a brush and make it spin 3,000, 4,000 RPMs. By doing it so fast, there's vacuum underneath the vacuum cleaner. Guess what? Dirt from the carpet is moving into the vacuum. Ta-da! Bernoulli was correct. Bernoulli was correct. Did you know same thing happens when you're in a car? You know, when you're driving a car, how come when you pass along the shoulder, all of a sudden the leaves go flying out? Because they're trying to get sucked into your vacuum. What about a piece of paper on the road when you go over? Piece of paper go flying up in the air like that. That's because it got sucked into the vacuum underneath the car. There's a vacuum around the whole car. Guaranteed, man, guaranteed. All right, you want to learn how to fly? Here's how you do it. All you gotta do is hit 200 miles an hour. Did you know a car can fly at 200 miles an hour? It can fly. Let's see if I'm right. Now, there's regular car, and then there's race cars. If you go to the race car, the race course, right? Do you know there's a sign that says do not exceed 200 miles an hour? Gee, why did they pick 200 on it? Folks, the racers have spoilers in the front and the sides of their car. You know, that's why most of them pick the Trans Am, because Trans Am has the spoilers all the way around the car anyway. That's to keep your nose down. There's one place on the race course where you actually exceed 200 miles an hour. Is when you come out of a turn and G-force whips you forward like that. You're suddenly going 200 miles an hour or greater. If you watch the next Daytona or whatever race, okay, you'll notice the fastest guy is just under 200 miles. It was like 196, 198, 192, 191. They don't like to go above 200, you start flying. That's why when you come around the corner and you go above 200 miles an hour, ever wonder why all the crashes are right when you come out of a turn? That's because when a bunch of cars are doing more than 200 miles an hour, they start flying. Their tires not on the ground anymore. So they go slam into the other people and wipe out a bunch of people. That's why as a racer, you got to be careful when you come out of the turn because somebody else may wipe and take you right out. Now you're out of the race. Look at that. How about if you got a big old piece of metal called an airplane? And I was wondering, how the hell does an airplane fly? All you need is a strip of at least 10,000 feet. That plane, once it hits 200 miles an hour, it has a vacuum around it. If that plane is still on the ground, you can move the wings up and down. How come it doesn't fly? Because you haven't hit 200 miles an hour yet. what do you call it? You got to either take off. Okay, 200 miles an hour, all of a sudden you move the wing, how come you start taking off? That's because you got a vacuum on top, side, bottom, do whatever you want. That's why the wing can do whatever. You can go in any direction you want. Why? Because there's a vacuum all around that plane. Most planes are doing 300, 400, 500 miles an hour. Okay, and that's why there's a vacuum permanently all around that plane. Okay, what about when you get close to your airport? When you get close to your airport, why do you think the plane starts slowing down? When you start slowing down, you start to lose your vacuum. And then gravity starts pushing you down. That's why you're going down. What happens when you finally land on the ground? Since you land on the ground, why do you think they reverse the thrusters? You hear that? Take the velocity off the plane right away. Once you take the velocity off the plane, it can't fly anymore. Move the wings up and down all you want. It doesn't go anywhere. You gotta have at least 200 miles an hour to fly off the ground. Now you understand. So now I understand what the hell Bernoulli's law is all about. That's why you need an RBC to go around that turn at more than 200 miles an hour so that it cleans the air to garbage for you. That's what keeps cholesterol and lipids off that wall. But what happens when you get older and then you get atherosclerosis of your vasovagal arm? You can't replace everything. And that means now your muscle, heart atrophies. It can't pump at 200 miles an hour anymore. Why do you think you start getting atherosclerosis around the aortic arch? Basic physio. But they never explain this in medical school. They just tell you, oh, you get atherosclerotic plaques when you get old. No, there's physiology and physics behind it. Okay? When you cannot pump 200 miles an hour, that's when you start building up plaques. Because you don't have the cleaning effect anymore. It's gone. Any questions? Now, thoracic aneurysm. Two types, A and B. Type A aneurysms. How do you manage them? Number one, they always say control hypertension. Remember, hypertension causes dissection. So this is just a nice pictures of thoracic aneurysms and abdominal aortic aneurysms. So thoracic aneurysms, let's go through the presentation first. Ripping, tearing pain between your shoulder blades. Notice between the shoulder blades, that's up high. What do you see on X-ray? Wide mediastinum. Best test, spiral CT. Takes about 30 seconds. In the old days, we used to take them down to angiography suite. Then you have to wait for the interventional radiologist to come on down and do it. Takes more than 45 minutes, all of them with code right there on the table. That means you may save one or two of them. The rest of them would just die right there in the room, which was sad because we didn't know because it was taking so long. With spiral CT, shove you in, bring you right back up. 2,000 pictures have already been taken. And now it starts running back on the TV screen. Yeah, and you see, oh, there's a crack right there. There's a crack in the intima. Let's go. That means in less than 30 seconds, we're on our way to the operating room to do surgery on the guy. That's what saves their lives now. Okay, the spiral CT is done so quickly. Okay, that we don't need angiograms anymore. Okay. All right, type A is ascending order, A for ascending, easy to remember. What do you do? Control hypertension, because hypertension causes dissection and then do surgery. But look at type B, descending aorta. Treatment, control hypertension, surgery doesn't work. Somebody did a great retrospective study and found, didn't matter if you did surgery, 50% live, 50% die. If you didn't do surgery, 50% live, 50% die. So surgery makes no difference whatsoever. Now, the way I remember that is because the tissue behind the descending aorta, you don't have as much connective tissue as you do in the ascending. At least in the ascending, you got something to sew it onto. Descending, there's hardly anything to sew it onto. That's why it just rips again. And that's why surgery didn't make a difference. All right, because again, visual memory lasts a lifetime. I like to try to visualize whatever I can visualize. All right, any questions on thoracic aneurysms? What about abdominal aortic aneurysm? Again, atherosclerosis is the most common cause. Location below the renal arteries 90% of the time. Left kidney is most at risk. Why is that? Because the aorta is where the aneurysm is, and the left kidney is right next to the aorta. So when the balloon goes out like that, that's the aneurysm, it smashes the renal artery to the left kidney, that kidney's shot, gone. So it gets asked you which kidney will shut down first is always the left when you're talking about aneurysm. The one on the right is far away from the aneurysm, so that's why he's not bothered by it. The rule is, now this is called a Stanford system. We don't use, the old one was more than, less than 4, 4 to 6, and more than 6. All they do is just divide it in half, 5.5, 5.5, below or above, that's it. It makes it simpler for physicians to remember. If you're less than 5.5 centimeters in diameter, control hypertension, and then do an ultrasound every 6 to 12 months to follow it. But once it hits 5.5 or greater, control hypertension, plan for surgery. Do surgery. Any questions on it? Abdominal aortic aneurysm. Again, ripping, tearing pain, but now it's in your lower back. Pulsating abdominal mass. That's if the person is thin. You're not gonna see that in most people who are obese now. So that's why if somebody has a long smoking history, I think now they've got it down to, if anybody has smoked for at least 5 continuous years, at age 65, you do an ultrasound screening for AAA. Prevention, big study was done, and by screening people for it, they found a lot of them and did something before it ever became symptomatic or exploded. Any questions on that? All right, let me tell you about my first running with a AAA. All right, I was on call. This was a patient of one of my colleagues. He was a surgery resident. He was 2 years ahead of me, so he had already graduated and was one of his innings. And so here, me and my team were on call. All right, now this is for Dr. Shah. We're not a good crew to call, but hey, they had to call us. We're on call. All right, so what happened? I went to see the patient, examined it, got my history. I went down the hall to dictate it because we're taking the surgery in the morning. In the middle of my dictation, all of a sudden I hear blue alert, blue alert, blue alert, means somebody just coded. Then I heard the room and I said, damn, that's my patient. I dropped the phone, I go running down the hallway. Here comes the rest of my team, and we start CPR. Why do we start CPR? That's what it says, that's the protocol. It's the one time you're not supposed to do that. How come it doesn't say that in the ACLS, BLS? None of them. None of them say CPR unless it's a abdominal aortic aneurysm. You don't compress the chest. Does everybody understand? Every time you compress, blood just squirts out into that aneurysm. You're actually killing your patient with every compression. Thank God Fred knew better than we did, because we sure didn't know. We just followed orders. That's what every resident does, follow orders. And we're compressing, killing the patient every minute. And then Fred came down. He still had his gown on, mask on. I said, damn, how you doing, Fred? And he just pushed me out of the way. He said, get out of my way. And he took out the scalpel. I saw that gleam. I said, what are you doing? He took that knife. Just get out of my way. He took the knife, boom, caught one of the ribs and took the cut all the way back to his spinal cord without stopping. That is a damn surgeon. I've never seen a surgeon without cutting. You know, he just cracked the chest, grab the aorta with one hand like this, grab the person's heart with the other one, squeeze, let's go. That's what you're supposed to do. A AAA, that burst, if they decompensate, you have to crack open their chest. You don't do any compression whatsoever. Every compression will kill your patient. So you cut open the chest. That's why you cannot be afraid to cut. Please don't send me. Okay, because me and Sergio don't get along. I'll be right there. Nice. Somebody turn on the fan, man. Turn on the fan. All up in here. I can't do it. But Fred, like, I was like, Fred, you are the man. I did have with this one student, female student. She was a divorcee, or her husband died, I can't remember. But I think she was divorced, had 2 kids. Kids are grown and gone, right? So she's always had this dream being a doctor. I said, great. And then we were discussing this. And she said, oh, I love a man with a scalpel in his hand. And she said it with such desire like I've never seen. I said, damn, you're that attracted to a man with a scalpel in his hand? She loves surgery. So any surgeon with a scalpel in his hand turns around. And you can see it was like a bachelorette night or something. Boy, she had that look. Ooh, I love a man with a scalpel. I said, you sure you can handle this? Because she wanted to go into surgery. I said, do you understand? If you go into surgery, you'll have no personal life. I said, you may not see your kids ever again. I said, you definitely not gonna have a chance to meet another man. You're gonna be working your butts out. She said, no, I wanna have a scalpel. I said, okay, girl, go ahead. So anyway, so I have to pass her exams and she got surgery. So she got surgery and then she calls me less than a year later. She was almost crying on the phone. I said, Dr. I can't take it. I can't take it no more. I can't, they're gonna kill me. I said, didn't I tell you? I said, that's what surgery is like. And you know, and surgeons are the most chauvinistic men there are. You gotta be ready for that if you're a female. Okay, because as a resident, I saw so many female surgery residents just crying all the time. Crying all the time because the men were just abusing them. Folks, that's a field, unless you're tough, you ain't gonna be able to handle it. All right, but the one female I remember who could handle it, oh, she was tough skinned. I mean, she never showed any emotions whatsoever. They couldn't wear her down. I mean, she just did her job. She just, she just laid it down. Anytime I asked a question, boom, she just explained it, and they were, whoa, man. When you're sharp, they'll leave you alone. But the other ones were trying to be ladylike. Nobody knows ladylike around these men. You can be really tough. You gotta show tough skin, leather skin, whatever. Man, they were just abusing those little girls, and they were crying all the time. And I said, that's why I'm not gonna be a surgeon. Go ahead. You know, and then what happened one time, she got me in trouble. The one I was trying to protect her because she was always crying, so I was trying to help her out. So I thought she would help me out, right? So one time we were looking at an x-ray and it was about an ulcer. And I didn't know where the hell the ulcer was. So I said, well, maybe she would help me because she gets abused. Maybe she would have mercy on me, all right? Because I don't know what's going on. So I leaned over to her and said, hey, where's the ulcer at? Before the attendant asked me. And what'd she do? What? You don't know where the ulcer is at? What do you mean you don't know? Man, I was so embarrassed. And what happened? Now the attendant is just jumping me the rest of the afternoon. Because I didn't know what an ulcer was on a small bowel series. I was so mad at that girl. I said, I hope he abuses you again tomorrow. Man, I thought because you're being abused, you at least be sympathetic. That girl was not sympathetic. This is what I mean. They pass on that hazing crap. Because I got hazed, you got to get hazed too. I'm like, oh, Lord. Okay, that's why I can never be a surgeon. All right, but anyway, abdominal aortic, remember, aneurysm. Atherosclerosis is #1 cause. Hypertension is #1 cause of dissection. Okay, how you treat it? If you want to treat the hypertension, remember I already said labetalol is a preferred drug. Okay, we don't want the reflex tachycardia that comes with the nitrates. You gotta remember that. And I use nitroprusside for this. All right. After aneurysm repair, there's a problem that we run into. The surgeon has to clamp on them. You have to clamp both sides of the aneurysm because you're going to cut out this, right? Or at least open it up, take out the plaque, and then put another tube in there. While they're clamping, a lot of times they crack the atherosclerotic plaque. Now they don't know they've done it until they put everything in and then release the plaque. Pieces of that thing go flying. That's how you get atheroemboli. So after aneurysm repair, and you see a cold leg, that's a plaque that went, that's atheroemboli. Or all of a sudden the scrotum is discolored, they lost the scrotum. Or ischemic bowel, same thing. Or goes to any tissue, all right, to the kidney. I've seen that. Go to the kidney and all of a sudden just shuts down. Just shuts down because the plaques just go flying. The key piece of history, it's right after aneurysm surgery. Like the same day or the day after, all of a sudden plaques are flying, okay? In the kidney, you always see eosinophilia. Cholesterol plaques set off such allergies to the kidney. So you see this eosinophilia and eosinophil cast in the urine. All right, Adam, you had a question? Yeah, chasing the blood, yeah, that's what that is. Atheroemboli syndrome, very common after surgery, yes. You clamp? Yeah, remember you got an aneurysm right here in the middle. Okay. You clamp before and after while you're repairing it. That way you can cut this open, remove the plaque, put in the tube. Yeah, do whatever you gotta do. But while you're clamping it, a lot of times you accidentally crack the plaque. And then when you finally release the clamps, then a piece goes flying. Yeah, that's expected after surgery, so you got to watch out for that. Yes. Can you get anaphylaxis? It doesn't usually cause anaphylaxis, but it causes an allergic response in the kidney. That's why you get the eosinophil, and the kidney can shut down from it. Yeah, so plenty of fluids, plenty of fluids. All right, after aneurysm repair, watch out for that. Now, as a vessel narrows, velocity increases, flow decreases, resistance rises, blood pressure rises. Gustavo, all that sound okay to you? All right, Amy, all that sound okay to you? All right. Vessel narrowing. So if you take a vessel, let's say aorta, and empty it into a small artery, does everybody understand there's going to be a traffic jam right here? That makes sense to everybody? You take your femoral artery, empty it into another artery that's smaller, traffic jam right here. Every time you empty into a small artery, does everybody understand there's gonna be a traffic jam? Always. Everybody understand that? That makes sense to everybody, right? All right, let's say you're driving to Chicago, all right? And you got 4-lane highway. All of a sudden there's a traffic jam. You're like, what the heck happened? Was there an accident, a fire? What happened? Nope. They're doing construction on one and close off 1 lane. Now you're down to 3 lane. See that? There's a traffic jam right before the 3 lanes. When you get to 3 lanes, you speed up. Now you think, no problem. I'll get there on time. I'm okay. Oh, traffic jam again. Like, what happened? A fire? Somebody died? Car accident? Nope. They're doing construction. They close off another lane on you. All of a sudden, 3 lanes, 2 lanes. That's why there's a traffic jam right before the 2 lanes. And when you get in 2 lanes, speed up again. So that's what happens. This is called resistance in series. That's why it leads to road rage, Austin. Road rage, because you're adding it up. And the first one, you were calm. Second one, you start getting a little upset. Next one, you start cussing. Third one, you're honking and then putting a finger out the window at everybody. Okay. That's road rage, man. That's why we get more and more mad when they're stuck in traffic. Okay? That's why they always say, bring your patience with you. You gotta have patience. All right? Because when you're going to Chicago or any large city, you never know when construction is gonna break out. They don't send you a memo. Construction, that is. What used to be a 10-minute drive now is a 2-hour drive. I mean, one time it took me 5 hours to go from Chicago to Bloomington. Normally less than 2 hours, I'm home. 5 hours. That's how long it took. You cannot predict how many traffic jams you're gonna run into. Yeah, so anyway, that's all you can do. So resistance in series is what I described. Everybody understand that? That's one small vessel, that's one vessel, empty into a smaller one, empty a smaller one, smaller one, smaller one. That's not good. Because every time you put another narrow vessel, does everybody understand, you raise your resistance because you're adding it. You understand, Armando? You understand, Cesar? You're adding it. So what does your body do? Put it in parallel. Look at this. Parallel. Every organ is in parallel with your heart. By putting in parallel, Akshay, now it's 1/R total. That means when you add vessels, you're adding to the denominator. What's happening to your resistance? It's going down. See that? And when you subtract the vessel, what happens to your resistance? It's going up. Everybody see that for themselves. So how are you doing that? Your aorta, one vessel, empties into an artery. There's 100 of those. Empties into another small artery, thousands of those. Empties into more arteries and capillaries. By the time you get the capillaries, there's millions of them. So you're taking what used to go into one vessel and spreading it out to 10, then 100, and 1,000, and 1,000,000. Everybody follow? You're diffusing the resistance. That's why total resistance is dropping every inch of the way. You understand now, Amy? You understand, Reed? You understand, Solange? All right. So your heart is the central pump. Every tissue is in parallel with that heart. You understand, Armando? Here comes some questions for you now. What if you add one vessel to the circuit, to the parallel circuit? What happens to total resistance? Goes down. You add 10 vessels, what happens to total resistance? Goes down. You add 100 vessels, what happens to total resistance? Goes down. What if I had 1,000,000 vessels, but I rename it into a placenta and ask you why the blood pressure of a pregnant is so low. Woo, look at that. This is how they apply it on OB, and you swear it's some new question. That's exactly what the test writer is hoping, that you don't see. It's the same damn question again. With a pregnant woman in it, it sounds like it's OB. Oh, it should be on step 2. No, it's step 1. It's physiology. That's why a pregnant woman has low blood pressure. That's why. I know.
Based on that premise, what would the
When a morbidly obese person decides to lose weight, until their body readjusts, yes, their blood pressure will go up slightly. Right, because all the vessels they had, the heart will still be pumping all those vessels until the body takes it down. The body doesn't take it down in one day. All right, so let's say I amputate one foot. What would happen to your blood pressure? It would increase because I just eliminated a bunch of capillaries that was in that foot. So they'll ask you, how come blood pressure goes up after a transplant? You just took my kidney that was in parallel with my heart and you just gave it to somebody else. That means you subtract a bunch of capillaries from me. There's so many ways to make it clinical. I'll ask you guys the same question. And that's the genius of test writing. They know how to make it sound like it's a whole new story so that you think, no, it's going to be a new answer. You don't realize it's the same answer as before. All right? Yes.
follow on that,
Somebody gets liposuction.
next day, they could have.
No, they're not going to have hypertensive crisis. Their blood pressure will go up slightly. Yeah, you're just assuming they're going to go way to the roof. No, it's going to go up slightly, but your body will readjust and bring it back down again. Yeah. But it's normal that anytime you remove any tissue, any organ from somebody, as you understand, total peripheral resistance will go up automatically. I don't care what it is we're removing, it will go up. You understand, Mitchell? What if I subtract a vessel from the circuit? Increase. Everybody understand that? What if I subtract 100 vessels? Increase more, 1,000 vessels. Increase more. What if I subtract 1,000,000 vessels, but I call it a placenta and ask you why, when the placenta separates after you deliver a baby, you get preeclampsia? See that? That's how the test writer hides it from you. You guys think he's asking a new question. Postpartum preeclampsia. What the heck is that? Exactly what I just explained to you right now. You just removed 1,000,000 capillaries that were parallel with the heart. The minute those capillaries separate, mom's resistance goes up. Chris, if mom told her first resistance goes up, her body says, I can't handle this, man. I'm not ready for this. Oh my God. What organs are we sacrifice first? Kidneys. Now you got hypertension along with proteinuria and hematuria, and we call it postpartum preeclampsia. Oh, but wait a minute. The body says, okay, I don't think I can take this. I gotta adjust. But wait a minute, who's gonna be sacrificed second? All right. All of a sudden she's having arrhythmias. Oh my God, who's gonna be sacrificed last? The brain. And then boom, she lost her pituitary. The radial she has was the same thing I just said. Look at that. Guess why the postpartum hemorrhage is number one cause of death after you deliver babies in America? Because so many doctors didn't understand that this is a risky period. Although a female is hypercoagulable throughout pregnancy and cardiovascular risk exists throughout pregnancy, the highest risk is after you deliver the placenta. Doctors were not ready. So by the time they call the pharmacy, mix up some hydralazine, mix up some labetalol, bring it down in a bag, mom's dead. Mom is dead. You know, America has one of the highest maternal mortality rates in America. I mean, in the world, not in America, the world. And that's what's a shame. Because the physician doesn't understand what's going on. So what they do to address this, folks, they now have hydralazine in the delivery room. See, now it's protocol. Watch what happens. 5 years from now, nobody knows what is hydralazine in the room now. It's just gonna be, oh, we always do that up here. That's what I hate, is when everything becomes protocolized and then residents are just led to believe, well, that's just always happens. And they forgot how it even happened that somebody said, why don't we just put hydralazine in the room? That way, the OB doesn't have to call the pharmacy and say, mix up labetalol or hydralazine. It's right there. Just hook it up to IV and get that blood pressure down. One case in point, I had a young lady I was working with in the Peds ICU. Remember, her name was Diane. Beautiful girl, just got married, you know, brand new marriage, and she was pregnant, but she was pregnant with twins. That's 2 placentas. So this girl was a runner though. You know, so she was running all the time. We were like, man, Diane, you know, run on with you, deliver that baby. That was just her habit. Remember, if you normally do some activity, but you don't do the same activity because your body's used to it. That means her abdomen was nice and tight. The baby doesn't feel the trauma. Well, she went in to deliver the baby. I remember seeing her the day before she was supposed to go. The next day I come to Pete's ICU, everybody's looking real sad. And I was like, what was everybody so sad right here for? And one nurse said, well, you didn't hear what? She said, well, Diane just died. That is one of the weirdest feelings when you're talking to somebody like this, and the next day they're dead. They're gone. Well, Diane had twins, 2 placentas. That's 2 million capillaries. I got subtracted. Well, before the surgeon, the OB-GYN could call the pharmacy, mix some hydrolysine, mix some labetalol, bring it down to me. Man, she dissected from the arch of the aorta all the way down to iliac artery and exploded into a pelvis. Died within seconds. See, it was many stories like that they now have hydrolysine in the room. Because you only got seconds, you got to plug that in, get a medication in the system right away. Because she started dissecting right away. That aorta was just ripped. And she gave up her life for her twin children. You're so sad. She was, man, just a beautiful couple. Anyway, but just so you understand, but that ain't the worst case. The worst case is a woman called Octomom, where somebody implanted 8 placentas into that woman. And nobody would have found out about it, except she was making her circuits from TV station to TV station, making money, right? And then she would, of course, tell what happened. And when American College of Obstetrics and Gynecology, ACOG, I know, what the hell do you mean, 8 implantations? They said, oh, wait a minute. The ACOG limit was only 3. You're not supposed to do more than 3. That's already dangerous enough, but 8? They brought that man before ACOG, and they said, why would you do 8 implantations when 2 and 3 are already dangerous enough? You're gonna do 8 implantations in this woman. Did you understand the danger you put her in? His explanation, well, other guys do it too. Well, now you know he was right? Other guys did it. But today, you're the one who got busted. Guess what? Your career's over. Took his license and said, no, you're not doing it anymore. That was it. See? You and I know a lot of guys stopped doing it right after that. Because when they heard what happened to him, they thought it was okay to be doing a bunch of implantations. Now realizing every placenta puts that mom at risk. 1 placenta is enough. 2, 3 is way too much, but they say, okay, no more than 3, triplets. But man, once you go beyond that, she was lucky to live through that pregnancy. Very lucky. She had no idea what risk she was facing. And neither did OB-GYN either, the guy who did it. He had no clue how dangerous it was to put her at that risk. That's why they said, okay, you're not practicing anymore OB-GYN. Give us your license. Get out of here. That was it. Anyway, it's sad, folks. It's sad. Anyway, but I want you guys to see the big picture. Then I'll leave you with this. This is why they say take the treatment of hypertension very seriously. Does everybody understand? If you don't treat my hypertension well enough, every time I blow up a blood vessel, everybody understand? You just remove the capillary out of parallel. What happens to resistance? Every time you subtract the vessel. Is what? You subtract from the denominator. So the denominator is going to be smaller. That means the numbers increase. Oh, I thought you said decrease. Okay. Yeah. So every time, if you don't treat somebody's hypertension quickly enough, or you don't treat their cholesterol quickly enough, you see that? They're losing capillaries. They're getting clogged up or popping because of hypertension. That's why it keeps going up and up and up and up. How do you know that? They call it resistant hypertension. It means you need more than 2 drugs to try to get under control. But definitely once you get to more than 4, that's how you know that thing's been out of control for years. Okay? That's why we try to screen and catch things early. Because if you catch it early, all you need is 1 drug or half a pill of 1 drug, get under control right away. But if you wait a bunch of years, when all this has happened, blood vessels have popped, they're no good. The one I see on the test right now, let's go, Abigail, and on a high. This is yours, girl. There's only 2 minutes left in the day. All right? This is the one I've seen several times on Euro. You got a baby newborn, right? And once his PDA closes after he takes a few breaths, what happens to his total peripheral resistance? It's going to increase. That's all they want to know. And they ask you about what happens to his TPR before he was born, because remember, the PDA is open. So after he was born, take a breath, PDA closes. TPR goes up. That's why is left-sided pressure becomes higher than right-sided pressure. Just by remembering that, move the vessel. So there's so many examples, folks, but parallel and series. You want to know the difference. Notice it's 1 over our total for parallel. So every time you add vessels, boom, that's helping keep your blood pressure down. That's why, like an obese person, Adam, the bigger you get, the more blood vessels your body grows. To keep up with that, that's why your blood pressure stays under control. And so you think obesity does not cause hypertension. Yes, it will, because your body one day can't build any more blood vessels. Now you get hypertension. Now you get hypertension because your body can't take it. Okay? That's why we say don't push your body to that limit, because it eventually will. Yes, sir.
So reinforcement rates, that's probably much higher, quicker.
Reinfarction rates. Did you talk reinfarction rate in the heart? Is that what you're talking about?
Yeah.
Oh, heck yeah.
In diastolic heart failure.
In diastolic heart failure, remember, too much hypertrophy. That means too much contraction around the coronary arteries. Of course, you have more infarcts, yes.
So then, if there's ischemia in part of the heart, wouldn't your afterflow even increase?
If there's ischemia in any part of the heart or any part of your body, afterload will start to increase. Yeah. That's why we try to treat things as early as possible. That's why we use vasodilators. Why do you think we use nitrates? You got to get the resistance down. Otherwise, resistance will keep going up and you're going to blow more blood vessels. Resistance goes up some more, hypertension will go up and it eventually kill the patient. Okay? All right, I think this is a good place to stop. Yeah, so we'll take it from here in the morning. Okay. Oh no, tomorrow all day is Dr. Chaco. He's doing renal. Then I come back in on Wednesday morning. But I'll still be here for morning questions. So see you in the morning. Any questions from anybody online before I click off? You doing okay, Lashiba?
Yeah, I'm okay.
Okay, girl, hang in there.
Thank you.
One day at a time. Just keep studying the notes one day at a time. Don't try to go too far ahead or behind. All right, it's
Okay.
doable when you do one day versus too many things. All right, Bryce, you had a question?
Yes, what's the cause of the pseudoaneurysm?
What is the cause of what?
Pseudoaneurysm.
Pseudoaneurysm? Is that what we said?
Yes. Yes.
A pseudoaneurysm means it looks like an aneurysm, but it's because you tore a part of the wall. Like when we do a cardiac cath in your thigh, the guide wire we use can accidentally tear some of your femoral artery and cause ballooning of just part of the wall. That's why they call it pseudoaneurysm, because it's not a complete aneurysm.
Okay. Thank you.
And that's usually caused by trauma.
Oh, thank you.
All right, no problem. You understand, Amara Chaudhry? You good? Hanging in there? Okay, end of the day. All right, we'll see you guys tomorrow. See you in the morning.